place to the hospital that I saw, which is the picture that you can see in the top of this piece. But also, while I was here, I did eat lapa and I did drink Black Creek water as I went upriver into Essequibo. And there's a very old phrase, and we were told it many times, if you did both those things, you would come back. So I'm very delighted to return. But one of the things that I would also say about being here in Guyana was that it shaped how I think about infectious diseases. It was probably my first big experience of tropical infectious diseases, and it has lived with me forever. It's taught me a lot about inequalities and inequity in delivery of healthcare. I spent time upriver working with the Amerindian communities, thinking about their healthcare delivery. And I was really delighted and pleased to see about the telehealth. Because back then, more than 30 years ago, I would go upriver with some colleagues, and we would travel for a day and a half to get to the community. We would spend a day or a day and a half there. We would determine if there were any people who needed to come back with us to the hospital for treatment, predominantly for things like chronic malaria or cutaneous leishmaniasis. And then we would offer them minimal health care, basically whatever medications we had in our bag on that day. So we couldn't make assessments before we went. So we just guessed what we might need as we went there. But it also reminds me that public health is just not an abstract term. It is deeply rooted in place, in people, and in lived experience. So while I may talk today about things like genomics and artificial intelligence and surveillance platforms, it really only matters if it reflects what is happening on the ground and how that's going to make a difference to the health of the people there. And while I'll focus predominantly on infectious diseases, we require a multi-hazard approach in thinking about how we deal with these things, biological, environmental, and whilst technology moves forward, one of the challenges that I can see in the future when we're moving rapidly is how do we deal with pollutants? How do we deal with air pollution? How can you reduce the impact of cardiovascular disease through accurate treatment? So to, being able to do that vision that we heard yesterday evening, if you were there, by North Wall, about being able to call an ambulance, being able to get to the hospital. But then we're increasing the risk of cardiovascular disease and respiratory disease by cars on the road, by the dust that's around us, by particulate matter. So we need to hold those tensions. And as somebody who sort of was born and bred in clinical practice and in hospitals, it is very easy to focus on the hospital practice and very easy to disconnect about the important primary public health interventions that we can do to actually improve health. So we don't need as many hospitals and we don't need as much hospital care. So again, thinking about that as we go forward. We heard also yesterday about that here in Guyana, they're below seawater. We need to think about what the meteorological and hydrological impact of flooding and of climate change are going to be on this sector. It's not going to be similar as other parts of the world, and it may have increased challenges about how it thinks about what it's going to do with its waterways, as well as for it to reduce the impact on health. But in focusing on infectious diseases, one of the reasons I love it is that it's so complex. One of the reasons I love it is that you need a lot of different data sets to understand it. And you will also need to think that none of those data sets are perfect. Infectious diseases are challenged by the pathogen itself, the human host complexity and immunity, the age of the population, their underlying health status, the environmental factors, humidity, altitude, climate and ecological change, and many, many, many more things. And the other important things about infectious diseases is that it isn't just about what happens to you personally. So cardiovascular disease, for example, you treat the individual, they treat their cholesterol, you treat their secondary risk factors or primary risk factors, and you can reduce cardiovascular disease. Infectious diseases is much more about how humans interact and how humans interact with each other. And we saw that during COVID. In COVID, many other infectious diseases disappeared or almost disappeared as well, because the human interaction is so important in the transmission of infectious diseases. And our social and behavioral patterns is equally as important as everything else. And you need to understand all of these pieces of the jigsaw to ensure that you're actually able to intervene in the correct way. So as I've tried to talk about, public health works across multiple levels at once. For an individual, it's the infection as the clinical problem and the response to that infection that matters. For a cluster, it becomes a public health problem. So how do you manage that? How do you reduce spread? What does that mean? And when it's a trend, when we're looking at it over time, it becomes a system problem. How do we have the healthcare system that delivers for everything that we need? How can we use the education system to deliver vaccines in the most equitable way possible? How can we work with the transport system to make sure that people can get where they need and that the delivery of cold chain, etc., allows for vaccines to be delivered to remote communities? The best surveillance really connects at all of those levels, thinking about how the individual experience aggregate into population risk, how those population signals feed back to clinical decisions and to population interventions. And too often, systems are built up one level, and data is collected alongside that system rather than integrated in that system. And so this becomes a structural weakness, because every time you want to collect a new piece of information, you develop another siloed surveillance system alongside it. And each of those siloed surveillance systems means that you still only see part of the picture. So just coming here to this pictorial representation of an individual care journey, if you like, in an infection pathway. So infections are acquired, there's an incubation period. Some people will never go on to develop symptoms and remain asymptomatic. Some of those asymptomatic people will transmit to others. Others will develop some symptoms that they may go to the pharmacy and take some antibiotics if they are available over the counter, or some paracetamol to make themselves feel better and reduce their fever. But vast majority of those syndromes are not captured by any surveillance system. So what are the ways we can think about capturing those? Are often by doing surveys of people and population. So for example, you can ask people, have you had mild symptoms? You can look at pharmacy records about how many over-the-counter drugs they've been given, and that can give you a marker about what diseases might be going on in the community. However, really, when people start to develop symptoms that are more severe, the first place they usually goes to the GP or primary care service. And again, there's very little surveillance in a primary care service. We heard yesterday about indicator surveillance that's available there. But that means that we're collecting information along a secondary route alongside primary care doing their primary intervention. So again, once we're thinking about healthcare strengthening and thinking about the digitalization of healthcare, one of the things that I would say is quite important is how can we think through that if we're digitizing primary healthcare across the world, how can we collect the data directly from that primary healthcare system into federated platforms that we can then use to interrogate those data systems and look for signals earlier than we might otherwise do? In the UK, for example, we collect data from all general practices across the country, and we look for indicator conditions that they might, for example, write down as flu, but equally conditions they might write down as fever and cough, fever and rash, and we use their primary systems to collect that data. There's a secondary data system which can ask them to contact us for notifiable diseases that we know transfer very fast, such as measles. But for a lot of the sort of commoner conditions, we ask them just to document it in their system, and we collect it from that. Equally, when I heard yesterday about collecting that they tried to set up numbers for ambulances that you can direct to hospital, how are those ambulances going to record their data? We, again, try and record all of the 111 and 999 calls, which are essentially our telephony healthcare system model, where people can seek healthcare advice online, digitally, by telephony, and where ambulances can be called. And that gives us a secondary signal. We often focus on laboratories as the primary focus for infectious diseases. But if we do that, we're actually looking at the tip of the iceberg. And I mean that in the sense that the vast majority of people who get an infectious disease never seek healthcare. Some of them go to primary care. They rarely get samples. The vast majority who go to hospital will not get an infectious diseases sampling, or may get one test, but not many. And it's really only those people with more severe illness that go on to receive a microbiological test. But at the moment, the vast majority of places in the world use that as a very big signal of whether we've got a problem or not. And of course, a lot of the tests that we do test for one thing. So we test for one thing, such as COVID-19, or we test for measles, but we actually don't know what's wrong with them and what's sitting there in the background. The future, I think, looks quite different. So in the, as the test price comes down, a bit like PCR tests that we use quite readily and widely now come down, one of the things that we'll be doing in the future is something called metagenomic sequencing, where rather than taking a sample and deciding as the clinician what we're going to test for, we'll take a sample and the laboratory will run an assay and we'll look for the DNA of whatever is present and then decide through artificial intelligence and machine learning about what that looks like in the future. And that will allow us to basically be scanning for the unknowns as well as the knowns. And that will change how we look and develop new components of care. So looking at this, what I'm going to highlight just in the next bit of the talk is the community surveillance and how that helps us integrate signals, hospital surveillance, a little bit of that, and then two of the more forward-leaning things, such as wastewater and metagenomic surveillance. Excuse me. This is our example of real-time syndromic surveillance. So in real time, we get an overnight feed every night from the GP practice databases, from emergency department databases, from our NHS 111 system, and from our laboratories across the country through an integrated interface that allows us to just pull in that data. We run automated statistical analysis algorithms on that, and that produces a daily signal, allowing us to determine what types of diseases are happening across the country. I'll give you a couple of examples of how that's worked. So for flu, we do this on a daily basis, and we routinely bring it into our forecasting, which I'll show you in a second. But it actually allows us to be able to tell what days of the week there's going to be more of an impact on the emergency care departments. It allows us to say which part of the country is experiencing flu. It allows us to determine what resources in different parts of the health system go where at each time. And one of the critical things it does for public health interventions, it allows us to determine when we should ask prescribers to start routinely prescribing antivirals for individuals who present with flu-like illness. So we don't wait till we've got tests in primary care if they're over 65 underlying medical conditions. Once they hit a certain threshold of flu circulating in the community used by these daily tests, we then automatically ask people to start prescribing in order to reduce the impact on hospital care for those people. Here's an example of where in post-pandemic, we had a new syndrome that was causing severe hepatitis in young children. It was caused by a combination of adenovirus and adeno-associated virus being infected to children at the same time because they had not been infected over a previous couple of years. And that caused an acute severe hepatitis requiring individuals to be admitted to hospital. We didn't have a surveillance system set up for this in advance, but we were rapidly able to adapt this surveillance system in order to be able to do that. So defining this through the emergency department and through looking at it just because we collected all of the data and can then decide which bits we look at. I would highlight, and I think it's really important to highlight that actually, as with the vast majority of rare things, clinicians suspecting and reporting is still one of the most important critical components. So educating all of our clinicians across all countries to say, if you see two things that look unusual, if they look unusual to you, they probably are, call a number, is one of the most important parts of sentinel surveillance we can have anywhere in the world. It happened for COVID-19. It happens for things like Mpox. When we saw Mpox, it was clinicians from different hospitals reporting to a central place going, we've got these funny rashes and we can't diagnose them. And that sort of clinician suspecting, going to a single number, really allows you to bring intelligence together in an effective way. Breaking the system. Anyway, we'll try and see if this, oh, there we go. Okay, so one of the things that we do is operational short-term forecasting. So over the winter period, we use all of this data coming in to allow us to determine on a forward look 14-day period what the impacts on the healthcare system are going to be, whereabouts in the country those healthcare system impacts are. And you can see this is an example of our forecast over the course of winter, where we've overlaid the sort of 2 weekly forecasts on top of each other. And what this allows us to do is basically say to the emergency departments, actually flu's come early, COVID's coming now, you need to actually get ready for a surge of patients. You need to start reducing your elective hospital beds in order to have more emergency beds for these people. And we use this really effectively by having sharing this data with all of our healthcare systems, so with our hospitals, with our primary care providers, so that they're ready and activated. So once we see something on its way up, then we look at this in a really important way. I will highlight that in the world of artificial intelligence and machine learning, we keep putting artificial intelligence and machine learning against our routine statistical models, and routine statistical models still keep winning. Now, I'm sure that will change, but it's just something to keep reminding everyone that we still need the routine stuff. And what we use here is a combination of multiple different statistical models that we merge. But that is still more effective than using artificial intelligence at this moment in time. So where people have the holy grail of AI, we still need good statisticians, good modelers, and good people to be able to do that. I'm going to just move on to the next bit, which is a little bit on environmental surveillance. And by that, really, I mean things like wastewater. And I don't know how many sites across the Caribbean and for other countries that are here used wastewater in the pandemic. It became a hot topic, and a lot of money was spent on it. And at that time, we were also doing a lot of other testing, more testing than we had ever done for any other infectious diseases globally. And it really helped us understand that wastewater could give us a signal. But I think the jury's still out about whether it's going to outperform traditional other modes of surveillance. The one thing that I think it's extremely useful and important for is where you don't have any of something in a country, and then you find any signal in wastewater, and you know it's a problem. And so for one of the big examples that we're using it for currently across the UK is poliovirus surveillance. So we've eliminated polio, but we know that we have pockets of the community who are under-vaccinated, and therefore we know that we have a risk of polio coming in. And actually the main type of polio that we see coming in is a vaccine-derived poliovirus from oral polio vaccine campaigns across the world, where it can modify and mutate. But that modification and mutation that can then therefore transmit to others. And here we could, test vast amounts of people with GI illness across the country for poliovirus, or we can just test wastewater. And this makes a valuable area and contribution. And for us, it has detected on at least 3 occasions now poliovirus in our wastewater. We have known where that wastewater has been, and we have gone out with a community polio vaccine campaign to make sure people are up to date. And it gives them both a sort of hazard or jeopardy by telling them you've got polio in your community, and then a response such as a vaccine. And I know, for example, that the US has used that for measles. Sadly, we've got too many measles cases across the country at the moment in the UK to use that effectively. But we are looking at it in many other areas. And so we currently have a coverage of our wastewater sampling for polio for 35 million people, mainly in the urban centres, so less so in our rural areas. And we have a list of emerging diseases which we have either very little or none of, and a list of endemic diseases which ideally we are trying to eliminate. And once they get low enough, we'll be able to test them. So we have now expanded our wastewater surveillance program to look at this variety of areas. And the advantage of this as well is that if we have a new and emerging infection anywhere in the world, we can add this rapidly to the program. Because one of the big challenges with wastewater isn't so much the testing at the end, it's actually the going out and collecting the samples, arranging with the water companies, figuring out how best to do it. Moving on to metagenomics, and to metagenomics, I think, has a broad use in pathogen surveillance for the future. It will allow us to have a much more pathogen agnostic detection methodology. So it's not about what we know, but it's about what we don't know. It will allow us to characterize straight from a sample, rather than at the moment, for example, even if you have got TB testing that's being done molecular, it can take many, many, many weeks from that TB test to really return a molecular result. And in the future, and in not very far future, those CEPHID PCR machines you might have in some of your labs from COVID will be transformed into CEPHID metagenomic machines, because Oxford Nanopore and CEPHID have now created a partnership to create a black box for this technology. And that's really going to be able to transform this technology being in laboratories without requiring a whole load of expertise. And that's where really machine learning and artificial intelligence are going to become important, because those machines are going to have that artificial intelligence built into them in order to be able to determine what the pathogen is. And that will allow us to have more efficient surveillance. For some reason it's jumping. In the UK, one of the things we've done is we've tried to create a surveillance platform for metagenomics. So we're not doing all of the metagenomics in our agency, but what we're doing is creating a platform that anyone who is doing metagenomics can submit that data to us. That does two things. It allows us to help them validate the results that they're getting. It also allows us to find things that might not be otherwise found. It allows us to look for the really rare diseases that might not be sitting in the pipelines and automated approaches at the moment. And it also allows us as the national agency to start assessing and characterizing the pathogens to understand what countermeasures may work. So it's really important from a surveillance system where we basically, before it's even in routine practice, we are now thinking about what might the surveillance system might we need for the country in 5 years' time, and how can we start to pilot that now so that we're ready for those changes when it occurs. And that will only work if we're able to link that pathogen sample to the surveillance of the system that we've talked about already. So the core surveillance, event-based surveillance, the core surveillance from the hospital systems and the primary care systems. It will only work if we're able to demonstrate it's got health economic value. And that will be really challenging if we're not able to do that well. It will only work if we talk to the public about it, so to ensure that we've got the ethics, the privacy, and the public acceptability. And it will only work if we've got the partnerships with industry, academia, and others to allow us to go forward. And that means that when we're thinking about these systems, we need to think about how we handle data ethically from the start, whether that's individual-based, whether that's pseudonymized, how can you relink it for public health purpose. So I was just going to finish really by saying, at the moment, AI in all of this is about optimization. It is not going to change your primary healthcare surveillance. It's not going to change your secondary healthcare surveillance, but it will allow us to potentially connect data sets easier and faster than we can do right now. It will allow us to translate and move from one system to the other. And it will allow us, as we go forward, to be able to think through how we can integrate systems across countries in a better way, in a better frameworks than we have now. For me, the very last thing I would just like to say is that surveillance is not just about data. It's about the judgments and the decisions that data enables. So no matter how far we go in the world of artificial intelligence, it will need still a human-centered individual to think about what the decision is going to be and how that decision is going to impact on the populations that we serve. It is about the integration of the surveillance that we can do, the information that we can collect from those systems, the interventions that we can deliver to improve the health of the population. And none of this will work unless we start thinking now about the trust, the partnerships that we have to have in country, across countries, and globally. Because if we work in a world where we all look inward rather than outward, we won't protect the population across the world. And that will mean that we will be less protected together overall too. Thank you.
Ladies and gentlemen, want to thank Professor Hopkins for that elegant presentation. She's taken us through a systems approach to health security, using good examples from the UK scene, pathways for understanding infections care, forecasting environmental surveillance using novel techniques, including metagenomics, and understanding that there's a living lab concept to this with industry, academia, and community, which allows integration of all of these pathways. So thank you very much for that. I would like to give the community an opportunity to ask questions if they may, if that's okay. I do have a question to ask, but I will let the community ask first. So please turn your mics on and ask question. We will then move on to the next session once we're through. Any questions? Oh, yes, please go ahead, because I'm not able to see you directly.
I had a question about the wastewater monitoring. So all wastewater goes into central sewers, so it gets collected centrally. So unless your monitoring system is very kind of spread out, how do you kind of get the granularity? So if you detect something, is it a case of sending teams out to then try and trace it to the source? Because obviously it's impossible to have high level of coverage at a really local level.
Yeah, and that's why I think it's useful for detecting rarer pathogens rather than common pathogens, because common pathogens just gives you a signal. But I personally don't see that it's hugely better than our enhancing our patient level systems at the moment. For rare things, yes, if you detect anything, then you can use that as within that population of 1 million or 2 million, whatever that sewage system that you've tested covers. You can then go back upstream and test it further upstream, which is how we do it at the moment in polio. So we're actually able to break it down to populations of 50,000 by going right upstream. But we only do that when we detect it. We don't do it on a weekly basis. And that allows us to have the efficiencies of scale in looking at populations of a couple of million at each point, and then going into granular detail, which will be then able to deliver an intervention in, so smaller population.
Thank you. Any further questions? If I may ask, I'm not seeing a red light on. Yeah. Okay.
I wanted to ask about the nanopore, the next generation of nanopore machines. One of the problems has been that for LMICs, it's very hard to get the reagents. They're expensive. It's hard to get the machine serviced. There's a sort of disconnect between what's available in the global north and the global south. Do you know if there are specific plans to ensure that there's going to be availability of those machines in the global south?
So Oxford Nanopore is a fantastic company, and it does mainly works for research at the moment. But its new partnership with CEFID, that's now gone into stage 2, is really going to be able to move it into thinking through how you can create it as a much more black box technology, so that the reagents, et cetera, can come to it in a much more reasonable way. And I know that many of the laboratories around this system use things like CEFID at the moment. So you can see how CEFID will be able to think through that much better than Oxford Nanopore. And so I think that partnership will allow it to be amplified and actually deliverable at scale in a way that we couldn't do it before. And so for me, this is why I believe metagenomics is on a turning point, because up till now, it required a lot of technical expertise, required quite a challenge in getting the reagents, and we're actually about to move that forward. And I think it will transform surveillance for pathogens.
May I ask, given that some of the concerns related to infectious diseases across the region remains high level, what would you suggest a first step for the low resource setting Caribbean communities? What first step would you suggest to get on the health security pathway? Thanks.
Yeah, so I think I heard fantastic developments that were happening yesterday in some of the afternoon sessions. And I heard the great vision from the president of Guyana yesterday. I think the thing I would start by saying is that what I'm trying to say is that you need to think about your surveillance needs as you're building the health system strengthening. So if you do that alongside together and you're thinking about what is the digitalization, you're talking a lot about telehealth. Well, if you're doing telehealth, how are you recording that information that was happening on telehealth? Because if you're doing that, you're actually building your surveillance system integrated into your clinical system. And that will allow you to be able to develop the surveillance robustly for not just infectious diseases, but for everything else. And so I think what I'm trying to say is that's where you want to get to, is being able to integrate your clinical systems as part of your surveillance systems. At the present time, I think what we see is that often that's done by surveillance officers at a side, going out and collecting data, either on paper or on digital forms and transmitting. But what you're then doing is you're building in layers and layers. So the biggest thing I would say is that as you're building your electronic health records, as you're building your technology and infrastructure in country, start by thinking, how can this be a surveillance system too? How can I capture the data from this? And how can this inform the future? Because that will allow you to think about it collectively and really make it as an integrated surveillance system for your country across a wide variety of diseases and pathogens.
Excellent. Thank you very much. Thank you. Okay, for our second lecture, this is a video presentation. Our colleague was here at the conference, Professor Sonia Anand, but she had to go back to clinic. So her presentation is entitled Prevention of Chronic Diseases Among Women in CARICOM. What can we learn from the Smart Health Cluster Randomized Control Trial? Professor Anand is a professor of medicine and epidemiology at McMaster University and director of the Chanslani Research Center focused on health equity research. She has numerous awards, and most recently, Professor Anand was awarded the King Charles III Coronation Medal for Community Service. She is working with colleagues among the Caribbean islands to prevent postpartum risk factors in women who've had an adverse pregnancy outcome, and we look forward to her feature presentation. Thank you.
Good morning. I'm Dr. Sonia Anand from McMaster University in Canada, and I'm very pleased to be here today to describe an exciting new research study that a number of collaborators have come together to initiate. This is called Smart Health Caribbean, and in fact, we've just spent the past 2 days working out the training and further details to begin this study. We're focusing on reducing cardiovascular risk, in particular amongst women who have high-risk features in the postpartum stage. And I'm going to describe the rationale for the study, the details, and hopefully you will share with me the excitement to initiate this project. Now, if we look at North, Central, and South America at the burden of cardiovascular disease, you can see in red that both the Latin and the non-Latin components of the Caribbean have amongst the highest rates of cardiovascular disease mortality, referring to death from heart disease as well as stroke. And if we look in particular in the CARICOM region, we can certainly see this is true in both men and women. Now, there are a number of global bodies, such as the World Health Organization, and regional bodies, such as the Pan American Health Organization, who have recognized this problem and have made some recommendations. One is aggressive primary care and screening to identify individuals with cardiovascular risk factors that could be treated. The second, led by the World Health Organization, based on clinical trial evidence, are what is known as best by interventions. They include salt reduction for hypertension, changes to diet, as well as restriction of tobacco and alcohol, but also include low-cost medications to treat cardiovascular risk factors like high blood pressure and diabetes. Now, a one-size-fits-all model can't always work. In particular, we have to think of the local context. We have to think about barriers to care in the healthcare system. And with respect to this project, we have to think of the periods in the life course where risk can be identified easily. And the postpartum period is one of those higher risk periods. And if we look into more details of the life course and when in the life course do we have an opportunity to observe future cardiovascular risk, for women, it is often the pregnant and postpartum period. Why? Because risk factors can develop that are like a future vision of the woman's cardiovascular risk. You may have heard that pregnancy is like a stress test for a woman. And if conditions such as gestational diabetes or hypertension in pregnancy are identified, we know that that particular woman has a 2 to 3-fold increased risk of developing diabetes and high blood pressure in the postpartum period. So this particular trial will identify high-risk women based on cardiovascular risk factors in pregnancy, other adverse pregnancy outcomes, including obesity, as well as small for gestational dates, baby weight, and with a list of high-risk features proven through epidemiologic studies, we will enroll women to receive an intervention versus usual care. Now, typically, after the baby is delivered and the mom is sent back home, standard postnatal care usually finishes between 6 weeks to 3 months. Now, this doesn't always take into account that risk factors like high blood pressure and diabetes in pregnancy place the woman at increased risk of cardiovascular disease. And this period of time is sometimes known as the 4th trimester. It is an opportunity for physicians and researchers to intervene to lower risk. And that is the goal of the Smart Health Pregnancy Study. Within our healthcare and family ecosystem in the Caribbean, in putting together this intervention, we wanted to put together an intervention that actually could be embedded within the existing health system. So we studied it carefully in 4 countries: Guyana, Jamaica, Dominica, and St. Vincent and the Grenadines. And by understanding the way healthcare is delivered in pregnancy and afterwards, we were able to build an intervention that takes advantage of community healthcare workers and in some cases nurses who see women after delivery and may see them on a regular basis at a community health center-like environment. Typically, on the left-hand side of the slide, we would see standard care, that after 6 weeks to 3 months, there's no regular care for a postpartum woman. In particular, the mom goes home, may or may not have family support, has to take care of the baby, initiate and maintain breastfeeding if possible, and also go about her normal activities in the household, preparing meals for others, sometimes going back to work early. The Smart Health Intervention plans to take advantage of the fact that there are high-risk features identified in pregnancy that tell us an individual has a higher cardiovascular risk, and integrate either home visits or visits back to the community health center where we screen and follow up cardiovascular risk factors over the course of 1 year after delivery. We use a simple risk scoring tool developed by the American Heart Association called Life's Essential 8, and where we identify a woman has a particular set of risk factors, our community health worker or nurse, guided by a digital health application, will provide advice and in some cases referral for treatment of those risk factors. Here we have the inclusion criteria for the trial. The high-risk pregnancy features are high blood pressure, gestational diabetes, early delivery called preterm birth, fetal growth restriction, and obesity defined as an elevated BMI greater than or equal to 30. The risk factors that we will track clinically include hemoglobin A1C, a measure of long-term glucose control, blood pressure, weight and waist circumference, and cholesterol. As well, as I mentioned, this period of time called the 4th trimester gives us a great opportunity to intervene and treat risk factors. We also felt it was an amazing opportunity to extend the screening to a family member who lives with the postpartum woman. And this could be her spouse or her mother or father. And we invite the family member to also receive a cardiovascular screen check and this advice, because it is easier to make risk factor changes when you are together within a family as opposed to on your own. So the goal is spread the wisdom to the postpartum woman and household members. I mentioned the way we screen cardiovascular risk factors include Life's Essential 8 risk factors. These are common to many risk scores, so we are collecting all of the factors that could be used to calculate a Framingham risk score or the PAHO risk score. These include health behaviors such as diet and physical activity, nicotine generated through smoking cigarettes or vaping, sleep, because sleep between 7 to 9 hours a night is protective against cardiovascular disease, body weight, blood lipids, blood glucose, and blood pressure. And we're able to tally up these risk factors and convey to a woman if she has a low risk of cardiovascular disease, a moderate risk, or a high risk. So it's a very simple, validated cardiovascular risk score. Now, our colleagues from Imperial College have previously validated the use of a digital health app that augment the health screening and information provided to patients by the community health worker or nurse. It enables point-of-care diagnostics, the uptake of patient history, the measurement and storing of the details within the application, and the ability to communicate back to the health center and make referrals. So it is a digital health application that could be very useful in this setting. And you can see here displayed the cardiovascular risk factors we are testing. We want to embed the intervention within the existing health system. So at the time of screening, we will ask questions by history, measure certain factors, and also measure blood tests. These are entered into the database and simultaneously populated into the Smart Health Pregnancy app. The risk score, low, medium, or high, then dictates the advice that the community health worker gives to the postpartum woman. You can see here the study visits will occur at baseline, approximately 6 weeks postpartum, where all of the risk factors are screened. At month 3, the community health worker will do the first assessment of the risk factors and provision of advice. The follow-up visits will occur also at 6 months, again, repeating measurements of blood pressure, lipids, etc. And finally, the final visit will occur at approximately 12 months from the time of the baby's delivery. And in between these times where we measure risk factors, the community health worker will have text or phone call interaction with the postpartum woman. I've mentioned that we are funded to enroll patients from 4 locations. We are using a design called a cluster randomized trial, where we randomize the health center. So you can see in Jamaica, we will have 14 clusters, 7 intervention and 7 control. In Dominica, 10 clusters, 5 test versus 5 control. St. Vincent and the Grenadines, 8 clusters, 4 tested versus 4 control. And here in Guyana, 4 clusters, 2 intervention, 2 control. And in total, we aim to enroll 1,700 women and an equal number of household members in the intervention group. And the control group throughout this study will receive usual care. So we will compare the change in cardiovascular risk factors from baseline to the end of study in the intervention group compared to the control group. And we have built into this study other measurements beyond the risk score, such as breastfeeding duration and intensity, mental health measures, and quality of life. We also will record if the woman has been referred to a specialist or to her family doctor for urgent assessment. We will, in concert with this, do an economic evaluation so that we have a cost effectiveness measurement at the end of the trial. We'll use a measurement and evaluation tool known as RE-AIM that helps us have an understanding of the reach and effectiveness of the intervention, the adoption and implementation, and the maintenance. And it really helps us understand if this type of intervention could become usual practice should it be proven to be effective. Once again, we're focused on the 4th trimester. It's a very important period in a pregnant woman's life, a period where we can identify cardiovascular risk, and we're using this as an opportunity to provide advice and treatment to lower cardiovascular risk. So I thank you for your attention. I would like to thank all of my colleagues who are leading in this effort, Dr. Simon Anderson from University of West Indies, Dr. Jane Hurst from the Imperial College of London, together with the George Institute, and many, many people who work with me from McMaster University, Mary Hearsing School of Global Health and Social Medicine in Canada. Thank you, and I hope you've had an enjoyable conference and that this sparks interest in our work. Thank you.
Excellent. So we want to thank Professor Anand for her contribution. I'm following that clock on the wall, and I know that the next session starts at 9:15. So what I'm going to do is, using the chair's prerogative, we will go into Jane's presentation next, and then we could ask questions after. If I may introduce Jane, Professor Jane Hurst. She is going to speak on smart health pregnancy, a new approach to integrating maternal care with NCD prevention and management. Professor Hurst is a consultant obstetrician in Oxford, chair of Global Women's Health at Imperial College London, and director of Women's Health at the George Institute for Global Health. Her research focuses on preventing the lifelong effects of pregnancy complications, including gestational diabetes and hypertension, and improving women's access to care through digital health and AI. She's a UKRI Future Leaders Fellow and founder of the Smart Health Pregnancy Program, developed to improve detection, referral, and postnatal follow-up of high-risk pregnancies. Jane, please, the floor is yours. Thank you.
Thanks, Simon, and good morning, everyone. And luckily for me, Sonia has, covered quite a bit of the ground that I was going to talk about today. But it's a great pleasure to be here in Guyana at this conference, and also to be presenting the exciting work that we've been doing globally on this program, but what's going to happen now in the Caribbean. So just as a first background, who are the George Institute for Global Health? This is the group I work with. So the George Institute is a not-for-profit academic medical research institute headquartered in Sydney, Australia, but with offices in India, the UK at Imperial College London, and in Beijing. And we really focus on trying to improve the lives of millions with a focus on equity. And you can see some of the statistics there about the group. But diving right into what we're working on and what my research focuses on, we've heard a bit about how things that happen in pregnancy can be this sort of window on lifelong health. And what I really want to push us all to do is open up that window and let's just get out there and stop admiring the view and start changing things. I think Sonia quite nicely summarized that, things that happen and that we pick up as obstetricians in pregnancy can have effects, obviously, on the baby and the pregnancy, and we focus on that as obstetricians, but these things have lifelong consequences for women. It's estimated that gestational diabetes affects 1 in 6 pregnancies worldwide. That's enormous if you think about it. Hypertensive disorders of pregnancy, 1 in 10 pregnant women worldwide, and hypertensive disorders, of course, one of the leading causes of maternal death. But once we, get through the pregnancy, you can see that 5 to 10 years, so pretty soon actually after that pregnancy, up to, depending on the population in the world, 1 in 2 women could develop dysglycemia, type 2 diabetes after gestational diabetes, and a third will have chronic hypertension, which of course these 2 factors are the leading risk factors in women for premature death and disability from cardiovascular and metabolic diseases. So what we're trying to do is really break this link. For those of you who are interested in, well, how much is the risk increased for future cardiovascular disease? There's been a number of systematic reviews here, but basically it's between a sort of a 50% to 100% doubling of risk depending on the pregnancy complication that you have. And note here, there's a few here that for public health people, you're probably like, oh, placental abruption, low birth weight, aren't those things that just live in the obstetrics world? They have long-term vascular consequences for women. So can we prevent cardiometabolic diseases after pregnancy? That's the big question. What's the point of screening for it if you can't do anything? Well, there is sort of, consistent evidence that there's a modest effect from diet and lifestyle interventions. Of course, picking up people who are needing to have drug treatment, particularly for hypertension and dyslipidemia and hyperglycemia, will have a long-term effect. The role of drug therapy in asymptomatic people or people who have not yet developed disease is a bit more iffy in this young population, if you think about it. But the thing that probably has the most consistent evidence of benefit is actually prolonged exclusive breastfeeding. And so this is something that we should be promoting, not just because breast is best for the baby, but also it's best for the mum. Using the postnatal period for prevention is something that, is not, an original thought that we've had as a group. This is something that lots of big groups around the world have pointed out. But what's happened is there's a lot of saying we should do something in this period, but not a lot of action happening. And where systems have tried to implement something, it's very poorly followed up. In the UK, for example, screening for type 2 diabetes after gestational diabetes varies from between 30 to 60% of women will have one screen after that gestational diabetes pregnancy. And after that first year, things rapidly drop off. So we really need to think about creative ways to move forward. The American Heart Association has highlighted this as a risk, as has FIGO, which is the International Federation of Obstetrics and Gynecology, where they've developed this thing called a pregnancy passport, where if you tick any of these risk factors, you are at risk. Now, FIGO has, helpfully come up with some recommended screenings for what would we do in these high-risk people. And one thing that, I think is really important here is not to overburden new mums with more visits to the doctor. So what they've done, and I've just circled there, is the screenings they've recommended are in line with the infant immunization schedule in the first year. The idea being that the mum is probably going to bring her baby along to some sort of health worker, and this could be a time to trigger a short assessment in her. And this sort of underlies what we've been doing. Sorry, my slides are jumping ahead. What we've been doing in Smart Health. So Smart Health stands for Systematic Medical Appraisal, Referral and Treatment. It was developed by the George Institute for Global Health back in about 2014 with colleagues at the University of Oxford and also in Sydney. And it's a mobile-enabled, interoperable, digital clinical decision support platform designed with and for frontline health workers to help deliver guideline-based quality care. So we're not talking here of doing anything particularly fancy or groundbreaking or AI or anything like that. We're just talking about what if people could get the basics? How would that improve things? It was developed originally for cardiovascular risk screening, and it's been adapted subsequently for many other conditions: diabetes, renal disease, mental health, pregnancy, HIV, TB, environmental exposures, and perinatal mental health. Smart Health Pregnancy, which is where I came in, how this sort of all came about is the community health workers in India who were working on the cardiovascular disease prevention studies there actually said to the George Institute staff, could we use this in our pregnant women? Because we think we're seeing, more people who are having diabetes and hypertension after birth, but because the cardiovascular program was designed for older adults, these women were really being missed out. So we designed a program to improve guideline-based screening, referral, and management during pregnancy and in the first year after birth, focusing on the health of women. And it was really focused in the community. After a lot of community engagement work, we found and listened to the community that their 3 priority conditions were actually anemia, hypertension, and gestational diabetes. And from that, we developed this platform and ecosystem we call Smart Health Pregnancy. So the first step in Smart Health Pregnancy, which we are also focusing on here in the Caribbean, is educating our health workers about the importance of these risks, on how to screen for them, and also on how to use a digital platform. So we talk a lot about apps and digital, but are we making assumptions on the digital literacy of our frontline health workers? Some of them are going to be very au fait with this, but some, particularly some of the older ones, may not be that digitally literate. The women then, the community health workers then go back to their community. The community health worker in India is called ASHA worker. And part of the ASHA worker's job is actually to identify in her village or her local community all the pregnant women there and help bring them into antenatal care. So for that, she uses the app to register them. She then does some very basic screening for the high-risk conditions. She enters that data in the app, and the app will give some sort of risk assessment, low, medium, high risk. For those who need it, they will be referred along to the primary healthcare centre for review by a doctor, and the doctor also has access to a tablet platform with a slightly different interface, because remember, doctors have a different responsibility in that they then need to manage these people, and particularly if drugs are indicated, they will get some support to support guideline-based prescribing for hypertension, diabetes, anemia, etc. And as was highlighted by Sonia, this actually goes on, this screening, up to 1 year after birth. The app itself is pretty basic looking. I mean, we're not a tech company, but it's very simple to use. And here's some pictures from our India project of training community health workers, very hands-on training. a community health worker screening a woman and entering data. We train the community health workers how to measure blood pressure. This is not something that has been part of their usual skill set, but we find, you know, with education, task sharing is completely possible and reliable. And this data is then entered into the app. We use point of care testing in India for hemoglobin and diabetes. And importantly, what we've done is we've selected the point of care tests recommended by the government of India for rollout in communities. So we're not introducing a new thing that doesn't exist there. We're trying to improve the way the current system works. At the end of the assessment, there's a color-coded boxes for what would be recommended for this woman. So this hypothetical patient, say, is green, so blood pressure is good, hemoglobin is good, but they haven't had their tetanus or deworming assessment, and a high-risk pregnancy condition has been picked up, which in this case looks like it's to do with blood sugar recommendations. And so we've been assessing this, and we've recently finished a large cluster randomized trial in 2 states in India, really asking to see whether we can improve women's health after pregnancy. And for the India study, we actually focused on reducing the prevalence of anemia as well as on implementation. The trial design, like the trial we're doing here in the Caribbean, was a type 2 hybrid effectiveness implementation trial. And we were working across 30 primary healthcare clusters, 50-50 intervention control. This was 60 villages in India. We trained 240 community health workers and recruited just under 3,500 women. And what we found as we have completed the trial, we, in the process of cleaning data and analysing our primary and secondary outcomes, but as a sort of sneak peek of unpublished data, you know, the system has been proven to be effective, it's been proven to be feasible and acceptable. But like all complex interventions that are done in real world settings, we've also found that other external factors also influenced how some of the health outcomes change for the women over the pregnancy. So watch this space for that data. The key learnings that we took away from this study is that the digital tools were highly valued by the frontline health workers. They really liked having the support. But in India, I don't know if this is the same in the Caribbean, there's sort of like a bit of a tsunami of apps coming at people with, you know, for screening for tuberculosis or trachoma or for malaria or whatever the local thing is. And so there really needs to be a very integrated approach to this, and working with governments to work with their digital health strategies as to how can we not just put another app on the person's phone or tablet, how can we have, you know, a seamless integrated system across different conditions. We also found, and this is something for any of you looking at digital technologies and introducing them to health workers, that doing one training session to say, here's a tablet, here's an app, here's how you do it, it's not enough to get people to do this. We needed to have support beyond the training sessions. So we had some hand-holding of health workers when they first started using the app. We also had refresher training sessions, and we really needed to sort of make sure that the fidelity of what people were doing was really able to be adhered to. We also found one learning, because as I mentioned, the app also focused on doctors. What we found actually is that in India anyway, the primary healthcare doctors change over quite a lot. You know, often the junior doctors are rotated through. So, you know, we do all this relationship building and convince someone this is a great idea, they get on board, and then 6 months later that person's gone and a new person's come in. So we need to think, how do we have these interventions? How can there be continuity in a system where there's a lot of personnel change? Where are we now? Well, as you've heard, really excitingly, we're now extending this to the Caribbean and actually modifying the approach to extend it to family members. So that's going to be something quite new that we're testing here. We're also working with partners at King's College London, expanding this to Sierra Leone and Zambia, focusing on hypertension and anemia in pregnancy there. And very excitingly, we're also working with partners, digital health partners, and the University of Sao Paulo in Brazil to expand this also into the Brazilian context. So watch this space. You know, I think this is definitely an area where we hope to see lots of great progress for women in the future. So my take-home messages, and I think you'll be impressed, Simon, I've almost made it in on time. I want everyone to go home and realize that these pregnancy complications can have, lifelong consequences for women. And it's not just diabetes and hypertension. It can be other things that happen in pregnancy: stillbirth, low birth weight, preterm birth, abruption. We need to be creative to think how we can deliver effective screening and prevention in the community, and particularly how we can center that around the woman. I mean, if any of you have had kids before and you've got a new screaming baby, the last thing you're thinking about is your heart health in 20 years' time, and that you're going to go into the community health center and sit there for 2 hours to have an assessment with someone. We need to break that model and think about, can we use community health workers, outreach workers, make screening and prevention timely and convenient for women, as well as cost-effective for the health system. And finally, we really need to try and make women's health more than reproductive health. This is me as a reproductive health specialist telling you this. Women's health, women have different experience of health throughout their lifetime across multiple conditions, and cardiometabolic disease is one. And so I think, I hope we've inspired you today to support our program and go from there. And here's a final slide with a QR code. We have a booth here at CARPHA and some information if anyone's interested to learn more about the study. We also are having some training opportunities for early career researchers across the Caribbean. Lots of exciting stuff happening. So thank you very much, and I'll hand back to you, Chair. Thank you.
Thank you very much, Jane. That was really fascinating. Even though I'm part of the project, very well presented. So thank you. I will give opportunities for call. It's not fair for me to ask questions. This is our project. So I'll give opportunities for colleagues to ask questions. I can only see when the light, I can't see hands. So if you let's turn the light on, I'll spot the red light. Yeah, go ahead.
Thank you very much. That was really interesting and quite timely sort of initiative as well. It fits in quite nicely with the sort of recent Lancet report that came out on women's cardiovascular risk factors and outcomes. And that came out in 2021. And there has been quite a lot of movement around that. But what that highlighted was how factors such as hypertension and sort of type 2 diabetes can almost put women at greater risk than age-matched men, for example, of cardiovascular diseases. And that, when combined with the underdiagnosis, the undertreatment, and the general approach to women's health is causing women to have significantly much worse outcome from cardiovascular risk. So that is a really great initiative. But what I wanted to ask was, in collecting these data, how is this being fed into a national strategy within each of the countries? Because that is quite critical in terms of building within the community, as well as being able to sort of have a global approach towards these types of diseases.
Yeah, excellent question, and thanks for highlighting that Lancet Commission on women's cardiovascular health. It was really, a landmark, a piece in this space. So at the moment, the work is being conducted as research, but because we're working in the health system itself, the data that is being collected through the Smart Health platform is actually housed within the health system. So we're working with local digital partners in each of these countries to make sure that that data stays locally, it's owned locally. Women give consent and permission for the research team, like foreigners like me, to be able to analyze that data. Although I don't see any individually identified data, that stays very much locally. But I guess, before a government is going to say, yes, let's just, put this on our electronic medical health record or our health system app, they do need to see some proof of concept and that this can work and this is feasible in each setting. So at the moment, that's what we're trying to do. But we are working with governments in each of these settings to make sure this is fully aligned with the digital health plans for that country. If they don't have a digital health system, pretty much everyone has plans for one at the moment. So let's make sure that this is something that would seamlessly integrate as we go forward. I showed the different countries we're working in, and you can imagine we're going from Sierra Leone to Brazil. So we're going from a very poor country to a country that is actually pretty advanced on this stuff. So we're learning how to integrate into systems at different levels of digital readiness. But yeah, it's a good point, and this is something that Simon and I will be working on for the next few years, I think. So.
Yeah, I probably should thank the CMOs of Jamaica, Guyana, St. Vincent, and Dominica, as well as the ministers of health and the ministries of health for supporting this. So all these projects, we did our co-design and our community engagement before we submitted to the NIHR, which funded this project, and we're grateful to the NIHR for that. So the approach is a community-based approach. It's supposed to enable systems and develop the health systems of the region, and it's not meant to be a leg up for us researchers to get on with our careers. It's really meant to be life-changing in the systems, because we're trying to cut the prevalence and the premature mortality from cardiovascular diseases in the Caribbean. Thanks. Yes, just go ahead.
Yeah,
Sir.
thank you so much for your presentation. I have just two questions. Normally, in the course of your presentation, you did mention the fact that you use like the vaccination schedule. I would like to find out if within that window, maybe, or within the postpartum period, which does not fall within that particular window, and then a lady develops maybe like high blood pressure and then some funny readings, what did you guys consider? And then secondly, like I think more focus was being laid on training of the health personnel. I would like to find out, were there any like some challenges to actually engage the community? And then secondly, how was it actually addressed? Thank you.
Yeah, great questions there. So yeah, between those screening visits, if you like, at the time of the infant immunization, if someone is detected to have a condition that needs follow-up, that they have high blood pressure and things, there's then a pathway built in for either referral to primary care doctor to reassess that and make a formal diagnosis of hypertension or whatever it is. Or if the doctor thinks someone's a bit borderline and they want the community health worker just to recheck their blood pressure in a week or something like that, that can be done in the community too. So there's a two-way communication through the app that we can do that. The second question around engaging the community health workers, I mean, the work that we started in India, before we were able to do the trial, we actually did a pilot study, which took nearly 3 years because of COVID, came in. But it was very much focused around listening and working to what would be possible within the health system, understanding the workload of the community health workers, understanding, how they talk to women and the questions that the women have. And that's an ongoing piece of work. It's not a static thing. And I think that's something we have as part of our Smart Health Caribbean project, quite a big co-design and community engagement involvement piece. And I think I saw Joanne was here somewhere before his leading on some of this work. So that is critical, understanding that.
Thanks, Jane. I see, is it ceremony there? And there's one across. So ceremony first, please go ahead.
Can you hear me?
Yes.
It's too fancy. I'm sorry, I'm Ceremony Harding from King's College. Thanks to you, Jane, Simon, and Sonia. Really nice presentations. The questions I'm asking is the sort of troubles that we're all facing with these types of studies. Is one, we've had a lot of discussion, for example, in one of the studies that we've just started in Kenya, about the overload on community health workers. And in South Africa, this is such an issue here. Everyone goes to community health worker. It is really worrying, actually, because as you know, also the business of their career progression is almost minimal in terms of discussion. Secondly, questions dear to my heart is as usual with all of these studies, the issue, the central to this issue is addressing inequalities in health. But I didn't hear much about how you're going to measure the intersectional impact of the intervention to ensure that this does not drive inequalities further and widen inequalities in outcome. Thank
Wow,
you.
good questions again. And there. So I think, you are absolutely correct that community health workers around the world, they're often very overworked, underpaid, often not paid, and are a voluntary sort of group. Here in the Caribbean, the way that we are structuring the program is working with each country, working out the cadre of health workers who would be best placed to deliver this. So there's actually a bit of a range across each of the countries with the health system structured differently. And in some places it's a community nurse, in some places it's a public health outreach worker, in some places it's more a community health worker. Coming back to where we're working in India, I mentioned the overload of apps, but of course that reflects an overload of burden that they have. And when we actually would speak to the ASHA workers and say, which of these apps do you actually use? The only one they used was the one that they can use to get paid through. So they basically were just, it was sort of just total overload and not actually then delivering the work. So I think that implementation step for the health workers is how can we see the world from their eyes, work with them to make their job easier. And this is where technology, the role of technology in health, should make our lives easier. It should not burden us with more stuff that we have to do. So how can we really take that mindset into this rather than say, here's another thing for you to do, here's another, this won't work. In terms of the inequalities, obviously limitations of time, we have done this as an implementation effectiveness trial, and one of the core parts, we've been using REAIM framework is thinking about reach and equality and actually thinking not just how many people did you screen and where did they live, but actually then diving a little bit more into those who missed out or those who dropped off, what was happening in their lives and what are those other intersectionalities. We have been I have to admit, where we piloted the work in India was not the most deprived and remote places. We actually went somewhere where they had a capacity to be able to implement something like this. So would this scale into a more deprived area, into a slum community, into something like that? I don't know. That's work that we would have to do, but it's a point very well taken.
Hi, thank you very much. Wonderful presentations. It's a follow-up, just very quick follow-up. So I think you started defining it in the Caribbean. I think there is a very diverse group and profiles of health professionals where also with community health workers in different countries, in some countries, we haven't been able to identify the existence of community health workers. So you just mentioned that it would be a different profile of workers. But my follow-up to that was, were you also creating or generating new cadres with the profiles of community health workers within those? And how are they connected formally to the healthcare delivery systems within those countries? Thank you.
I don't know whether, Simon, you want to talk about the different health workers?
Yeah, so the idea is that we're aiming to start with what's available. So as you say, there's a variety of types and even names. So we use the term community health workers generically here, but there is going to be, as you say, different cadres of workers across the region. And we will work, we are working in the system that exists. So we're not aiming to create something new. The key thing is to be able to train, to have training that can overflow into the whole health system rather than remain as a standalone for the study. So at the end of the trial, we would aim that everybody gets trained according to whether or not the health system thinks that it works. I don't know if that answers the question, but yeah. And final question, sorry to keep you that long.
That's okay. Thank you very much, Jane. Jim Campbell, also from King's College London, Professor of Health Workforce, and so similar question. When we're talking about women's health, and you made the emphasis on that, Jane, if the intervention is also then looking at women's labour, so the occupational group of community health workers around the world, more than 2/3 of which are female,
often in very informal, spurious forms of employment. Decent work is not necessarily engaged. It's a heterogeneous group from volunteers with 1 week's training to a licensed, not licensed, but some sort of credentialed form of education after 12 months in a community setting with a contract, part of a Ministry of Health and Employment Labour model. What's the ethics when you're looking at this? And to introduce, it comes back to what the president was talking to us yesterday morning about. Technology, yes. Innovation, yes. But this human capital issue. If the fundamental problem is that women's health is dependent upon unpaid women's labor, are we fixing the wrong problem?
I don't know whether that's more a comment than a question. I don't know if I can answer that question there, but I think this is where if there are any budding PhD students out there who would like to look at this in the Caribbean, it would be an excellent question to think about. I don't have an answer for that. I think you do have, you have though hit on a nerve in a very overlooked area when a lot of these community health worker programs that are spoken about is actually, as I say, thinking about the health workers and their welfare themselves. I mean, I must say from the experiences that I've had, working in these different sites, the women themselves want to do things for women. I think they can see themselves, and often, particularly in India, a lot of the ASHA workers were sort of from, mid-30s to early 50s age range where they were being diagnosed with diabetes and hypertension, and they were looking back at their own pregnancies and thinking, oh, I really didn't know that. If someone had told me that would have been... So I think the women want to do, we have a lot of power and agency ourselves as women, but, we can't let the system, I guess, exacerbate those inequalities. Good point.
Great point. I think that we need to close this session now. We can have the conversations in the corridors. I'd love to speak to you as well about this. We hope that you enjoy this session, and we will hand over to Jane. I think you're chair of the next session.
Thank you.
Thank you.
Great. Okay, let's go. Yes, I think we're done. Yes, again. We'll take another picture.
Get a picture outside, man.
I don't know. Yes. Okay, thank you, everybody. Let's take our seats and get ready for this next session, which is also focused on women's health, which is great. For those who were in the previous session, my name's Jane Hurst. I'm an obstetrician gynecologist originally from Australia, but now based at Imperial College in London, and I'm the Professor of Global Women's Health there and Program Director for the George Institute for Global Health. And I'll let my co-chair introduce herself.
Yes, good morning, everyone. I am donc Jacqueline Véronique Baudin. Actually, I am the head of the Oncology Research and Development Unit at the University Hospital of Martinique, an island. Martinique is a French island between Dominica and St. Lucia. And I have to introduce the first speaker today. It's Dr. Carla Farmer-Diaz. This presentation, Suffering in Silence, Endometriosis and the Caribbean Research Gap. She is from the St. George's University of Grenada. You can proceed.
Good morning, everyone. Okay, so good morning, everyone. I am Dr. Carla Farmer-Diaz from St. George's University in Grenada. So now, imagine living with debilitating pain every month. Pain so severe it disrupts your work, your relationships, your sense of self, and yet being told it's simply normal menstrual pain. For many women living with endometriosis, this is not a hypothetical. This is their reality. Although endometriosis is widely recognized as a gynecological condition characterized by chronic pelvic pain and infertility, its psychological and social impacts are often overlooked, particularly in Caribbean populations where research remains limited. My presentation today focuses on endometriosis in the Caribbean, specifically examining the mental health burden and the stigma associated with the condition and how these factors influence diagnosis, care, and quality of life. Endometriosis is a chronic gynecological condition affecting 5 to 10% of women of reproductive age, contributing substantially to disability-adjusted life years, dailies, due to severe pain and infertility. As of 2021, the global burden is estimated at approximately 2.05 million dailies, with the greatest impact among women aged 20 to 29 years. Endometriosis occurs when tissue similar to the endometrial lining grows outside of the uterus, leading to inflammation, pelvic pain, dysmenorrhea, infertility, and systemic symptoms. Beyond its physical symptoms, the condition has severe psychological consequences. Chronic pain, fertility challenges, and repeated medical consultations can significantly reduce one's quality of life. One major challenge also is a prolonged diagnostic delay, which averages between 4 and 11 years, with many patients consulting multiple healthcare providers before receiving a diagnosis. Despite having a prevalence comparable to other major chronic conditions, such as diabetes, endometriosis receives less than 5% of global gynecological research funding. In the Caribbean, this issue is even more pronounced, as region-specific data is scarce and the mental health implications of the disease remain under-recognized. At the same time, cultural stigma surrounding reproductive health, menstrual disorders, and infertility can discourage open discussion and delay care seeking. This combination of medical delay, limited research, and social stigma creates a significant but largely hidden public health burden across Caribbean populations. To this end, the objective of the study was to examine endometriosis-related mental health outcomes and stigma in Caribbean populations, and evaluate how these factors influence quality of life and healthcare experiences. To address this objective, we conducted a scoping review for the period 2015 to 2025, examining the relationship between endometriosis, mental health outcomes, stigma, chronic pain, quality of life in Caribbean population. The review followed PRISMA guidelines to ensure a standardized approach, and literature searches were performed using Google Scholar, PubMed, and Scopus, with key terms including endometriosis, Caribbean, Latin America, mental health, quality of life, pain, and stigma. Studies were included if they were English language original research focused on Caribbean populations and associated clinical, psychological, or quality of life outcomes related to endometriosis. Review articles and non-relevant studies that aggregated Latin American studies that excluded Caribbean-specific analysis were excluded. The results, the literature search initially identified, I'm going fast. The literature search initially identified 73 records. After screening titles and abstracts, 16 studies underwent full text review. Ultimately, only 4 primary studies met the inclusion criteria. These included 3 cross-sectional survey studies and 1 large-scale cross-country epidemiological analysis. The included studies examined several key variables of quality of life, psychological distress, perceived stigma, social supports, and healthcare experiences. Some of the standardized measurement tools used in the research that were included were quality of life assessments, which measured the impact of illness on their daily lives, acceptance of illness scale, which measured the psychological adaptation to one's illness, and the effect minimum patient questionnaire, which provided standardized clinical and demographic data for endometriosis research. The results consistently demonstrated that psychological distress is a significant component of the disease burden. Patients frequently reported depression and anxiety, reduced social functioning, decreased self-esteem, and difficulties maintaining employment or daily activities. Additionally, stigma was identified as a major contributor to these outcomes, with many individuals reporting feeling dismissed, misunderstood, and stigmatized when seeking care, especially in relation to menstrual pain and fertility concerns. These findings highlight critical gaps in the Caribbean healthcare system, as endometriosis may affect over 2.3 million women in this region. Yet the true burden is likely underestimated due to underdiagnosis, limited surveillance, and scarce Caribbean-specific data. Symptoms such as chronic pelvic pain, dysmenorrhea, dyspareunia, and fatigue are also often normalized, delaying diagnosis. The mental health impact is significant, with depression rates up to 86% in patients with chronic pain, compared to 38% without pain. Anxiety, poor sleep, and low self-esteem were common, and the social and psychological effects outweighed the physical impacts of endometriosis in patients. Stigma and the perceived dismissal by providers further reduced care seeking and adherence, reinforcing a cycle of delayed diagnosis, underdiagnosis, and psychological distress. Chronic pain is a major driver of psychological morbidity in endometriosis, with symptoms such as dysmenorrhea, pelvic pain, and fatigue strongly linked to depression and anxiety. Pain catastrophizing reinforced a bidirectional cycle where pain worsened the distress and the distress heightened your pain perception. Stigma independently affected mental health, reducing quality of life and self-esteem regardless of the pain severity. Additionally, social invalidation further contributed to the psychological distress. The overall symptom burden, including pain, infertility, fatigue, GI or urinary issues, disrupted daily functioning, relationships, and employment. These effects were compounded by underdiagnosis and the cultural barriers. Furthermore, diagnostic delays often exceeding 6 years are driven by the normalization of menstrual pain and the reluctance to discuss symptoms in the Caribbean and in the region, leading to reduced healthcare engagement. Socioeconomic factors such as unemployment and poor self-rated health further worsened outcomes. Overall, these findings highlight the need for integrated region-specific care addressing both biological and psychosocial dimensions of endometriosis. Based on these findings, several key recommendations have emerged. Firstly, healthcare systems should integrate mental health services into gynecological clinics, enabling patients to receive psychological screening and support alongside physical care. This integrated model could help identify depression or anxiety earlier, improve treatment outcomes, and enhance patient well-being. There's also a critical need for Caribbean-specific epidemiological studies. This will improve data collection, enabling researchers to better estimate disease prevalence, understand regional risk factors, and develop culturally appropriate interventions. Public health initiatives should focus on reducing the menstrual health stigma by normalizing discussions about menstrual health and chronic pelvic pain. Furthermore, educational campaigns targeting both healthcare providers and communities can help reduce stigma and encourage earlier care seeking. Additionally, a multidisciplinary and stigma-sensitive approach can significantly improve patient outcomes. Effective management should require collaborations with gynecologists, mental health professionals, public health specialists, and pain management experts. Endometriosis, in conclusion, is a significant yet under-recognized public health issue in the Caribbean, with psychological and social impacts that remain insufficiently addressed. Addressing this burden requires an integrated multidisciplinary approach, combining gynecological care, mental health support, and public health strategies to improve early diagnosis, patient well-being, and equitable access to care. Crucially, region-specific research and stronger integration of mental health are needed to better capture the hidden burden and guide culturally sensitive response care in the Caribbean. And if nothing else, sorry. Okay, if nothing else, it doesn't want to me. Endometriosis is not solely a gynecological condition. It is a critical public and mental health issue. I would like to thank my collaborators for their valuable contribution to this research, and I thank you for your attention. I'll be happy to answer any questions.
Thank you so much.
Thank you.
Thank you so much for your clear presentation. Is there any question? Any question? Indulgence? It was so clear.
No questions? Okay. Yes, Bill?
Any question? Yes.
Yes, sorry, I was having technical difficulties myself. No, I thought it was a really enlightening presentation. A lot of females, within the Caribbean do suffer from endometriosis and PCOS.
Yes.
So my question, sorry, I'm Camille from Ministry of Health and Wellness in Barbados. I work in the entity unit. I just had a simple question. So how do you propose, you emphasize like the need for like psychological care, et cetera, and mental health. So how do you propose that this be integrated into already burdened health, like healthcare/mental health systems? So, and I give the example of Barbados. We have Lifeline Barbados, which is the mental health hotline that came on recently. I don't want to quote the date and get it wrong. But how do you propose like this be integrated and be added into an already burdened system?
So thank you for your question. So I believe it begins early. So knowledge to the young persons as they're coming up with their menstruation. So when they have puberty and go to knowledge in the schools, and we advocate and educate them that how pain is not normal. So when they're aware of these things, and then they can talk to the doctors early on instead of having to wait until it reaches critical mass where they're like, I am depressed, I have anxiety. At the beginning, when they're aware that how we have these gynecological symptoms like PCOS, like endometriosis and fibroids, these things are not normal, so they could address it and talk to someone early enough, even a social worker, and get help on how to mitigate the depression and the mental health burden later on. So I believe it is education and advocacy early, especially with the secondary school students. And that can then help mitigate the overload of the mental health professionals later on.
Great.
Sorry, can I just ask like one follow-up
Very
question?
quickly, just
Right,
because of time. Yeah.
Understood. So the obviously like persons experience like gynecological English, the gynecological things like at varying ages. Some people get issues as young as 10, I assume, or some people get as old as within their early teens. So how will you address that barrier in terms of like parental consent, et cetera, when it is that conversation is a really tough conversation that happens between Caribbean parents and children, as well as healthcare professionals?
So I think this is where outreach is important. So in Grenada and in the Caribbean, I know there are some outreaches that go to the schools and into the community and have health days. So discuss it and let it be known that these things are happening And that stigma, we should discuss it because we had the stigma where you have your period, it is supposed to be happy, it's supposed to have to be painful, and it's not normal. So we need to have those, when we have health fairs, have booths and just have that committee discussion, have flyers and just have interactions there and start on a small scale before it, and then we can upscale it. And that way we can get it to the parents because they're seeing it there and they will have that open discourse with their children or with their teenagers so that they are aware of it, so that when they're getting older and they're seeing these symptoms coming up, they're like, okay, I have these symptoms. Could it be PCOS? Could it be endo? Could it be fibroids? So they are aware of it from a young age. So I believe health fairs is what, and bringing that outreach into schools, because we have those outreach when you are coming from, I believe, common entrance, that age group, into secondary school. We have those interactions and we have those persons coming into schools and educating the students about the changing bodies and stuff like that. Highlight those things when they're having that conversation with them in that sector.
Great. Well, thank you very much for a great presentation.
Thank you.
Okay, so keeping on the theme of endometriosis and women's health conditions, it's my pleasure now to invite Dr. Julia Mandeville, who is going to talk to us about a cross-sectional survey of stigma, anxiety, and depression in women with endometriosis and/or uterine fibroids in Barbados. She has recently graduated from her PhD, so congratulations.
Thank you.
From George Mason University, United States of America. Thank you.
It's my slide. Oh, my slides. Oh. Hi, good morning, all.
Can we get some technical help with the slides?
Slides. Oh,
There we are.
there we go.
Okay.
Oh, so hi again. Good morning. My name is Dr. Julia Mandeville. I'm from Barbados, and I'm a PhD graduate from the George Mason University, and this is one of the studies that I did in my dissertation, a cross-sectional survey of stigma. So my colleague that went before me made my job a lot easier. Stigma, anxiety, depression in women in Barbados with endometriosis and/or uterine fibroids. So I just want to thank the research team, specifically Dr. Chung who was the mentor and principal investigator of this study. We're going to go through definitions, which my colleague presented some earlier, do a summary of the literature, why I have these research questions, all the way to the discussion and the next steps. So what is endometriosis? I think we all just learned a little bit about it, but I will reiterate. It is a chronic pro-inflammatory condition, and it's characterized by a lot of pain, and it's also associated with adverse pregnancy outcomes, which we spoke about this morning, as well as infertility, and it has a prevalence of up to 20% among persons assigned female at birth, women, girls. And I have a diagram here to show that endometriosis is not just a reproductive condition, even though a lot of us would have thought that before. It can affect any organ system in the body. So the other condition of interest, uterine fibroids. Given our context, I think most of us have at least heard of uterine fibroids before, but these are non-malignant tumors, which are made of smooth muscles, which are located in or on the uterus, and there's several different types identified here in this diagram, and it's associated with heavy bleeding, again, chronic pain, adverse pregnancy outcomes, and even though maybe up to 80% of women by the time they reach 50 could have uterine fibroids, roughly 30% are symptomatic. And the symptomatology of uterine fibroids aligns closely with that of endometriosis. And moreover, while these are conditions that are associated with reproductive health and gynecologic health, for this purpose, I characterize them as chronic conditions. Endometriosis is chronic, inflammatory. You can never get rid of it. And uterine fibroids, you can have a hysterectomy, you can have a myomectomy, but even with myomectomy, you can have recurrence of uterine fibroids. So it's just important for us to frame these conditions as lifelong and needing lifelong management and treatment. And then my exposure of interest is stigma. So again, my colleague before spoke about stigma, but really what is stigma? So it's like this overlap of labeling, stereotyping, status loss, and discrimination. And there's always this power dynamic. So you have this us versus them When you think about stigma, especially health stigma, you think all the way back into the biblical times, you think about the people that have leprosy. So it was us versus them. And it's also a social, political, and cultural construct, because when you have this stigmatized identity, even though it's more or less unspoken in a lot of spaces, it still maintains inequality through social, economic, and institutional processes. And for my research, I focused on 2 different stigma experiences. So there are many types of stigma, but for this, I looked at anticipated stigma, which was that, you had these experiences and now you believe, based on the history you had, or maybe someone told you something, that you can anticipate this discrimination specifically based on your health condition. And then internalized stigma is when you start to believe that about yourself and see those stereotypes as self-relevant. The adverse mental health outcomes that I focused on were anxiety and depression. And I think most of us in here either have experienced anxiety or depression at one point or another, or know people that are navigating these conditions. And these are typically very prevalent within the Caribbean region. And data shows that they're highly prevalent among women and girls. And so when we look at the current literature as it relates to stigma and mental health with endo and uterine fibroids, we see that there is this emerging research that has shown that there is a significant relationship with stigma and poor psychosocial well-being for persons that have endometriosis. And other studies have shown that there's a direct, significant relationship with depressive symptoms, as well as stigma experiences in the USA. Whilst uterine fibroids have been associated with depression and anxiety, there are no stigma-related studies that were available, but we assume because of the similarity of the symptom profile that the outcomes for endometriosis and stigma might also apply to uterine fibroids. And so this leads to the study rationale. We know stigma is a barrier to healthcare. There's this emerging research about stigma and endometriosis, but we have not done any of this research within the Caribbean, specifically Afro-Caribbean populations. And it is important to understand this dynamic between stigma and health outcomes to inform healthcare interventions, particularly within the setting that we are collecting data from, which in this case is Barbados. So we asked 2 questions, which are kind of repetitive, but it was an association between stigma and anxiety and stigma and depression for persons in Barbados that were diagnosed with endometriosis and or uterine fibroids. So I conducted an online cross-sectional study from March to May 2025. You have my poster there where I recruited persons using social media and word of mouth. And the study population were Barbadian residents who were assigned female at birth, older than 18, had access to the internet, and were self-reporting their diagnoses. So the key study measures, the exposures, like I said, were the 2 types of stigma. And so these were validated stigma scales that I used. And the questions for the scales were adapted specifically to ask about negative experiences or negative beliefs about themselves or towards them based on their conditions. And then the patient reported outcome measures I used were the patient health questionnaire version 9 and the generalized anxiety disorder scale 7, which I think many of us are aware of. That was dichotomized so that we can really look at severity. So the cut point was that for severity, for severe depression and severe anxiety for both of them. Come on. If it would move. And then I conducted multivariable logistic regression models to obtain the odds or the likelihood of these relationships, and then I controlled for sociodemographic variables. This is not working well. Okay, there we go. So my results, at the end of the study, we had 353 people that were eligible. Most obviously were born in Barbados, most identified as Black or Afro-Caribbean. And then when we looked at the breakdown of the diagnoses, unsurprisingly, most had uterine fibroids only. But we also had persons that had endometriosis and uterine fibroids, and then the lowest percentage were those who had endometriosis only. Okay, so this is showing us the relationship between internalized stigma and severe mental health symptoms. So broadly, what this is saying is that persons who had this internalized stigma were 2 times as likely to have severe anxiety, and this is statistically significant. And then concerningly, you see with severe depression, they were with internalized stigma, they were 7 times as likely to have severe depression versus not having severe depression. Is it me? Okay. Okay. And then for anticipated stigma and these mental health outcomes, we see that persons who had anticipated the stigma were almost 2 times as likely to have severe anxiety and almost 3 times as likely to have severe depression. Again, all statistically significant findings. Okay. So what does this all mean? I think it shows that when stigma is this exposure, it does impact mental health to the level of potentially the need for clinical intervention. So for those of us who have utilized these tools and work in the clinical field with these tools, we know that severe depression, severe anxiety, that can be associated with decreased functioning, increased impairment, and then potentially more rigorous intervention to reduce the risk for increased severity. But the issue is because people aren't that familiar with these conditions, and as my colleague before said, they discriminate towards persons that have heavy menstruation, painful menstruation, infertility. This stigma exposure can be chronic, and it actually can begin as early as adolescence. And so if it is chronic, it can lead to worsen overall health outcomes. I'm gonna go back. So what do we want to do after all of this? So it might be important to develop multi-component stigma reducing interventions from within the community, in the healthcare clinics. And there's also a policy implication here in terms of developing guidelines and developing more rigorous strategies to help reduce the stigma that persons with endometriosis and uterine fibroids are encountering. And we need more research in the Caribbean. I think that's going to be a repeated theme as we move through this particular session, but we need more research to understand how these conditions affect women and their health moving forward. So obviously, every study has its limitations, so can't really generalize this study beyond the sample because its cross-sectional causality isn't something that we assume, but that's not what we were looking for here. We were really looking at that relationship between stigma and mental health outcomes for persons that have these conditions. I also was able to geo-lock the survey to Barbados, and that's really important because since COVID, there were so many people that were trying to get onto surveys to potentially get the incentive. So it shows that the population was very representative of the Barbadian broader population. And we were able to prove without a shadow of a doubt, or show, I should say, that stigma and mental health are significantly associated within the Caribbean, as it has been shown in other places. And so we also need to develop more interventions to address this. So these are my key takeaways. It is the first empirical study of its kind. We show that stigma is significantly associated, and we need early community education and stigma reducing interventions. Thank you so much.
Thank you, Julia. That was really clear. Excellent presentation. We probably have time for one question, if anyone has anything. But yes?
Hi. Thank you, Dr. Mandeville.
Thank you.
This was, again, good research. We know the problem of endometriosis and the mental health impacts. So thank you for this piece of research. My question was really about the ages. I noticed in your demographic slide, you just had how many were from 18 to 34, I think. Yeah. So and it didn't seem to be a majority. So I was just wondering, what were the other ages of the persons in the survey?
Yeah, no, thank you for that question. So it was actually like a third, so it was 18 to 34, 35 to 40, and then to 45, and then 45 plus. So it was, so that was just like the bigger of the thirds, but it was majority of the persons that responded were in their mid to late 30s. Yeah. Any other questions? Yes.
The last one.
Very quickly.
Wait, the last one.
Yeah, you said that it's endometriosis and fibroids are lifelong problems. Not really. Endometriosis is menstruation lifelong.
No, it's not. Sorry, I have to disagree. This is my research. So endometriosis is a chronic, so you can have a hysterectomy, you can go through menopause, but because endometriosis can be, there are people that have endometriosis on their lungs.
I know that.
Right.
And in the nose, with the greatest respect, I've been practicing ONG for about 40 years. And in my experience, I have not seen endometriosis and problems at menopause. Again, my experience.
I have seen the research that it's happened in other settings. Yeah, so that's why we need the research in this setting.
Okay.
Yeah.
Once again, thank you so much.
Thank you.
We have to move forward to the third presentation. I call Dr. Kalisha Hale. She's a graduate student researcher. She's from the FAMU College of Pharmacy and Pharmaceutical Science, Institute of Public Health in Tallahassee, Florida, United States. The title is Investigating the Association of Drug Exposure During Pregnancy with Birth Outcomes Among Mothers with Medicaid. You can proceed.
Thank you very much. Greetings, everyone. I am Kalisha Halley, and I'm from the lovely island of St. Martin, representing Florida A&M University. And I would like to thank my faculty advisor, Dr. Tammy Johnson, for her guidance and support during this study. So we know that with many conditions or health issues, for assistance, individuals tend to use or turn to opioids in terms of terminal illness and rehabilitation. And recently there's rising use in marijuana prescription or recommendation for anxiety, poor appetite, nausea, etc. Pregnancy already places a significant demand on the body, making maternal health critical for both mother and child. Yet substance use during pregnancy remains relatively common in the United States, particularly with marijuana in the increasing alongside of legalization. The challenge is that evidence is still unclear, and while some studies link marijuana use to adverse outcomes like low birth weight and opioid use to neonatal abstinence syndromes, others find little to no association in terms of marijuana use, leaving both providers and patients navigating some uncertainty. So my research question is specifically investigating, is there a strong association between exposure to marijuana use during pregnancy and low birth weight outcome? So this study used 2018 to 2020 maternal and birth outcome data from the Florida Bureau of Vital Statistics for newborns of women who use marijuana or other substances during pregnancy, ranging from opioids, cocaine, meth, and tobacco use. Descriptive and inferential analyses were conducted to examine the relationship between infant low birth weight and mothers who use marijuana during the pregnancy compared to their counterparts who use other substances, controlling for socio-demographic characteristics, prenatal care utilization, and tobacco use. The final data set consisted of 988 mothers identifying as Black or white, non-Hispanic, and presenting positive for one or more drug use at the time of pregnancy. So the ProcFreak revealed 31.68% of mothers who use substances were between the ages of 21 to 25 years old. 30% were between 26 and 30 years old, and the rest followed in lower prevalences of frequencies. 65% of the women in this study had an insufficient number of prenatal visits, and prenatal visits in this study is defined as 11 or less prenatal visits during the time of pregnancy. 87% of this data set use marijuana, 9% use opioids, and less than 3% use both. So the results show that maternal marijuana use was not statistically significant with infant low birth weight in this population compared to the maternal use of other substances within the data set, as mentioned before. Using a multivariable logistic regression, the statistically significant associations with low birth weight was maternal age, race, marital status, and prenatal visits. So we'll talk a little bit about these significant factors other than sole marijuana use that was attributable to the prevalence of low birth weight. So what these results are saying, each individual year of maternal age was associated with approximately 5% decrease in the odds of low birth weight. This could indicate that the younger mothers within this substance use population may be at higher risk for adverse outcomes. The descriptive findings support this trend, as majority of the substance using mothers were within the younger age groups. The odds of the low birth weight occurring for Black mothers who use substances compared to white mothers who use substances were approximately 48% lower. However, this finding is a bit inconsistent with established literature and could likely reflect the differences in substance use patterns among race with the restricted population. White mothers represented for more than half of the substance use in this data set, specifically 57.8%, which may influence the observed findings. In this study, unmarried mothers who use substances had approximately 47% lower odds of low birth weight compared to married mothers who use substances. And oftentimes, marital status can be used as a proxy for social support and access to healthcare, but this finding can suggest that maybe there are different roles within substance using mothers' relationships. The dynamics may differ from what we're used to seeing in literature. For each additional prenatal visit, the odds of low birth weight decreased by almost 1%. Now, while this is pretty modest, it was statistically significant and becomes a little more meaningful as you consider cumulative visits across the pregnancy time. So the descriptive findings also support this relationship. Among mothers who use cocaine, for example, during pregnancy had over 90% either had no prenatal visits or insufficient visits. And similarly, 18% of the mothers who did not use marijuana had 0 prenatal visits compared to 7.3% visits for marijuana users. So these can suggest that access and engagement in prenatal care varies also across substance use group, and that lower utilization may contribute to worse birth outcomes. Lastly, among those who were already using substances, those who used tobacco had a lower odds of low birth weight compared to those using other substances in this data set, potentially having more harmful effects. So, okay. So this study has several important limitations to consider. First, there was no non-drug exposed comparison group. All the participants were substance users, and so this reflects differences within a high-risk population rather than comparing it to general populations or non-drug users. Secondly, there was also limited analysis of polysubstance use. Many individuals may have used more than one substance during pregnancy, and so that could not fully capture combined exposures and may mask effect of individual substance use. Thirdly, there could be reporting bias as a concern, as substance use during pregnancy is underreported due to stigma, and many women fear legal consequences, especially in America where the political climate is punitive towards this public health issue.
Additionally, residual confounding could also exist as factors like socioeconomic factors, mental health, and quality of prenatal care were also not fully accounted for, but can influence both substance use as well as birth outcomes. And finally, there's limited generalizability as these findings cannot be directly applied to populations outside of substance-using mothers. But taking these limitations into account, this study remains critical because I believe they move beyond assumptions and help us see how different types of substance use can actually influence birth outcomes via other factors, such as the prenatal utilization. It reminds us as public health professionals to avoid a one-size-fits-all approach and instead design targeted and data-driven interventions. And moving forward, I believe that health efforts should prioritize integrated healthcare services, harm reduction strategies, and policies that could expand access to prenatal and postpartum care, particularly for vulnerable populations. And while this study did use US data, I believe the analytic approach can be a scalable model for strengthened maternal health surveillance and also informing targeted interventions for other under-resourced settings and even in the Caribbean. And at this time, I'll accept any questions or comments. Thank you.
Thank you so much for these main topics in Caribbean and in other countries. Any questions?
Sure.
Thank you very much for that presentation. I think I learned a lot. David Johnson from Dominica, TJ Consultant Services. In this study, you look at the association between these drugs and low birth weight. The question I have for you is, did you consider the form of the substance which was used in terms of smoking, drinking, or inhaling?
Yes.
And in terms of quantity during?
So because of punitive laws in Florida, this information cannot be or was not collected throughout pregnancy. These are recorded at the time of birth. So it's just showing positive. And I do believe that's also a limitation because it doesn't show if it was edible or something ingested or smoked, just positive for THC. Thank you. Over there? His hand was first. Oh, ladies first.
Go ahead.
Thank you. I'm Ollie Pereira from the University of Guyana, lecturer. I was wondering what was the prevalence of low birth weight within the study population? And also, I didn't see any controlling for things like hypertension, actual other causes of low birth weight and how that might have affected study results.
So the prevalence of low birth weight in this study was about 14%. And I had to limit the things that I was interested with in this study for the scope, given that this was my thesis. So I didn't include other chronic conditions, for example, like you say, heart issues. Thank you for your question.
Thank you so much for your excellent presentation. I have two questions.
Okay.
The first one is, you did mention like a strong association. So I want to understand, like, in the course of your presentation, you didn't actually explain, was it just a simple association or was it a strong association? That's the first remark. And the second one is, I don't know if we should, in this setting, we should consider alcohol as a substance used in pregnancy, because alcohol has been documented or it has been reported to contribute a lot to low birth weight. So I don't know if you should have considered that or not. Thank you.
Okay, thank you for your question. The first question. Oh, yes. So I didn't go into discussion on the strength of the association because it was not significantly statistically significant. So I went into the other variables that were significant. And then also alcohol in the United States is classified as a big issue, as I think in 2021, over 20% of mothers use alcohol during pregnancy, and that was a big issue, but it was not included as a variable in the model.
Great. Thank you very much, Kalisha. We grateful. And a very important area that you've highlighted. I think there are probably a lot more questions that we could ask of your data. So thank you for presenting that. So I'm going to move on now to our final speaker of the session, Dr. Britta Lawrence, who is going to talk to us about a review of hypertensive disorders of pregnancy between January and December 2023 at the Queen Elizabeth Hospital, Barbados. She is a medical doctor from Queen Elizabeth Hospital, Barbados. Over to you.
Good morning, everyone. My name is Dr. Britta Lawrence. I'm from the University of West Indies, Cape Hill campus, Barbados. I am honored to be here to present our study. I want to thank CARPHA for this platform, as the findings speak directly to a regional gap we need to fill. All right, so let's start with the problem. Globally, hypertensive disorders of pregnancy affect 5 to 10% of women. It remains a leading cause of maternal morbidity and near miss. However, the burden is not shared equally. In Latin America and the Caribbean, the numbers are stark. In 2006, WHO analysis showed HCP accounts for 25% of maternal deaths in our region. Between 2016 and 2020, PAHO reported a troubling 15% increase in maternal mortality in Latin America and the Caribbean. And by 2013, PAHO reported that a woman dies every hour from preventable complications during pregnancy, childbirth, or the postpartum period. By 2024, the WHO identified postpartum hemorrhage, infection, and hypertensive disorders of pregnancy as the leading major complications worldwide, collectively responsible for 75% of all maternal deaths. Regionally, a lone representative study in the Caribbean was from Haiti, who estimated the prevalence of 5.8%. However, it did not examine the risk factors. While in Barbados, no recent data on HCP prevalence exists, neither risk factors associated. And of course, we ask, why does this matter? In SIDS contexts like Barbados, human capital is a critical resource. The loss or incapacitation of women of reproductive age due to maternal complications has far-reaching socioeconomic implications. With Barbados' small population and the declining birth rates, our maternal mortality ratio is highly sensitive. This phenomenon, often referred to as a small numbers problem in epidemiology, can lead to significant statistical volatility in health indicators. Every single maternal death exerts a disproportionate effect on our national statistics and our ability to track progress towards the Sustainable Development Goal, which aims 3.1, which aims to reduce maternal mortality ratio to less than 70 per 100,000 live births by 2030. So we need a baseline. Oops. Sorry. All right, so to address this gap, our aim was straightforward: to estimate the prevalence of HCP and identify associated risk factors among women delivering at the Queen Elizabeth Hospital in 2023. Secondarily, we sought to identify the socio-demographic and the maternal risk factors, specifically looking at age, BMI, parity, anemia, chronic hypertension, to name a few, and their associated hypertensive disorders, disease of pregnancy in the Barbadian context. So our methods. This was a retrospective cross-sectional study. And of course, when we look at setting is important. So why QEH? Barbados operates on a tiered healthcare model with primary care services provided through a network of polyclinics and private healthcare centers distributed across the island. And QEH sits at this apex as the principal public tertiary hospital in Barbados, with 3 healthcare at the point of delivery. This made QEH the appropriate setting for this research to estimate prevalence and identify any associated risk factors between the specified time of January to December 2023. So our target population, we wanted antenatal patients, any pregnant woman during the study period of 2023, greater than 20 weeks gestation. Now, these patients, part of the exclusion criteria, would be persons who have renal disease, liver disease, UTI, or thyroid disease, as these disease pathology can mimic HDP signs and symptoms. Okay, and we'll just summarize on this slide better. All right, we systematically sampled every 6 patient record from the labor and delivery admission book at the QEH for the entire year of 2023. Given the time frame of this MPH project and the necessary administrative approvals, we reviewed 115 records, which were then finally included in the study out of the calculated sample size of 289. Data was analyzed using descriptive and inferential statistics, including logistic regression. And just to mention, this study was exempted from IRB approval. Okay. Whoa. Okay. Let's look at who we studied. Our cohort was predominantly Black women with a mean maternal age of 27 years. The majority were single, gainfully employed, and had competing secondary or tertiary education. This profile is important in context. This is an economically active, educated population with free access to healthcare at the point of delivery. Maternal characteristics. Regarding maternal health, the mean BMI was 28.75, placing the average woman in the overweight category in Barbados. Critically, we saw BMI increase with age, reaching a mean of 32.1 in the 30 to 39 age group. All right. Notably, in this section also, obesity and anemia prevalence are at 62.7 and 61.7% respectively among all pregnant women in the study. All right, for the headliner. We found a cumulative HDB prevalence of 14.78% at the QEH. Intrapartum preeclampsia was the most common subtype, accounting for over 11% of cases, and with a mean onset of 35.5 weeks gestation. To put 14.78 into perspective for this audience, Barbados, though a small island developing state, is characterized as a high-income country. However, the prevalence we have discovered here is on par with low middle-income nations. All right. In our analysis, 2 factors showed statistically significant associations with HDP testing and were at least overweight and similar proportion as anemic. First, nulliparity. Women have their first baby, nulliparity women having their first baby, and second, which was the most significant, was chronic hypertension. These findings align with global literature, but confirm they are driving the disease burden locally. Interestingly, while obesity and anemia showed increased odds of 2.1 and 2.3 times respectively, they did not reach statistical significance in the multivariate model, and this might be possibly due to the sample size limitation. However, clinically, this is a red flag. Okay. One regression finding stood out as counterintuitive. Higher education was associated with increased odds of HDP. This may seem surprising, but in the Barbadian context, it suggests that while poverty may not be a barrier, work-related stress and the demands of being an employed, educated woman might impact health-seeking behaviors or physiological stress differently. It tells us that even in a high-access system, we cannot take our eyes off the ball. All right. So limitations, and I want to be transparent about this. As mentioned before, it was a retrospective single-site study at the QEH, which means we cannot establish causality. Our sample size being 115 was smaller than the 289 projected, and due to the timelines, as mentioned, the temporal timelines of that, it did lead to some wide intervals and collinearity in the models. So for example, we did assess GDM, which is gestational diabetes, but because of the possibly the low sample size, we were not able to have the regression show any relation at that point. And because of this, the study is a foundation and not a final word. It shows us where the fire is burning hottest, even if we cannot measure every spark. However, I am happy to report that the field work has been completed and the sample size is actually exceeded. For instead of 289, we collected a total of 300. Right. And in conclusion, the burden of HCP in Barbados is high at nearly 14.78%. Our key clinical recommendations are clear. One, vigilant blood pressure monitoring is especially critical at 35 weeks gestation. Two, obesity, nulliparity, and chronic hypertension must be the central to risk assessment protocols. Three, we must address the 62% anemia and obesity rate as a modifier risk factor for this population. So for a future study, which will be great to see around the Caribbean, a Caribbean multi-site prospective cohort study on HDP. This single site snapshot gave a prevalence of 14.75, while in Haiti, it was 5.8%. And that is a variance that is notable. Small island sample sizes may limit our individual power, but together with sites in Barbados, Trinidad, Jamaica, and of course Guyana and beyond, we can pool data to overcome this. Together, we can identify shared risk factors and provide CARPHA and PAHO with the regional baseline data needed to fill the dearth. For my acknowledgements, I wish to thank my co-author, Dr. Heather Haywood, my research assistants and team, Miss Brittany Jordan, and also I want to thank Dr. Ashley Paris, the IRB, the Queen Elizabeth Hospital Medical Records Department, and the Labor and Delivery Ward for all the assistance. Thank you.
Thank you for that very clear presentation, highlighting some of those really concerning findings around, I think, anemia and obesity, as well as hypertension in the Barbados context.
Thank you.
Questions from the audience? Simon.
Thank you for your presentation. Very, very well done.
Thank you.
I just wanted to, because your conclusions slide mentioned the prevalence in Barbados, I would be very careful of putting up that headline because you did a sample size of 286.
Correct.
And I can't understand why then you went for every 6th note and then only sampled 100 plus. So it means that even in the site that you've undersampled. And so to make the claim and then the inferences that come from that about the prevalence in Barbados is just too far. What do you think? Am I too harsh?
No, I completely understand. So part of the project timeline, we had a lot of administrative approvals to get through. And though only 115 were included in the study, we actually went through up to 195. But because we had to look at the exclusion criteria, so a lot of persons had to be taken out. Besides that, yes, it was mainly because of the timeline that the project needed to be handed in. But as I said, I do agree that it could be misleading in a sense. However, we still can't ignore that the findings are still important in a sense. I've completed the 300, which is higher than a 289. So I definitely will enjoy following up to let everyone know what the final findings were. So thank you. Yeah.
It'd be great to see that sort of larger data set. I guess it's the difference, I think you're saying, Simon, between the prevalence in an institution versus in a population as
Correct.
well. So just being careful there. But it's important.
Understood.
Thank you for your presentation. It is not a question. In your last slide, you were hoping multi-site study.
Yes.
It is just to let you know if you want to collaborate with the French speakers and mainly Martinique, we will ease it.
Yes, because I will also mention that when I was looking for studies, and one of the main studies highlighted by PAHO on their website, the study that they had, which highlighted Latin American and Caribbean, only 4 to 5% of countries were from the Caribbean. The majority are actually from Latin America and actually the French-speaking countries. So yes, definitely. Thank you.
Yeah, good point. Back there.
Very good presentation. I'm Alex Grant, PhD student in epidemiology at the University of Pittsburgh. And I wanted to know if it is that, well, I'm not a clinician, so I wanted to know if it is that they prescribe antihypertensive medications for women during pregnancy. And then on top of that, if they do, is that something that you control for? I don't remember that's wanted to know. Or do you have
Thank you.
that information?
Actually, I did not look at treatment in my study. I'm pretty sure they were given something because we wouldn't want them to have very high BPs, of course. The medical faculty would definitely want us to say that. But I did collect other information, and that was more so driven towards outcomes. So because my study was more focused on the prevalence and the risk factors, I did though collect in my data set the outcomes like low birth weight, how many women had cesarean sections. So definitely potential for additional studies to come out of the data set that I have. Thank you.
That's great. Thanks, Britt.
Thank you.
So we'll draw this session to a close. I think it's been a very, very informative session about women's health issues. So enjoy your coffee break and hopefully warm up a bit. It's very cold in this room. So yes,
I
All right, good morning, everyone. We are going to get started. If you're here for the family health session, you're in the right place. My name is Shade Malki. I am the Director of Strategic Initiatives at the University of Michigan School of Public Health.
Hi, good morning, everyone. I am Shanti Singh Anthony, and I am the Knowledge Management Coordinator with PANCAP in the CARICOM Secretariat, and I'm a co-chair for this session.
So we're going to have our first session shortly, but a few housekeeping. Each presenter will have 10 minutes to present, followed by 5 minutes of questions. We were also told to remind you that there's a networking reception today at 5 p.m. that you're encouraged to attend. Our first section is by Dr. Owens Obewe on evaluating management strategies for late pregnancy loss, a randomized clinical trial of Georgetown Public Hospital Corporation. Dr. Obewe is an obstetrician and gynecologist at the Georgetown Public Hospital Corporation here in Guyana.
Good morning, esteemed chair, panel members, colleagues, and distinguished guests. Today, I'm honored to present my research entitled Evaluating Management Strategies for Late Pregnancy Loss. So basically, pregnancy loss is referred also as an IOFD, basically any death of a fetus beyond 28 weeks. And this remains like one of the most challenging and emotionally devastating outcomes in obstetrics practice, with profound psychological effects and also to the mother and also to the family, and also clinical implications for the healthcare also. So globally, the burden remains significant, nearly about 2 million stillbirths occurring each year, and the incidence is roughly about 3 per 1,000 births in high-income countries, and it's roughly about 21 per 1,000 in low-income countries. So the management of IUFD requires a comprehensive and evidence-based approach that includes timely diagnosis, safe delivery planning, identification of underlying causes, and also compassionate post-loss counseling, and also like considering other future reproductive outcomes. So it's hoped that these findings of this study will contribute to the strengthening current management protocols and improve the standard of care for affected women and their families. So IUFD poses a different challenge to obstetric care, and WHO defines fetal death at any point of the pregnancy. In Guyana, our age of viability is about 20 weeks. In the US, about 20 weeks and above. UK is between 22 to 24 weeks. Now, it can actually occur antepartum. It can also occur intrapartum also. There could be maternal causes. There could also be placenta causes, and it could be unexplained causes, and also fetal causes also. Now, in terms of the global rate, it's still very high. It's between 21.4. It has dropped to about 13.9 between year 2000 and 2019. It's still very, very high in low-income countries such as Africa and Asia. It's about 22.7 per 1,000 births. In Georgetown Public Hospital, between 2016 and 2020, we have roughly about 14.2 per 1,000 deliveries. So now, you go here about some medication, and it might sound very funny to some that are not obstetricians. We have something called misoprostol and mifepristol. So basically, misoprostol, the trade name are Cytotec. The street name you hear abortion pill, basically. So misoprostol, basically, what happens is it posts an E1. It binds to the uterine lining, leads to release of prostaglandins, leads to contractility and the expulsion of the fetus. Now, mifepristone is a progesterone antagonist. Basically, what protects the pregnancy is progesterone. So now, what happens? This medication strips that off, increases sensitivity of prostaglandins, leads to uterine contractility, also cervical wrapping, and that can also aid in expulsion of the fetus also. All right. So the main objective of this study was to check the efficacy in terms of comparing both the combination of mifi and misoprostol only. Also try to see the safety, whether it was safe in terms of adverse effects, and see how well the patient actually tolerated it during this study. Now, it was a prospective single-blinded control trial that occurred between 1st of January 2023 to December 2023 at the Department of Obstetrics and Gynecology at Georgetown Public Hospital. Now, we had inclusion criteria where we looked at patients that had a diagnosed IUFD with an ultrasound more than 28 weeks, a singleton pregnancy, any at least one ultrasound finding, that confirms the dating of IUFD, and patient actually consented to the trial. Now, patients that were excluded from the study was any patient less than 28 weeks, multi-fetal gestation, any contraindication to vaginal delivery, like placenta previa, any tumor obstructing, and if the patient was hemodynamic unstable, was out of the case. The patient was already in labor, a Bishop score of more than 6, was out of it, previously trying surgery, and there was any form of coagulopathy, such as a DIC. So, what happened was that we had about 70 envelopes, 35 contained the combination of MIFI and MISO, and the next 35 was misoprostol. So patients, after adequate counseling, they picked randomly, 35 out of them, which had a total of about 58 patients that actually had IUFD. Now, out of the 58, 23 were excluded because they didn't meet our inclusion criteria, and why the 35 actually met our inclusion criteria. Now, 20 of them chose the combination of both MIFI and MISO, and 15 of them actually chose misoprostol only. Now, during this study, we noted a very, very weird patient that had with some like risk factors, for example. The most common reason that we noted was that most of the patients had hypertension in pregnancy that was either not diagnosed before, never followed by the antenatal clinic. Diabetes in pregnancy was the next one also. Now, the most affected population were mostly the Afro-Guyanese and Indo-Guyanese. The least affected were more of those of indigenous or Amerindian population. Now, we had a total of 5,284 deliveries in 2023, and out of that, 58 were IUFD cases. We had a rate of about 10.97 per 1,000 deliveries. Now, those patients that chose the combination therapy of both MIFI and MISO, they had the induction to delivery time was roughly about 7.7 hours. So basically, we gave the patient mifepristone like a day before, and after 24 hours, we gave misoprostol, about 25 to 50 micrograms, between 4 to 6 hours, with a maximum of 4 doses. While patients that chose cytotegrilone, basically misoprostol, had 25 to 50 micrograms every 4 to 6 hours, a maximum of 4 doses. Now, when we compared both of them, the induction to delivery time when we used the combination therapy was about 7.7 hours compared to the single therapy was about 15.3. That was more than 50% decrease in terms of the delivery time. It was statistically significant, less than 0.0001%. So less than 0.0001. All right. We looked at the safety comparison to say, okay, the main aim was to see how much of this patient was able to achieve vaginal delivery. Now, those that chose the combination therapy, 100% of them actually had vaginal delivery, while 87% of those that chose misoprostol only had a vaginal delivery. There was no cesarean delivery due to any failure to progress or any failed induction, while only 30% from the misoprostol group had cesarean delivery. The complication was also decreased in those in the combination group. Only 5% developed postpartum hemorrhage, while those in the misoprostol group had postpartum hemorrhage within placenta endometritis. Now, what were the limitations? Now, in limitations, the sample size and the single center design. GPC is the main referral hospital, so most high-risk cases all come to Georgetown Public Hospital. In terms of protocol constraints was an issue, and also staff variability may also affect the outcome because some patients, some doctors will give 25 and some might give 50. That was not under my control. Now, the conclusion is combination of both MIFI and MISO can significantly shorten the induction to delivery time. There's lower complication rates in the combination group compared to cytotec or misoprostol. And the recommendation is actually to use the combination therapy when you have a case where you have an IUFD. I want to acknowledge my supervisor, Dr. Nacho France, Dr. Ravidia Haidial, Department of Obstetrics and Gynecology, for everything. Thank you so much.
Thank you. Does anyone have any questions? Please introduce yourself.
Yes, I'm Donald Simeon. I'm with UG. I would like to first congratulate you on your presentation, and I always like to see clinical trials being conducted in the Caribbean because we really need to do a lot more. So, excellent work. I wasn't sure whether or not the patients chose which drug they actually received. At times you were saying it was a randomized trial, but then you mentioned from time to time that patients who chose this one, what was
okay? So we had like a ballot box, basically. 35 of them was combination of Miffy and MISO. In a blank envelope with nothing, nobody knows what is there.
Okay.
And the other 35 contain only MISO poster only. So it was basically a big ballot box. Everything was shipped up together.
Okay, so it was
Nobody has an
random.
idea. You just pick up one from there, and whatever you pick from there, they will
Yes,
see.
fine. Yes, I understand now. The other question I have relates to the power of your study. You never mentioned the sample size that was calculated if you met your target. And my very last question, though, is was there any difference in the two groups, for example, age, etc.? You never mentioned how the two groups compare.
So, thank you so much. So the most affected groups was between age 20 to 34. And yeah, it was between age 20 to 34 with the most affected group. And in this case, the study number was not that much. To be honest with you, as an obstetrician, I do not want to have dead babies. It brings me joy to see more babies coming alive than dead. So at 2023, we have 58. The numbers have decreased over the years. We have more investment into our healthcare now compared to before. So we're not having as much IUFD cases compared to before. That's why we have that little amount of number. So, yes.
But you didn't do a calculation of the sample size, though?
It
that you
was
needed?
done by my statistician.
All right, thank you very much. If there are no other questions, thank you very much. Yes. Okay, so we'll move on to the second presentation. This will be done by Dr. Artemisa Hamilton. It's on the effectiveness of HPV quadrivalent vaccine in Guyanese women. Dr. Hamilton is the Director of Primary Health Care in the Ministry of Health, Guyana.
Good morning, everyone. It is a pleasure for me to speak on this topic because I'm so integrally involved in the work that is done with the HPV quadrivalent vaccine in Guyana. So this study is looking at the effectiveness of the HPV quadrivalent vaccine in Guyanese women. So just to give you a background, we are well aware at this point in time that cervical cancer is a preventable disease. We also know that early detection gives us the opportunity to provide the care that is needed so that women don't die. At this point in time, we have enough evidence from WHO and other authorities on this topic that screening is recommended for early detection and so that action can be done. And screening is recommended from as early as 25 years or earlier, depending on the local burden of the disease. The tests that are mainly utilized are the VIA, the pap smear, and the HPV DNA test. Of course, each test is suitable based on the context of your country, your economy, your healthcare system that is in place. But of this, we know that the HPV DNA test is considered to be the most reliable for the early detection. Guyana, like many of the other Caribbean countries and countries in Latin America, began their journey with the HPV quadrivalent vaccine in the year 2012. This was a beautiful journey, I must say, and for those persons, for most of the health workers, we found it to be one of the journeys in which you learned early whether you had the passion for this or not. And in this journey, quadrivalent vaccine and there was a bivalent vaccine that were available. And thanks to our partners, Gavi and PAHO WHO, the quadrivalent was made available to us as compared to the bivalent. So the quadrivalent vaccine protects against 4 strains, strain 6, 11, 16, and 18. Most of the cervical cancer cases that we know are because of strains 16 and 18. In 2024, the country would have launched a HPV voucher program, which is a part of a comprehensive cervical cancer elimination plan. Now, this was done and was made available to every woman who was 21 years and older within the context of the country. So it was available to every woman who met the criteria to receive this test. So the objective of this study would be to assess the effectiveness of the quadrivalent vaccine in preventing infections against HPV strain 16 and 18 among the Guyanese women that were screened by this voucher program. I must begin by explaining that effectiveness is done after the vaccine would have been introduced to the general public. There are two things that we measure: efficacy, which is done during the trial phase, and effectiveness when it has been introduced to the general public. So this was Guyana's opportunity to see if the vaccination that we've been doing for the past 13 years would have made a difference. So a retrospective cross-sectional study was conducted, and I utilized secondary data that would have been collected from the voucher program for the year 2024. So the data set that was collected looked at the vaccination status of the women, the regions which they came from, the number of the doses of vaccines that they received, the proportion of the vaccinated women with a positive HPV test, and the prevalence of HPV 16 and 18 among these women that were already vaccinated. And the data was then summarized using frequency and percentage in Excel, and a descriptive statistical analysis was done and employed to ensure that I could present this data to you today. So from looking at this, a total of 12,226 women did the HPV test in 2024. Of that number, 1,475, which was 12% of that, would have received their vaccines. And you can see yes and no based on what was there. What was most evident is that 85% of the women who tested reported no prior vaccination. The region who had the highest vaccination coverage would have been Region 8, accounting for 40% of the women who received vaccines. The results, we saw that a total of, for the persons who received vaccines, most of them would have only received one dose of the vaccine, which would have been 5%, 5.75. The others were less. The results across the regions, based on the strains that we see, we can see that for the voucher program, strain 16 and 18, 4.8% of the women who tested positive were positive for strain 16, and 6.1% who tested positive that were vaccinated was tested positive for strain 18. So from this study, we recognize that strain 16 and 18 were still present among the vaccinated women, and it represented 1.9 and 2.7%. Now, it should be made clear that there were 14 strains in all that was discovered among women in Guyana for the test. Now, of the percentage of the women who were vaccinated that were positive for strain 16 and 18, we would only have a 2% for strain 16 and a 3% for strain 18, which allows us to see that there was high performance of this vaccine within the Guyanese population. In 2022, also what was important to note is that from the SAGE recommendation for vaccine, they were recommending one strain, and our data shows that the largest amount of women only took one dose as compared to 2 and 3 doses that were recommended at that point in time, but we were still allowed to see that it would have still provided some amount of protection for these women. Some of the factors that we can look at that can contribute to the breakthrough infections would have been that some women, of course, only took one dose, which meant that they were still some amount of, they did not have the full coverage to be fully protected against strain 16 and 18. What we recognize also is that for the women who were vaccinated, that some of the breakthrough doses could have been because some of these women at that point in time, they may have been infected prior to vaccination. And so this would have continued. And so there was no protection that could have been offered. The single dose, according to SAGE, is still recommended for cohorts who are younger than 18 years. And that is what Guyana is utilizing currently as their vaccination schedule. Forgive me, I'm trying to get to my conclusion. So what we can conclude from this study is that HPV breakthrough infections were observed with the women who reported previous vaccination with HPV quadrivalent. We also know that the vaccination history showed that most of these women also would have only taken one dose. And so they were still not fully covered against the HPV strain 16 and 18. The findings suggest that there is high effectiveness of the vaccine among the Guyanese women, demonstrated with 98% with 98% protection and 97% protection. I must say that the limitations of this study was that most of the women would have reported, it was self-reporting, the vaccination status that they had. And also one of the limitations that we must consider is that for some of the women who never had multiple partners that remained within a faithful relationship, we would not know if the actual interaction with HPV strain 16 and 18 would provide the protection. That brings me to the end of my presentation. Thank you very much.
Thank you very much, Dr. Hamilton. We now open the floor for any questions. Questions? Oh, this was very clear. Thank you, Dr. Hamilton.
Sorry, can I
Oh.
just ask a couple?
Sorry, go, Prof.
Yeah, sorry about that. A quick question. Excellent presentation, Dr. Hamilton. I was just wondering in terms of the effectiveness, can you say what % of women with 0 vaccination, with 1 vaccination and 2 vaccination who were infected?
So I am unable to do that because we did not go that far in the study. This was just the preliminary data that we received. But thank you for raising that because that is one of the things that we want to look at.
And what was the age group of them?
So the age group of these women who received is from 21 years to 46.
Thank you. Professor Simeon? Yes.
Hi, Kunra from UE. Just for the preliminary work that you did, were there any adverse health outcomes that were observed?
Well, this goes beyond this study, and what you're asking is a part of our normal vaccination program. So we do have what is called ISAVI, in which we look for event-based, any event that would have occurred after vaccination. All of the events that we have seen over the number of years that we were doing this are in line with what is also there in the literature that exists, which is tenderness to the spot, redness, and some people would have an allergic reaction. We have not had any case for the time that I have been there, which is probably 13 years, of an anaphylactic reaction. But to be able to look beyond that, it is still work that we have to do. But we have a very, very good surveillance system as it relates to our vaccination program. And so we're able to look at this, and we have not seen anything outside of the normal among the population. And can I say something? One more time. I'm happy to report that this study would have also influenced Guyana introducing the 9th valent vaccine because we were able to see the evidence of additional strains of HPV in our population. Thank you very much.
There is one more
moderator.
question.
Could I have
Yes. Yes.
Hello. Hi, Alex Grant from University of Pittsburgh. I just wanted to know if you saw in this study variations in the effectiveness by the regions. I know you have several regions in Guyana, and I wanted to know if there is any difference in the effectiveness, but then also, is there a difference in the uptake of the HPV vaccine in different parts of the country?
So we did not see a variation across the regions, but yes, there is the difference with uptake. And that's why I told you the story is very beautiful, because we would have seen so many things evolving over the years, in which when we first started, the uptake was very high, very high. And then we saw a fallout because there was a period, because when we introduced this vaccine, it was just based on a donation that we received. And then we were supposed to purchase subsequently. At that time, the cost was very high. And thanks to Gavi, they would have negotiated and we got a better cost. So we had a very small, short period where we did not have to continue, which would have been probably like around 2030. And then the internet became very active, with the anti-vaxxers. And so by the time we started the reintroduction again, we had some amount of challenges, which would have led to lower coverages. And then we had COVID, which added to the entire message with the vaccination hesitancy. But luckily, the Ministry of Education has been so instrumental. And not just the Ministry of Education, the President would have been extremely instrumental in insisting that HPV had to be one of the priorities. And when we have the commitment and the buy-in and everyone speaking on the topic, you have persons becoming more acceptable. And so for some of the communities where we did not see that uptake, we saw it happening again. And I must add that one of the things that really would have aided the cause with getting better uptake would have been the fact that the vaccination team is very dynamic. They started doing house-to-house vaccination, and they saw going to people's houses and speaking to parents in their setting allow them to accept the vaccine as compared to when you were doing it only in a school setting. Sorry, they said stop, but I could talk on this for hours.
Yeah.
Meet me afterwards.
Thank
I
you.
will continue.
Thank you, Dr. Hamilton.
I have a question. Hello?
So we'll take, sorry.
Hello?
to-
I have one
Yes,
quick
Dr.
question.
George. So I will also have to give the floor to Dr. Arifa. So go first, and Dr. Arifa, you'll be the last question. Dr. Hamilton, sorry, there are lots of questions for you. But we'll try to make them as brief as possible, okay?
So could I
Oh.
go ahead?
So Dr. Hamilton is willing to take them during the break. That's okay with you? Yeah? Okay.
Thank you. Our next presentation is from Ms. Hallie Miller on improving protection against and understanding of human papilloma virus infection in the Cayman Islands using a multifaceted approach. She is the Policy Support Officer within the Ministry of Health and Environmental Sustainability for the Cayman Islands. And I apologize, I only have.
Not to worry, not to worry. Thank you. Good morning, everyone. I'm Rachel Corbett, a national epidemiologist in the Cayman Islands. This is Hallie Miller, my colleague, and we both work in the Ministry of Health, Environment and Sustainability. The slides are available. Wonderful. Thank you. So we're going to be presenting on improving the protection against and our understanding of human papillomavirus infection in the Cayman Islands using a multifaceted approach. So some of what we've already heard, as you know, human papillomavirus, HPV, is a group of viruses that infect the skin, the genital area, and the throat, and transmission is primarily through sexual contact. These are often asymptomatic infections that naturally resolve without the need of treatment. However, persistent infection with high-risk types of HPV can result in cervical cancer. As we've heard, we have a very effective prevention tool of the vaccine, which is the latest development is the non-covalent Gardasil 9, which looks at protecting against 9 different genotypes. And as we've heard, this does include 16 and 18, which account for around 75% of HPV-related cancer. The World Health Organization recommends that the vaccines are administered before the onset of sexual activity. As we heard from Dr. Hamilton, there were some studies done recently that has shifted the advice that a single dose can provide comparable protection to the multi-dose regimens. So a little bit of context on the Cayman Islands. We're a group of 3 islands in the Western Caribbean with around 89,000 individuals, mostly residing in Grand Cayman. We're slightly unique in that Caymanians currently make up 46% of the population, so over half of the population are expats. We introduced our HPV vaccine initially in 2012, which was also the quadrivalent vaccine. This was targeted at females aged 12 to 14 and delivered through 2 of the public high schools. However, the uptake from this time wasn't actually known. So we undertook a piece of operational research with a kind of 3-pronged approach. Firstly, we looked at reviewing and updating our vaccine program approach. So we did an evaluation in 2023, and in the 2 subsequent campaign rounds in the schools, we made a series of step changes. So we brought on Gardasil 9, and this was available in May 2024, which was targeting the 2003 to 2004 school intake. We also offered this to all of the schools on island, of which there are now 16 high schools. And we expanded the eligibility criteria to be both males and females. And then over the summer, we made a few more adjustments before the campaign restarted for the next school year of 24 to 25. And we updated our dose regimen to be 1 dose of Gardasil 9 for those aged 9 to 24, and to be 2 doses for those up to the age of 45. We did a really big comms campaign and vaccine drive in the schools for the build-up of that second campaign, attending parent-teacher associations and the like. We also shifted the consent form to be an online electronic form, and what that enabled was the public health nurses to have real-time access to the data so that they would know as soon as someone in their school had given consent, they could then arrange the follow-up and administer the vaccine. 2 other methods that we included in our research was looking at the uptake to see what we could establish. We've focused this on Year 7 students as they became eligible for the campaign. So we're looking at those 2 school intakes, 2023 to 24, and the second one, 24 to 25, by school and by sex. Where there are schools with a very small cohort in Year 7 of under 50, we just group those schools together. And then additionally, we've also introduced genotyping surveillance. So this has been through a PCR assay that the Cayman Islands Molecular Biology Lab symbol has onboarded, and it detects HPV types 16 and 18 individually, and then the other high-risk types that it tests for are in grouped targets. And we've analyzed this data from January to November 2025, looking at the individual level and also looking for any co-infections of multiple high-risk HPV strains. So moving on to the results. What we found, this graph shows the uptake in those Year 7 cohorts. The dark blue is the 23 to 24 year, and we found there was an uptake of 32% overall among all Year 7 students. And in the light blue shows the next round of the 24 to 25, which unfortunately we had a drop down to 17% uptake. The second takeaway from this graph was also looking at it by sex, and it was really reassuring to see a really similar uptake among males and females. It was slightly higher in the first year among females of additional 4%, but in the second year, there was uptake was exactly the same. So that was great to see. We then also looked at the coverage by school, and this is where we saw a lot of variation, the dark bars again being the earlier year. And you can see schools A, B, C, and D all had a much higher uptake in the 23 to 24 than the 24 to 25 year. However, E showed the opposite trend, and the second year they managed to improve the uptake, and F, it was similar in both school years. I'm going to pass over to Hallie for the rest.
Okay, so on to our HPV genotyping results. So in our sample of 1,503 patients, the high-risk HPV positivity rate was 16.8%. HPV 31, 39, and 59 was the most frequently detected genotype target with 5.5 positivity, followed by HPV 35, 58, and 66 at a 4.9 positivity. So the table there gives you a full breakdown of the genotype targets, the number of positive samples, and the respective positivity rates. So among HPV positive patients, the median age at sample collection was 34 years. And to highlight here, we found that 21% had a co-infection. So this was detecting at least 2 high-risk HPV genotype targets. 4% tested positive for 3 high-risk HPV genotypes, and around 1% tested positive for 4. So overall, the access did improve in both the 2023 to 2024 campaign and the 2024 to 2025 campaigns through firstly increasing participation among schools. So there were only about 2 schools that did not participate. And secondly, by adapting the program to be universal to include both males and females. However, we do note that there was a notable decline in the uptake from 2024 to 2025. In addition, HPV protection, of course, improved through transitioning to Gardasil 9. We also improved surveillance by monitoring vaccine uptake. So stratifying by school identifies where uptake is lower. And again, through that real-time consent form, understanding what's going on and the patterns and uptake among the schools. Also improving surveillance by the high-risk HPV genotype testing through our molecular biology laboratory. In comparing our findings to other regions in the Caribbean, we found in terms of vaccine uptake in 2023, similar results in the Bahamas and Trinidad and Tobago. And in relation to high-risk HPV positivity rates, again, similar in Martinique. There are a few limitations, of course. Firstly, our coverage estimates don't fully capture all age groups. So particularly older students weren't reflected in this analysis, as well as older adults. We are working to now generate that under 15 immunization uptake, which would be in line with the WHO indicator. Secondly, we have a limited understanding in the drop in uptake in the 2024 to 2025 vaccine campaign. Our thoughts are sort of that we did have 2 vaccine campaigns that were close together. Maybe that had to do something with it. And then in addition, vaccine hesitancy was seen particularly among certain subgroups of the population. Of course, further research and qualitative studies will be needed to inform this uptake and hesitancy moving forwards. Finally, our high-risk HPV positivity rates are not nationally representable. So the data that we presented reflects clinical samples which are processed in our public hospital and have a limited number of samples from private providers because we have our private providers sending tests overseas, for example, so that wouldn't be included. And further clarification of positivity rates will be available when full sequencing is conducted, so we'll be able to better differentiate among those HPV genotype targets. To conclude, improvements have been made to our national HPV immunization program with regards to access and availability. Surveillance of uptake in high-risk HPV genotyping has been successfully implemented with data informing ongoing vaccine efforts. Further work, as I mentioned, is needed to align with international indicators and to understand vaccine hesitancy. Just to say, this is the first sort of work we've done in understanding the different high-risk HPV strains circulating in the Cayman Islands. So that's an accomplishment. And that leads me to my acknowledgements, where we just want to thank our public health team, including our school nurses, our molecular biology and laboratory team at Symbol, and the schools for participating. Thank you.
We have a couple minutes for questions. Do we have any questions from the audience?
I was surprised to see the similar uptake between sexes, especially due to a recent uptick in vaccine hesitancy and a potential for a what's in it for me mentality among males. I was wondering if you had any idea of what encouraged that similar uptake between the sexes.
Sure, great question. Thank you. We did try to put a kind of strong comms campaign alongside bringing the Gardasil 9 on Ireland and making that change for males and females. But it was a welcome surprise to us that it was so similar. I was expecting it to be lower. So we haven't done any kind of qualitative work after the fact to kind of ask what the attitudes and perceptions are. So that would be really interesting. But so I can't offer too many insights. I just hope it was a successful comms campaign.
Our next question. Your mic is on. Do you have a question or no? Yeah. Sorry. No. Okay. Could you turn it off though? Thank you. Go ahead.
Thank you. Thank you so much for that very enlightening and interesting presentation. I was just wondering, oh, by the way, Kali Radix from Austin University. I was just wondering about how vaccine rates in general over the couple of years compared to what was happening with HPV. Because I know we've approached, well, we've had different approaches, but we've approached HPV as an opt-in rather than an opt-out, which has been most of our childhood vaccines, for various reasons. But I just wanted to know if you looked at all at trends around general vaccines and if those shifted as well.
Sure. So, I mean, we fortunately have quite good coverage in our childhood vaccine campaign generally. I think with HPV, we do have quite conservative views in the population generally, and there are concerns around if my child's getting this vaccine, that I'm saying it's okay for them to be sexually active at a younger age than I would choose for them to be. So I think that has historically been where some of the hesitancy for it has come from, and where some schools have flat out said to us, we're not offering this program in our schools. So that's something that we're kind of ongoing looking to try and address. I think the way that we targeted this campaign was very much like, this is a highly effective prevention for cancer, and steered clear of that topic. I'm not sure if I'm really answering your question, but we generally have good uptake. I think while we said we didn't know the uptake before, there was a feeling that in the schools where it was happening, it was maybe 15 to 20%, but those were very rough indicators, and that was only a couple of the schools.
Thank you. And our last question.
Thank you, Gloria Geraldo. I'm with PAHO, and thank you for a wonderful presentation. The question is, just to clarify, the coverage among the target population for the years 2023, 2024, and then 2024, 2025 represents a substantial reduction. So that one is you're continuing to monitor the same target school, but these are just the schools. Let's say population-wide at the health centers or others. Do you have any of those numbers to compare? And is the campaign still going on to try to bring at least to pre-existing levels the coverage? Thank you.
Some great questions, thank you. Yes, so this is an ongoing campaign in our schools every year, and it does run the whole year round. We have been closely monitoring it this year to try and hope that we can bring it back up, and preliminary analysis a few months ago showed that it was back at that kind of 30%, 35% rate we saw in the first year. So we're encouraged that we're going in the right direction, and hoping as the year continues that we'll get it a bit higher. It is our whole target population is broader than just the schools. Tracking uptake among that broader group in the population is quite difficult in terms of the denominator data, but also in terms of the data management of where that's recorded across private, public providers, because the school element side of it's a lot easier to monitor because we have our public health nurses in the schools, and they do a really great job with the data management. We find it quite difficult to gather that data across the population otherwise.
Thank you so much.
All right. Thank you very much. It's really good to see so much interest in the HPV presentations. If you have any additional questions, feel free to have them answered by our presenters in the break. And so moving on to the next presentation, I invite Mr. Mustafa Drame, who is the director in the Department of Clinical Research, University of Martinique, and he will be presenting on self-rated health as a predictor of short to long-term survival in older Afro-Caribbean hospitalized via the emergency department. Mr. Mustafa Drame.
Thank you very much. Good morning, everybody. I expect your understanding and your kindness because English is not my native language, so I will try to do my best. So I am glad to share the result of our study about self-rated health as a predictor of short to long-term survival in all the Afro-Caribbean people in Martinique. So I do not have yet any conflicts of interest. If you have good tips, you can tell me. So geriatricians used to implement multidimensional assessment, including social demographic characteristics, clinical ones, biological, social, environmental, etc. This helps them to determine the prognosis of the person. And assessing the prognosis enables to identify the most vulnerable subjects to define the best targeted treatment options. So in the literature, we have a lot of mortality risk scores. Often their performances are questionable and they take little account of what we call subjective health. The objective of our study was to determine whether self-rated health was an independent prognostic factor of short to long-term survival in all the patients admitted to an acute care unit for older people. It was a prospective cohort study at the University Hospital of Martinique. People were recruited in the Department of Acute Care for Elders, and all data were collected by geriatricians. To be included in the study, the patient had to be at least 75 years old and admitted for an acute condition. When they refused to participate, when they were relevant of palliative care or intensive care unit, or when they died before assessment, they were, of course, excluded from the study. We gathered a lot of data, including demographic characteristics and characteristics obtained through the comprehensive geriatric assessment. For self-rated health, we just ask a simple question. Overall, how would you rate your health on a scale from very good to very poor? When they answered very good or good, we consider they had good self-rated health. For statistical analysis, we implement descriptive ones, bivariable analysis, and we use a multivariable Cox regression modeling using a stepwise selection method. Results are presented as hazard ratios and their respective 95% confidence intervals. So in all, we 371 older adults were admitted to acute care for elders unit. Among them, 84 were not eligible, and among 287 were eligible for inclusion, and among them 60 was aphasic, and 4 of them had missing data for self-rated health. In all, 223 people were included for analysis. Mean age was 85 years. It was geriatric patients. Most of them were female. That's normal at this age. Men die quicker than women. I don't know why, but no, I have an idea. So we have 71% were living alone, and 86% were dependent for activities of daily living. 50% had dementia syndrome, and a lot of them, almost of them, 95% had denutrition. These are the mortality rates through the different time points, going from 15% at 6 weeks of follow-up to 57% at 36 months. For short-term mortality, it was 6-week mortality. When adjusted for age, sex, the fact of living with a partner or not, the fact of living in an institution, when adjusted for dependency, for risk for falling, malnutrition, and the comorbidity, self-rated health proved significantly associated with mortality. Those who had medium to poor self-rated health died 2.6 than those who had good self-rated health. These results are similar. This result was the same for 6 months mortality, for 1 year, 2 year, and 3 year mortality. At each time points, when adjusted for the confounders, self-rated health, but self-rated health increased the risk for dying. So self-rated health was the sole independent risk factor at all time points when adjusted for the others. It is a simple indicator based on patients' experience. So we can use it even in limited resources context. This provides a comprehensive assessment of health, function, psychology, social context, environmental, etc., etc. We think that it should be systematically incorporated into geriatric assessment. Prognosis assessment in acute condition is crucial to providing targeted care in elderly people. Numerous tools, but fair predictive performance already exists in the literature. In this study, we show that self-rated health is an independent risk factor even when adjusted for the other factors, and it should be integrated in routine clinical practice. Thank you for your attention.
Thank you, Mustafa Drami. Questions on self-rated health? We have time for maybe 2. Anyone?
That's great for me.
You did very well. Thank you very much. Yes.
Okay, our next presentation will be by Dr. Dion Thurston Dorset on factors associated with quality of life among elderly Bahamians attending selected primary care clinics in New Providence, Bahamas, a cross-sectional study. Dr. Thurston Dorset is the medical officer for the Department of Public Health in the Bahamas.
Thank you so much for your introduction. And I thank you for this opportunity for me to present my family medicine DM research. So just to get started, you may or you may not know that the world's population is aging. And it's not just aging, it's growing at an unprecedented rate. By the year 2050, the United, and for the first time in the world's history, this elderly population will outnumber children ages 5 and younger. Oh. Okay. So this demographic shift is also occurring swiftly throughout the Caribbean, in both our young and old age profile countries. The Bahamas sits right here between Jamaica and Barbados, and we are projected to see our elderly patient double between 2023 and 2060. Population aging is a significant global burden with a complex and unique set of challenges to many aspects of society. And there is a global initiative focused on keeping the elderly healthy, functional, independent, and contributing to society. Efforts are being made to improve or maintain quality of life with this trend of increased life expectancy that we are seeing. So the aim and objectives of our study was to assess quality of life among elderly Bahamians attending public primary care clinics in New Providence, to describe our study participants' socio-demographic characteristics, and then explore factors associated with quality of life among our seniors. To achieve this, we conducted a cross-sectional study in New Providence, Bahamas, our most populated island, and it was done between October 2024 and February 2025. Patients aged 65 years and older were recruited using a convenient sampling approach from 5 selected public primary care clinics that serve the length and breadth of New Providence. Our instrument was a 2-part researcher-administered survey. The first part of our survey collected our participants' socio-demographic characteristics, and the second part was our quality of life measure, which was the Older People's Quality of Life Brief. This questionnaire was the short version of our OPQOL 35. It's a validated, highly reliable tool with a Cronbach's alpha of 0.856. This tool has a self-reported global quality of life rating, along with 13 statements that cover 7 domains. Some of these areas were home and neighborhood, financial circumstances, and health. So our participants were asked to indicate their level of agreement with each statement, and the items were summed up for a total quality of life score. We then used these quality of life scores to determine their quality of life category. Higher scores indicated a higher quality of life. For our data analysis, we did enter all of our data into REDCap, and our data was analyzed using Stata 16.1 software. We started out by doing our descriptive and summary statistics, looking at our data distribution, and moved on to conduct 2 sample t-tests, which were used to compare the main quality of life scores of our dichotomous independent variables. We conducted a Pearson's correlation test to assess association between age and quality of life, and then moved on to do a bivariate analysis using linear regression, and that was used to assess association and direction of relationship between quality of life scores and our socio-demographic variables. A multilinear regression model was then constructed using our bivariate results to identify predictors of quality of life. Oh, sorry. Oh, there we go. Sorry about that. So 367 seniors participated in our study, and the majority of which were female. Participants' mean age was 74 years. Oh. The largest proportion of our participants were married, living with family, and had a secondary education. The majority of our participants were living in uncrowded conditions. They were retired, and they depended on a government pension as their primary source of income. Majority of them did not use alcohol within the last 12 months and did not have a fall within the last 12 months. 92.4% of our seniors had a medical illness, and our top 3 medical illnesses seen were hypertension, diabetes, and arthritis. Approximately 31% of our participants had at least 2 medical illnesses, and just over 10% had as many as 4 to 6 medical illnesses. Most of our seniors rated their global quality of life as good, and majority of them had a fair or better quality of life. Our participants scored highest and were most satisfied with aspects of life in the psychological and emotional well-being domain, and they were least satisfied with aspects of life in the financial circumstances domain. Statistically significant differences in our mean quality of life scores were observed between individuals with and without CKD, CVD, dementia, and depression. The red bars in this slide indicated our 6 factors negatively associated with quality of life, and the green bars indicated our factors positively associated with quality of life. For our multivariate model, the red bars here display factors predictive of a lower quality of life, whereas our green bars in this slide indicate factors predictive of a better quality of life. So in summary, this research highlights the quality of life among elderly Bahamians. This research highlighted the quality of life among elderly Bahamians participating in our study. 95% of study participants had a fair or better quality of life, and this was better than we had hypothesized. There were a number of socio-demographic, medical, and socioeconomic factors influencing quality of life in this population. Both marriage and living with families were factors predictive of a better quality of life, and both of these factors usually promote well-being by providing emotional, financial, and caregiving support, all which enhance quality of life. Education emerged as a key protective role in quality of life in this population. Education improves health literacy, it supports income generating capacity and lowers poverty risk, and helps preserve independence in later life. For the sake of time, I will highlight the impact of CNCDs and medical illnesses, especially depression, in our data set. CNCDs are on the rise globally, and majority of our participants had between 2 and 6 medical illnesses. Multi-morbidity presents a significant health challenge and negatively affects quality of life in the elderly. Unfortunately, depression is often underdiagnosed and untreated in this population, but we saw that it had a detrimental impact on quality of life. This, due to the nature and the design of our study, it was subject to limitations, and some of these included selection bias, desirability bias, and recall bias. We also were restricted to New Providence and only looked at patients within the public sector. For future studies, we would like to expand this study to the Family Islands, our more rural areas, and also use the expanded version of our tool, which includes a culture and religion domain. In conclusion, we see that population aging is a global demographic phenomenon. And these findings highlight the need for a multi-dimensional approach to programs and guided policies to address these critical factors in order to maintain or enhance quality of life as our populations continue to grow. Thank you for your time. I'd like to acknowledge my advisors, my supervisors, and the research team. Thank you.
Do we have any questions?
Arifa Aladdin, University of Guyana and Georgetown Hospital. I want to applaud you for doing a quality of life study. This is an important thing that we need to focus on in the Caribbean and to make it primary outcomes of study. As a kidney specialist, I saw that you have CKD there as your number 2 for non-communicable chronic diseases. And I know as physicians, we tend to focus on clinical factors, your creatinine and dialysis and all of that. And we tend to not measure quality of life. Consistently across studies, quality of life actually makes it at the top of the list for patients with kidney failure rather than their medication adherence and all of that. So congratulations, and I hope as CARPHA, we prioritize quality of life as outcomes when we do research. Thank you.
Thank you.
And we'll take one more question. Saw the mic there. Can you go first and then we'll let you go? Yeah.
All right. Is she gonna go? Am I gonna go? All right, go ahead. Oh, okay. Well, she got started. Just very quickly. Camille from Ministry of Health and Wellness, Barbados. Again, I want to commend you as well. I think it's a really, really good study. I work in NCDs, and obviously I live in Barbados, and that is a lot of old people. So I am very happy to see it. But I saw that the majority of your sample group were women, right? Do you think, I think it was like 60,
around 63%
to
women.
30, right, to 30 something percent men. Do you think that the quality of life indicators that you saw, do you think that that's like represented? I know you said you had selection bias. I understand that part as a limitation, but you know, women are traditionally persons who go to school, who live with family, etc. Do you think that if it is you had more men, that some of your indicators would have like shifted a bit more? If you get my question.
Well, thank you for your question. We did have more women represented in our study, and women on the whole, I think we have more women in our population, more women utilize the public health clinics. I think your questioning is asking that if we had more men represented, whether it would have shifted the differences in our predictors and our associations with quality of life. Maybe, I can't say. I can't say for sure, but that could be quite possible, and it would be interesting to do further studies in maybe areas where we do see more men utilizing certain clinics to get more of their input in a study like this. Thank you.
Please ask your question.
Yes, thank you so much. Congratulations, a
Thank
very
you.
interesting study. My question is kind of similar to hers. You did a convenient sampling, Benny. Why? Why didn't you choose to do random sampling?
Thank you for your question. We chose to do a convenient sampling approach for a couple of reasons. One being the availability of our study population. We went into our polyclinics, our geriatric clinics, and also a family medicine clinic. And we had to basically recruit those seniors who were there. And because we had such a large sample size that we were trying to make, our minimal sample size was actually 474. So we didn't have the privilege of randomly selecting. We wanted to try to gather as many of those seniors as we could.
May I just quickly follow up? So your clinics didn't have like a list that you could have perhaps done something systematic, like you started off with one and then the fourth person afterwards?
No, ma'am.
Not at all.
No, there was no appointments at the time. So we took whoever came to clinic that day, we approached them, we got informed consent. If they were willing, we said, okay.
Thank you. For the purposes of time, because we are running behind, we have one more presentation, so
Thank
save
you.
questions. Thank you.
Yes, thank you very much. And again, you will have some time to interact with our presenters. Our final presentation is on integrating muscle damage, immune function, and electrolyte balance biomarkers for early detection of training stress in collegiate athletes during preseason in Jamaica. And I invite Fabian Miller, lecturer at the Michael University College in Jamaica.
Thank you. Biomarkers provide an insight into physiological response in training. Creatine kinase increases during early preseason, reflects muscle damage and adaptation. Muscle soreness is not necessarily a reliable indicator for muscle damage. So basically how you feel after training doesn't necessarily mean that there is muscle damage. So what we do need is a more objective biomarker to assess muscle damage. Many athletes, biomarkers fall outside of the standard clinical ranges, and this is because athletes are considered as special population. So while results for normal persons would be, while clinical results would be normal for some persons, an abnormal result for an athlete could be considered normal. We're looking at muscle damage markers, creatine kinase, lactate dehydrogenase, immune markers, lipid markers, and high inter-individual variability in athletes. Need for sport-specific and context-specific interpretation is required. So as I said, during preseason, a rapid increase in training load is done, and preseason is an excellent monitoring window to assess these athletes. Risk of insufficient recovery may be present. So we have muscle damage, immune suppression, metabolic strain during this time. Key muscle damage markers, again, as I stated, we'll be looking at is creatine kinase and lactate dehydrogenase. So what is the aim of this study? One, we are going to investigate the distributional characteristics of biomarkers. We looked at the interrelationship among biomarkers and integrated predictors of training stress. The population, of course, male and female athletes, and the main focus is to detect the early detection of training stress during this period. So the design correlation study of 59 collegiate athletes was done, mean age 20.6 age, and athletes were drawn from seven sporting disciplines, including cricket that Guyana loves, football and volleyball. So some of the biomarkers that we assessed are stated right here with the normal reference range. So for muscle damage markers, we look at creatine kinase again, lactate dehydrogenase. Where immune markers are concerned, we looked at neutrophil, lymphocyte, monocytes. Where the electrolytes are concerned, look at the sodium level, potassium level, chloride level. And for renal function, we look at creatinine, magnesium, calcium, and so forth. So blood samples were collected venipuncture, conducted during preseason training phase. A laboratory analysis was performed using a Cobas Pro analyzer, and data was analyzed using SPSS version 25, and statistical significance was set at 0.05. we look at the relationship between the biomarkers, as I stated before, and along with the predictors of training stress. So what we found is that there is a large presence of muscle damage taking place where you see creatine kinase, 96.8% of male had results above reference range, while 71.4% for females. And for latent dehydrogenase, you have 87.1 elevation, and for females, is 60.7 elevation. And you can see where the female results is trailing the male. Particularly males have more muscle. They tend to train harder. So it is expected that they would have some more damage than the female. Not saying that female doesn't train hard. They do as well. But we also found that while CK increases, there is a positive correlation with LDH, white blood cell counts, sodium, and creatinine. Also, we see there's a negative correlation with lymphocytes. So as CK increases, the lymphocyte decreases. Other relationship that we saw was white blood cells. Again, there's an increased uptake with the neutrophil, along with a downregulation of lymphocyte. A strong inverse relationship between the both. For the renal function, we see where chloride and bicarbonate has an inverse relationship, and urea and creatinine has a positive relationship. Some of the predictors for creatine kinase. So we see again LDH, magnesium, creatinine increases while CK increases. And for lymphocyte and potassium, there's an inverse relationship. What are the take-home messages? So again, there's high prevalence of elevated muscle damage that was found. There's evidence of immune system involvement and electrolyte and renal markers linked to training stress. CK is influenced again by a multi-physiological system. So while training is seen as a mechanical thing, there are other systems that are very involved and important. So we see again, training produces multi-system response, not isolated changes. CK is strongly associated with LDH, which confirms muscle damage and metabolic stress. We see that CK is positively associated again with white blood cells and also associated with sodium and creatinine. So the regression identified key predictors for CK: LDH, lymphocytes, magnesium, potassium, and creatinine. Limited research was done. We have found that limited research and integrated relationship for muscle damage, immune markers, and electrolyte renal markers, especially during high-low preseason training. So again, there's a need for this type of multi-system approach. In conclusion, preseason training leads to elevated muscle damage marker, coordinated immune response, electrolyte and renal interaction. For the future study, we hope to conduct a longitudinal study, track more biomarkers over time, include training load and recovery measure. We also wish to develop an individualized athlete profile, expanding monitoring framework, for example, athlete biological passport, where we could include, again, muscle, immune, and electrolyte markers. I would just want to thank my supervisor, Professor Magroda, and the rest of my team. Thank you. Any questions?
All right. Thank you, Fabian Miller. We have, so go ahead. Thank you.
Thank you for your presentation. What was the population you looked at? High school, professional?
College. Was college. And many of these athletes are, while they're in college, but they are national representative. So they are considered amateur, but they're this close to being pro.
Thank you very much.
Thanks for the presentation. A couple of questions. One is the reference range that you use. Did you use a reference range that's based on our Caribbean population versus the reference range? Because a lot of the reference ranges are designed and adapted from the white population. And so if you put it into the Caribbean measures and you put average and above normal, sometimes they don't correlate well. Do you have like means and standard deviations for your actual numbers for LDH and creatinine kinase?
Yes, thank you for that question. So the reference ranges that were used, the laboratory at University of the West Indies, that is what those are that is where the tests were done. I'm not sure if they are culturally specific. My professor will.
It was, afternoon everyone. So it was developed from our populations. It's a Jamaican population developed reference range.
Great, thanks for that. And then my second question would be, what would be the so what? So now that we have this data and we know what's happening, what would you advise or where would we go from here? I know I've seen your next steps.
Yes.
But in terms of reality, I know that if you read the news up to this weekend, we've seen the marathon that was in Europe. We had quite a few people were hospitalized at the end of the marathon, fluid and electrolyte imbalances. So how does this correlate in real time and in the population?
Yeah, thank you for that. So yes, while the study was on athletes, many of these implications could be, associated or spread to normal population, because we have persons who we call weekend warriors. Maybe that's a result why they ended up hospitalized, because they are not really trained to take on these events. So to answer your question, repeat the last question again.
Sorry, I was just
So-
asking in terms of what would you do with this information? What would be your next steps? And if you were to advise an athlete?
Yeah. Right. So the education is important. Awareness is key. So the athletes, not just the athletes, but the coaches as well, who really organizes and run everything around the athlete, would be informed that while during preseason, where most of the load is concerned, they're coming out of off season, tailor the training program specifically, pay a little bit more attention to hydration, pay a little bit more attention to if they're getting sick easily and so forth, because as you see, there is immune response or activation taking place. So they could be prone to a cold or a flu, but so they could, my advice is to pay specific attention individually, again, to the training load, so as to promote more performance or better performance and to reduce risk.
I have one other comment.
Sure.
You said it was positively correlated with sodium. Was it high sodium or low sodium?
A good question. I'm not sure. We'd have to double check that.
Because that's really important. What happens is they hydrate with water while you lose salt and they become very hyponatremic, which is sodium drops very low, and that's one of the reasons why they decompensate.
Right. I often tell athletes that once you are active over an hour, you need more than water because you'll be losing salt. So yes, that could be an impact. All right. Thank you.
All right, thank you very much, Fabian. Thank you very, very much. This brings us to the end of this session. Please let's give a round of applause to all of our presenters. I think this session gave us a really good, diverse set of presentations, starting from the younger age with HPV to our last presentation among our young adults, and then being able to discuss quality of care in the elderly population, so across the lifespan. So thanks to our presenters. I don't know where this is, but okay, so 1 second. Just a kind reminder that on the screen at the beginning, there was an announcement of our networking sessions at 5 p.m. this afternoon. So please feel free to join. Yes, thank you very much. Please feel free to join the networking sessions. And finally, I invite you to come back at 1 p.m. We'll break for lunch. I invite you to come back at 1 p.m. to listen to the guest lecture from our CARPHA awardee, Dr. Moti Ramgopal.
They also ask that you enter to the win big by doing the conference evaluation. So scan the barcode on the back of your name badge, scroll down to the end of the web page until you see evaluation survey, select AHRC Day 2 survey and enter your conference registration ID that's located on the front of the badge, and scan the QR code below to start the survey. And then, of course, if you need credits for CME, apply for credits and then select submit. Thank you.
Thank you. Thank you. Good morning, Dr. Please don't let us stop here. Oh, no, no, no. I know people get excited and then they stop. So please don't let us stop here. Because I can see how they have such a great impact on the next like this being your thing or connect. Don't drop it. No.
What was the question? What was the question? What was the question from Mr. Bass? Didn't answer the question? Yeah. You did well, sir. You did well. You did well. You did well. You did well. But they're not gonna pick up. You just move on. You'll see me again.
Don't drop it, don't drop it. If it's
Thank you. You're welcome.
Move. Oh. What's I must do? I'm gonna pretend. All right.
Users. Users.
Alfonso.
Catch the flag. Oh.
Testing. Good afternoon, everybody. My name is Dr. Caroline Allen, and as somebody who's been involved in HIV research, it's especially an honor for me and a pleasure to introduce Dr. Moti Ramgopal, who is a Guyanese American infectious disease physician, global HIV researcher, and founder of Midway Immunology and Research Center, as well as Midway Specialty Care. He's led more than 250 clinical trials and authored over 200 peer-reviewed publications, contributing to advancements in HIV treatment and prevention worldwide. His work focuses on expanding access to innovative therapies for underserved and diverse populations. Through an integrated model of research and patient-centered care, he has helped bring cutting-edge treatment to communities across Florida and the Caribbean. At CARPHA, Dr. Ramgopal represents a strong commitment to regional collaboration, innovation, and equitable access to life-saving HIV care. So welcome to our CARPHA awardee, Dr. Moti Ramgopal. Thank you.
Good afternoon, everyone. Thank you for the kind words of introduction. I was reintroduced to CARPHA a few years ago after a long time being in Florida, not being, attentive to local works. And the introduction by Dr. Ramdat was very helpful. But the work that Dr. Indar is doing as well is very, very impressive. And it's indeed a pleasure to be here this afternoon. It's better? Is that better? Okay, thanks. So who am I? And many of you in the room probably don't know much about me. I'm an infectious disease physician primarily. First started a clinic, a small single clinic in Florida back in 1999, for which I do antimicrobial stewardship at several hospitals. I work at Cleveland Clinic hospitals as well. Antimicrobial stewardship, infection control, as well as sepsis management. That's one hat I wear. And then I put on another hat, that's a research hat. I founded Midway Research back in 2004, and as mentioned, over 250 clinical trials, some of which I'll describe to you. Then I wear another hat as clinical professor of medicine at Florida State University, and I mentor and teach students there. Then there's another hat, one more, and that's when I started Midway Special Care Center back about 12 years ago, in understanding the care that's struggled with underserved communities. And now that clinic has spread significantly throughout Florida, leaving a footprint. As consultant to Gilead and ViiV, I advocate for pipeline drugs, and I'm in the Bureau for addressing pipeline drugs. There's another hat I wear. I do a lot of speaking. I travel around the United States, going to communities and having speaking engagements about that. Next slide. Stuck. Anyone up there? Did the battery die? No. Oh, here we go. So when I look at my career, there are individuals in my life, many individuals, but there's two individuals of note that I would like to respect today. The first is Dr. Perry Gomez. I completed my internship after leaving Jamaica. I went to Bahamas for a few years. And with Dr. Perry Gomez, he introduced me to the world of infectious disease. And the second person is Dr. Benny Balkaran, who has been a mentor for me since I was very young. And throughout my career, he's supported me and guided me. My career, I will reflect on it, is built on compassion, lots of innovation, thinking out of the box, creativity, and entrepreneurship. As we heard yesterday, that's a driving force sometimes. And of course, self-belief. We can look at research, building research capacity. We look at innovative strategies to end HIV care in the Caribbean. And then we're going to ask the question, how can we end HIV in the Caribbean? And is it doable? I mean, you're hearing more and more about ending HIV care. There's a time when we said we just need to level off HIV, and that has happened. We have done that for 4 years now, 5 years, and now we're saying, how can we now? We have the weapons, and we'll describe that shortly. But there's several sparks that fed the flame, several sparks. What were those sparks? One, when I was in fellowship at the University of Miami, I was introduced to clinical trials. Learning and recognizing that new medications are necessary and essential. I started working, in that space, and I always felt that I would like to continue doing that throughout my career. But after 1997, I returned to Guyana in 1998 for a short period of time as consultant at Georgetown Hospital. And after several months, I recognized that I think I'm better suited for a return to the United States and forge my way through. Return to the United States was not easy. It was a challenge. I looked at many job opportunities, and I finally decided to settle in a place called Port St. Lucie, which at that time, unbeknown to me, had the highest rate of HIV in the state of Florida. Now, as a result of the work we've been doing, it's among the lowest rates in the state of Florida. During this period of time, I spent about 4 years coming back to Guyana from 2008 to 2012, and I was introduced to PEPFAR by Dr. Redfield, former CDC director, and learning about program management, learning about budgeting, learning about pipeline chain supply of medications. This is where I learned that. So when I went back, I took that knowledge and developed an organization called Midway Special Care Center. This is what it looks like today across the state of Florida, from Jacksonville to Key West. It all started in Fort Pierce and Port St. Lucie, and now we have over 25 clinics. I'm truly trying to build the strongest HIV organization, truly trying to build the strongest infectious disease organization in South Florida and even beyond. Currently, we have physicians in multiple hospitals, about 12 hospitals, from Jackson Memorial to West Palm Beach and to St. Lucie County. But when I look back at the evolution of HIV therapy, and you reflect in your life when you're using AZT and 3TC and D4T, we have moved from a 70% viral suppression to 95%. And when you look at the treatment strategies we've employed, they're truly innovative, truly innovative. From moving away from AZT was tremendous, and moving into the new HAART era in the mid-90s. There's a time when I didn't want to see another HIV patient die. That was the mid-90s. HIV was a death sentence. To those in the room who don't remember those days, patients would come in with PCP and be dead in 24 hours. It was really as traumatizing at that period of time as COVID was for me in the COVID era. So when you look at the development of drugs, moving from different strategies of stopping the virus, from integration to protease to capsid inhibitors, we not only improve virologic suppression, but the story is not about virologic suppression anymore. The story is about tolerability, patient satisfaction, always, patient compliance to medication. I think believing that the patient comes first and recognizing that every single drug we develop or every strategy of drug development has to be based on patients. We are 70%, 80%. What about that 20%? Don't leave them behind. We're at 95% now. What about that 5%? Don't leave them behind. So these are the studies I think, the landmark clinical trials I've been involved in. Back in 2012, when we were working on dolutegravir, and then the drug was approved about 2 years later. And dolutegravir is now used by 26 million people in the world. 26 million people are on dolutegravir regimen. And yet, when we were doing the clinical trials, we didn't see the amazing story around dolutegravir. As a result of dolutegravir, we have now moved from 3 drugs to 2-drug regimen because of the potency of dolutegravir as a new innovative treatment. We have took innovation to the next level, where many patients are afraid of taking, they don't like to take pills anymore, they cannot take pills, there's stigma around pills, the fear of being discovered, and we've gone into the direction of long-acting injections. When you look at the long-acting injection studies I started was in 2014. And in 2021, 7 years later, after 7 years, those patients were still in clinical trials. It was approved in the United States as the first long-acting therapy, cabotegravir, rilpivirine. And the PURPOSE 2 study is an exciting study. I was involved in that from the initiation. And we have seen that the excitement is building. It's every 6 months, one injection. Probably way more effective than any vaccine that we know of 98% effectiveness to prevent acquisition of HIV. I think when you look at the story around innovation and being part of that story is exciting. But it's not just HIV research I do. I've been involved in hepatitis C cure studies, of which now 99% of people are cured with hepatitis C. Been involved in pneumococcal vaccine studies with the Capvaxive. And Capvaxive, this was the first study that we looked at a vaccine in HIV patients. And that data was published in Lancet already 6 months or a year ago. During COVID-19, we were inundated. We were horrifically inundated with clinical trials. At one time, we were doing about 20 studies, running in the office, back to the patients, seeing 150 patients a day at that time, just having protocols, remdesivir, steroids. And actually, I was the person who brought the remdesivir to Florida through my relationship with Gilead. And the first patient who received remdesivir received it in my hospital. Hepatitis C B cure studies is something we're looking at, and you're going to hear more about the hepatitis B cure. We know hepatitis B affects over 50 to 100 million people, and that's going to be a story we'll be working with. What about treatment? What about work I'm doing currently? You're going to hear a lot more about lenacapavir, not in prevention, but in treatment. Is Latravir, lenacapavir, 1 pill once a week. That's going to be published pretty soon. 1 pill once a week. And then we're looking at weekly integrase capsid combinations. But also what's also exciting is we're moving away from medication treatment, and we're looking at broadly neutralizing antibodies. Imagine that, broadly neutralizing antibodies for patients. And we're engineering it in such a way that it can be given every 6 months. So what's that then going to look like? We're still 3 to 4 years away from that, but that's in the pipeline. I've worked on multiple HIV cure studies, and HIV cure, as we all know, is elusive and difficult, and will take many, many more years and many, many more studies. Even mRNA vaccines, we did that study. We'll be publishing that pretty soon. It wasn't as effective as we thought it was going to be. But what truly excites me in the next year is the lenacapavir once a year. Lenacapavir once a year study that we initiated in our office, and then cabotegravir every 4 months for PrEP. Many of these studies now have influenced guidelines. And you look at the guidelines every year, most of the studies I've been involved with in the last 10 to 15 years have impacted guidelines and shape how we treat HIV and hepatitis C globally. But what's our story in Florida? We are 95 biologic suppression. Midwest Special Care Center, with all our patients, 95% biologic suppression. And we do a lot of data mining. We track our patients. We bring those out of care back into care. And when you look at the state of Florida, they're only at 70%. 70%, and they have 120,000 people with HIV. That's 70% biologic suppression. That's why Florida is still among the highest states with HIV. So over the years, I've recognized that there are strategies you can use to stop HIV, or even pretty much for any infectious disease process. And what are these 5 pillars that I've designed and we've designed for success? The first one starts with electronic health records. It's very, very critical. Many of us opposed it back 15 years ago. It took more time to use it. But the data around electronic health records, capturing patients back into care, identifying medications refill challenges, identifying patients with homelessness. And many of my clinics in Florida are around environments where the patients suffer from or struggle with transportation, they struggle with food insecurity. They have a food bank in my office for which we give our patients free food, and they come looking for food. So as much as we think the United States is a beautiful country, there's significant poverty there, there's significant challenges of care. A lot of patients lose their insurance, so we have to find strategies to get them back into care with insurance. So pillar 1, it's about electronic health record. Pillar 2, which is what we are doing. I was a really strong advocate for CNV testing and treatment, and that is now universally accepted with the medications we have available and with our diagnostic tools that we have available. But number 3, I think, is going to be the future, and it's something that's missing, and that's continuing education. Virtual CMEs, we did that during COVID, but real-world CMEs. physician to physician education, physician to community education, physician to nurses education, and peer education. I think in the Caribbean right now, this is an opportunity for us to standardize CME around the Caribbean. I think, as I see it right now, every country have their own guidelines for CME, and physicians need to do CMEs. But I think we need a standardized version throughout the Caribbean, and I think that will be quite helpful. Prevention, as we are seeing, since 2010, we started with Descovy with tenofovir based regimen, and Descovy, Apretude, and now lenacapavir, because we recognize, apart from even these prevention medications, that patients who start treatment and are undetectable equals untransmittable. And that's a story that I think was hidden for too long. We suspected it for a while, and now we can clearly announce that to our patients. And this is a motivation for a lot of patients to become undetectable. And the fifth one is optimize ART strategies, identifying which patient, identifying treatment for each patient, and recognizing that there's so many options for patients. One pill once a day, in the future once a week, long-acting therapies, long-acting injectables. So let's take a dive now into the world at large. 40.8 million, that's slowly creeping up from 36, 37 million. But it was not the dramatic increase that we'd expected 20 years ago without the innovation that we have developed. 40.8 million people live with HIV. And what's impressive about that is the decline in infections. From 3 million new cases globally, we're down to 1.3 million. Oh, you're looking at how we're hoping that by 2030 we'll get to 500,000. I don't think it's going to happen, but we're getting closer to those numbers. And I don't think it's going to happen because it cuts in funding, and something we'll discuss later. HIV-related deaths have dropped dramatically down to 54%. In my clinic, when I first started seeing lots of patients, I would say this year, these patients may not survive. And lo and behold, now in the last 3 to 5 years, I can't recall any patient dying from HIV in our practice. But what bothers me, when you look to the left of this slide, what bothers us right now is the increase of HIV in Latin America. There's been a 13% increase in Latin America, and this is troublesome. This is challenging. We have to, and we're close to Latin America as a Caribbean islands. We've seen migration. Recognize we're part of that story as well. So let's look at the Caribbean at large. Caribbean, English-speaking Caribbean plus non-English speaking, about 40 million people. There's 340,000 cases of HIV identified. We now have about 15,000 new HIV infections per year, with 4,800 AIDS-related deaths. As you can see from the decline, is that impressive? From 20,000, we're down to 15,000, even with all the medications we've talked about. And why is that not somewhat better? And what do I mean by that? We recently said that the Caribbean is declining 21%. And many of you in this room will say, wow, that's great numbers. But is it really truly great numbers? Let's take a look at Sub-Saharan Africa, 56%. And Western and Central Africa, countries that are poorer in the Caribbean, countries with more HIV than we can imagine. At times, about 30% of the population were HIV infected. And they're doing tremendous with the same PEPFAR funding that we have seen for quite a while. So the question is, what is the Caribbean culture? What are we missing in the Caribbean that we're only at 20%? We should have been at 50%. And why is that so? So, this is where we have to do a deep dive in the culture, a deep dive in physicians. What does it need to get done that's different? What can we learn from Africa? What can we learn from the Midway cohort? So these are, questions that's going to happen. So we have been talking for quite a while now with 95, 95, 95, and there's a fourth 95, which I'll mention shortly. But when you look at the Caribbean data for 95, 95, 95, 81% of people know they're HIV positive. So when you take the 340,000, you're missing about 20%. That's not about 70,000 you're missing. 71% of that 81% are in care, and then and 64% of that 71% are biologically suppressed. So if you run the numbers, you're probably close to 200,000 people out there right now who are not biologically suppressed and who are transmitting HIV. So it's not surprising our numbers are where they're at, because we really have to work hard on those 200,000. And where's that going to happen, and how are we going to change that? It's going to be important. Again, I reflect back, I show the slide once again, the pillars to success. We have to implement EHR, we have to do data mining, we have to continue same-day testing, amplify it, and I recognize now that they are home testing as well. and improve our education. I think education, understanding the missing connections of why patients are not taking medications is critical and important. Let's do a little look now at the EHR. And the world is changing with AI. I love AI. I love going into the AI programs and seeing what the data is. I was telling Dr. Tariq earlier, I went into AI and looked at Guyana's data. I went into, you can pull data so much faster these days. It gives real-time access to my patients. I know which patients are in care. I know when they're not out of care. I can call them, we bring them in, and that's why they're at 95%. And St. Lucie County has the lowest rate of HIV transmission. When I went there, it was over 350 new cases a year. Now I'm down to less than 20. And most of those cases are transmitted by immigrants moving into the community. So my naive clinical trials are struggling because of the success of what we have done, and that's great. But it's also important, the AI integration is important for data mining and developing care pathways. Not all patients are the same. This patient may need more time. There's a mental health issue here. You work with that patient longer. Not every patient is a 10 or 15-minute visit. Some may be half an hour, some maybe 5 minutes. I think we need to recognize that with physicians. Building trust is critical, and that happens within the first 5 minutes of a conversation between a physician and the patient. And I always credit our clinic success because of the providers we have and the quality of care we provide and that trust story. Now, we're talking about rapid diagnosis for quite a while, rapid treatment, and this had to take a while because we didn't have the tool. Now we have the tools. In 15 minutes, I can tell you if you're positive or negative. In half an hour, I can get you your first pill to start. That's how we need to approach HIV. And so as an infectious disease physician, it always puzzled me why it took 2 to 3 weeks to start treatment on someone who have an infection. I don't wait for sepsis. I don't wait for bacteremia. We start immediately. And so that's why we're seeing the impact of rapid start, rapid in care and treatment, and a decrease of patients being out of care. All very important. These 3 studies now, when we look at here, the SOLAR trial, the Capella trial, and Calibrate trial, which I've been involved with closely, they all talk about something that's important. That's the fourth 95. That's patient satisfaction. We never considered that much in the old days, but now we consider it significant to end HIV. The patient satisfaction story, making sure that and that's a question you ask every patient. You may have a patient who's on their medication, same medication for quite a while, and you'll ask them the question, are you satisfied with your medication? Then they'll slowly tell you, oh, you know what, I'm missing pills, I'm not doing right. So those are the patients you have to address with the new innovative treatment that we have now with long-acting injectables and once-a-week therapy that's coming in the pipeline. That will be quite exciting when that happens. But what's going on globally with funding restrictions? How's that going to impact us? It's going to impact seriously. When you take a look at the Caribbean yearly budget of $350 million spent on HIV care, and 1/3 of that, 2/3 of that is by foreign funding, 1/3 is from local Caribbean governments. So now you're going to have a deficit of 2/3 from your budget. What's that going to look like in the next 5 years? Are we going to cut programs that PEPFAR has already built in place? Are we going to lose ground here? So I think there's going to be close watching this, and the fear from all of us is that these numbers will increase. We expect about 6 million new HIV infection by 2030, and possibly about 4 million additional HIV-related deaths. Right now in Florida, they're cutting some medications. We can't use Biktarvy in certain populations. So we've seen the challenges already, not only, and that will evolve and probably amplify as the numbers change. So we need to be very aggressive. We need to be aggressive of PrEP coverage. We need to change our mindset. Every clinician from even pediatrician should be addressing PrEP with their young patients, adult patients. There's only about 160,000 people currently using PrEP, and we really need to be at 2.3 million, and even much more than that. This is the most effective way of prevention that we've ever seen in any treatment arm of infectious disease. 99% treatment prevention with oral medication, and 98% now with lenacapavir. So it's a story that we need to be very cognitive of. So can we look at the 5 pillars? Can we replicate that in the Caribbean? What's the funding going to look like? And when you think about commitment from the Caribbean community, there's been significant commitment for the governments over the years, but there's been also commitment from global funds and PEPFAR and other generic medication story. But we need more commitment from governments. We need them to say and support it. I have been, since my clinic here established in Midway 5 years ago, we have a great relationship with the ministry where we now we have one of the few clinics that are seeing significant among the private patients. I think patients need to have an option, which clinic they should go to, not just saying you have to go to a government clinic, but I think we need to amplify the story, encourage primary care physicians, encourage private physicians to start taking care of HIV patients much more. The Caribbean structure is a lot different from Africa, a lot different from Australia. I love the Australian story because there's 30 million people in Australia with only 28,000 patients. That's an incredible story. And how they're down to less than 500 new cases a year now, even with such a large country. So we need a commitment of financial relationship, decentralization of medication distribution, budget allocation, and bringing in private partners much more. Caribbean healthcare providers need to get more interested in HIV again. There's something called a purview paradox, where a primary care physician don't think they should do prevention because it's an infectious disease, HIV related. And infectious disease physicians don't think that they should do PrEP and prevention because that's for primary care. So there's that lost story there, but we need to overcome these barriers and push forward. And then we also need a political commitment to the Caribbean. We have the weapons. We can proudly say today that we can end HIV, AIDS as we have known it for the last 40 years, and we can end that. And we need to be proud to say that. We've shown it in multiple stories. I keep showing you this five bullet points here that we recognize. So in summary, we have the tools. Global funding supporting prevention and treatment programs are going to go away. We need to develop our own tools in the Caribbean to figure that out. Rapid diagnostics is here, cheap, very easy to do, very easy to start medication. Immediate treatment for those diagnosed, we can keep saying that over and over, that has to be done. No patient who's positive should leave that office without a prescription on that day or medication. No person who's have an STD should be leaving your practice without a prescription for a PrEP drug. None. Those are the high risk. And make sure that those strategies are implemented. Long-acting therapy, I don't know when that's going to come to the Caribbean, but I do know lenacapavir will be here soon at $42 an injection. That will be amazing. Gilead has said that that's what they're going to do. New innovative affordable drugs via patent pools. That's keep coming. The one pill once a week will be amazing when it gets to the rest of the world. And patient-centered care that addresses individual needs that we talked about. The top photograph is the clinic we have here in Kingston, which you see providers here. And it's really a dream for me that has come true. I always said I want to come back to Guyana and set up a clinic that can provide infectious disease services. But they do way more on that and beyond. The lower slide photograph shows the team. You recently had a provider meeting, and you see all the providers. I'd like to thank the nominators, like my family, who's been very close to me. Anna and Sukram, my CEO, Caribbean Health Agency, Ministry of Health of Guyana, Dr. Frank Anthony, who's been very, very supportive of my work that I've been doing, and Dr. Shanti Singh, patients and study participants, as well as the award committee. I think these are my references that for some of the studies. I think ending HIV marks a triumph, not only of innovation, but it's a triumph, and it's a humanity story now. We've gone beyond the fear, we've gone beyond that. We need to now step up and get it to the patient. We have done the work. We've developed drugs, we've innovated in testing, we've innovated in every space. And a lot of that innovation is now translated to other disease states like hepatitis and hepatitis B treatment and cure strategies. And we saw that with the COVID story as well. We were able to rapidly develop protease inhibitors for coronavirus. So I think now is the time to act, and now is the time to move forward.
Thank you very much for a very inspiring story. We have about 5 minutes for questions.
Hey, good afternoon, Professor Rangopal.
Yeah, hi.
Dr. Joshua Rama here from Georgetown Public Hospital. As a physician who's directly involved in HIV positive patients that are admitted or acutely ill, I know the guidance has changed with early treatment initiation. For those patients with an opportunistic infection, say for example, PJP, or maybe cerebral toxoplasmosis, where we worried that their CD4 might be on the floor, and their viral load might be super high. Does this almost immediate starting treatment apply? And are we still worried about IRIS in this population?
Yes, we still worry about iris, but there are two particular conditions we look at, tuberculosis and cryptococcal meningitis. Those are the two we say we're not going to start immediately because the immune reconstitution syndrome has shown that there's more aggressive outcomes or worsened outcomes. So those are the only two reasons I do not start rapid start. The other reason I don't do rapid start is if there's going to, in the hospital, if I don't do rapid start, is how am I going to get that patient to the office? The transportation, travel. But if I know that patient is going to be in the hospital for the next 2 to 3 weeks with PJP or with some other condition, I will start. And I'll start immediately with those patients. And you observe them. There was that fear of immune reconstitution syndrome with integrase inhibitors having more versus protease. We have done studies to show that doesn't happen. We've done studies to show that starting earlier, even with the PJP, have better outcomes. So I think it's an important question. When do you start? There's certain reasons you can't. Yes, there are two reasons, cryptococcal meningitis and tuberculosis. Thank you. Yes.
Hi, good afternoon. Excellent presentation. That I know you're always interested in your presentation. I know you mentioned some countries that is doing very well, are doing very well, like Australia and so on. Is it our culture? We actually study, the culture aspect of it in terms of how these countries, the real life of these countries compared to Latin American, Caribbean, and Caribbean countries before we actually introduce, these preventative measures.
Yeah, I completely agree with that comment. Is it culture? And what does culture looks like? Can we have cultural transformation? What is it? I mean, when you look at where HIV, transmission of HIV, it's very, very important to look at that. It's a disciplined illness, very disciplined. I mean, you have to take a pill for the rest of your life. You have to take a treatment for the rest of your life until we find a cure, and that remains elusive. I think we lack that discipline. But that discipline can improve with encouragement. Physician-patient relationship, I think, is very critical. So is it the culture of the patient or is it the culture of the practice? That's the question I would like to turn back. Is it the patient not engaging? So again, when I started my private practice and I self-funded my clinic, and I was doing, most of my patients were uninsured at the time. And you would engage with patients and you realize that you have to walk in the patient's shoes to gain trust. And sometimes we're too busy, we don't recognize it. We have to learn empathy. We have to connect with our patients. Of all the illnesses, the challenges, I found that, we're not trained enough for that empathy and caring. And I think once you get started learning it and doing it right, you'll find your level of patients in your clinic increase. So I have about 1,700 patients, and which about 95% are in care. And usually in my community, with the challenges they have, you shouldn't expect that. I have the highest rate, over 95% of my patients who doesn't have insurance, something we call Ryan White patients of viral suppression. And the state came and they looked at me, they wanted to know how come we're having such a high number. And I think it comes back to the patient and the physician relationship.
Good afternoon.
No.
Hello. Hello.
Yes. Yeah, so, I went to Croy, and at Croy, they were talking about in sub-Saharan Africa, they were complaining. South Africa was saying that the funding is going to really damage them. Yet their healthcare budget was only 10%. And you should have a healthcare budget of 20%. It comes down to your healthcare budget. It comes down to your ministers of health. It comes down to your leaders. We have to own this. We can't just be dependent on the global space to help us. We're independent countries. The medication are given to us almost for free. It took us 15 years to develop an integrase like dolutegravir. It's taken us about 20 years to develop lenacapavir. These medications are coming with a very high cost, but we get them for dirt cheap. So the question to me is why can't we up our budgets? And there's a trade-off with treating HIV and there's a trade-off with PrEP, that you now have patients early in care. You can educate them about diabetes, vaccination, prevention. There's a lot more you can build into your HIV program. But I think what's also going to be key for the HIV program, back to why our numbers are high, we need to decentralize it. We need to find a way to get private doctors more involved in the care of HIV. So the governments in the Caribbean will face a challenge since PEPFAR fund is going away. We face a challenge of 2/3 of our funding right now. Are they prepared to say, we're going to step up, reduce budgets in some areas and amp those budgets up? I think that's going to be the question now.
All right. Yeah.
I'll be quick.
Thank you, Dr. George. Thank you,
Thanks so
Dr.
much.
Abdul.
I'll be quick. After we know so much about HIV, 25 years or probably greater, it still remains a vertical program. A vertical program in many member states, and we seem to be giving lip service to the movement of integration into primary care. Could you comment on that? Because I don't think that, as with other public health programs, HIV has lagged behind with respect to still maintaining its uniqueness. Thank you.
So that uniqueness adds to its stigma. And we've tried to destigmatize HIV for the last 40 years, pretty much, from the inception. And I really think we need to decentralize HIV. The vertical story works in some countries. It works in a lot of sub-Saharan countries. But the Caribbean, it's not, we are 21%. We got to get somewhere. We got to improve our numbers. And I think decentralizing it, engaging more primary care physicians into HIV care, more education. But I think the challenge for Caribbean countries is that here is the vertical transmission. Here the medication comes in, vertical transmission, control the medication, control the cost. It's all important. But here we have a clinic right now working with the government and it's working very effectively. And the patient will tell us, we're so happy we can come to your clinic because it's different. It's different from the government clinic. And I know many physicians in the room work in the government systems, but I've always felt that entrepreneurship and striving forward. I could have gone and worked at a university. Something I tell my friend, when you stay in institutions so long, you become institutionalized. And you don't think outside the box. You don't think about other things about the patient. You think about, what the day, have 20 patients to see, or how am I going to get through my day? Not saying, wow, I got 20 patients. Yes, I got to see those 20 patients. Now with that thrill and excitement to take care of every patient and save every life as you can.
Thank you, Dr. Thank you, Dr. Abdul. Hi. Thank you. Thank you, Dr. Thank you, Dr. Moti Ramapal. Always inspiring. I wanted to ask a question on lenacapavir. So in the Caribbean, we are at 86, 89, 85, 89, 86. And so we're very close to 2030. I see it almost as if we're on the last mile, and it's always the most difficult mile. But we do welcome lenacapavir, and the price, once generic becomes available, it's about $60 per patient per annum, which is good. So we had 2 million doses that were donated, and last week another 3 million. But when the 2 million doses got donated, UNAIDS did an assessment or modeling that showed that with the 2 million doses, you can avert 50,000 new infections. And I think it was the president who spoke about the whole Caribbean can be a pilot yesterday. And so when you think about our numbers, we could avert all of our infections with LEN. But my question is, considering that, one, our uptake for oral PrEP has been very low in the region. Two, that we seem to have a culture where we don't like vaccines and injectable. And three, where there's a long tail for LEN and the potential risk for resistance, like what would be your advice to the Caribbean?
So implementation of PrEP is a lot of education to start with, as I mentioned. But let's look at some of the numbers. Half of the patients who start oral PrEP, half of them, by 6 months, they will stop, half of them. When we moved to Aperture, which is Cabenuva every 2 months, that number went up about more patients remained up to 9 months. Most patients stayed on. And with lenacapavir, we're hoping once you get that one shot, you already cover 6 months. So who's going to be on for the second shot in a year? And if you miss that second shot, there's a risk of resistance developed. The 2 patients in the Purpose 2 study, there's 5 patients now, but all of them pretty much have developed mutations against lenacapavir. And as you can see from the pipeline drugs, oral lenacapavir is going to be out soon as well. So it creates a question. But the solution is ultimately, guess what? We're working on better drugs. In the future, we're already working, we already recognize that there's resistance with len. We're looking for the next generation capsid inhibitors already. So that's in the pipeline. But even with lenacapavir, with the story that sounds so exciting, and we have unpublished data, which can be published pretty soon, will tell you about 1 out of 3 of those patients injected will say they will prefer oral agent. So lenacapavir is an option. It's not a solution. It's an option for patients who don't want pills. But here's for those other patients, you can have it. And so when I think with the Caribbean is how are you going to roll it out? First of all, you need to roll it out to the STD patients. Any person with STD should get lenacapavir. My question always to the pharma companies, okay, you have lenacapavir, your HIV numbers drop. Are you going to tell people to use less now as your numbers are dropping financially? But it'll be an interesting story with communities as your numbers keep dropping, how much PrEP you need. But coming back to, the high-risk patients, coming back to rolling it out strategically. And it's an education story. Recently, the 3 top Brazilian doctors came to our clinic and to learn about injectable PrEP. And we showed them, we taught them, we sent them back. So education is critical. Training physicians is critical. Training physicians, and that's where the electronic health records comes in. Tracking every single patient. Here's month 5, making sure you're coming back for your injection. Are you ready for your injection? And you give them warning. We have alerts through our phones now that we can send a patient alert. Your time is coming up for your next injection. You need to be here. So I think we have to have the implementation strategy right. We have to have 3 or 4 pillars as we were talking about: electronic health records, tracking patients, social health as well is important. Most of the time, when you look at HIV transmission in the US and globally, it's associated with poverty, it's associated with tough lives, IV drug usage, something else. And those are all, enough things you have to work on. You can't just say, here's PrEP, take it, and in 6 months you're protected. Great. And what happens in month 7 when you become infected? Yes.
Thank you very much, Dr. Motilal.
Motilal, I love that.
Moti Ram Gopal. How can I do that to my friend? As someone who's been involved in the Caribbean response from the very early days, so I'd like to clear a couple of misconceptions. First thing is that the Caribbean governments have stepped up in the Caribbean response. For example, Barbados had taken a World Bank loan of $20 million, right, for its response. Trinidad and Tobago, government funding, never received PEPFAR funding or global funding. The countries who received PEPFAR funding were mainly Haiti, Dominican Republic, Guyana, and then there was a regional program. Now, for us to understand something, that a lot of the overseas development association that comes to countries, especially US government funding. And I'll give an example. US government said it had spent $150 million in the Guyana HIV response. I did an analysis in a publication called Health at 15 Guyana. When you look at when the epidemic peaked in Guyana in 2006, looking at 10 years before the peak and 10 years after the peak, there was statistically no difference in the number of new HIV cases that were diagnosed and reported. It was 832 versus 834. 150 million. And Guyana got Global Fund 27 million, World Bank 10 million. Roughly $250 million US was spent on the response, and no difference between when the epidemic peaked and thereafter. Much of the US funding goes towards what? If 20% of that goes into actual interventions that help people, you're getting a lot of money, right? And then something that we need first to understand. It may have worked in Africa, hasn't worked. And I give the example of Guyana. And you could go and look at the data and you will see that. And that the Caribbean countries have responded. Guyana itself, right? While they got Global Fund support and PEPFAR support, the government of Guyana put a lot of resources. And if you look at the data, because at the ACE conference in, what was it? Last one in Europe, where I presented a paper to show that the governments in the region have been increasing their contribution, while overseas assistance has been reducing.
Yeah, and the overseas
no,
assistance.
one second. Okay. We won't have time for this, unfortunately.
I'll do a quick response.
Yeah, that's one. Two, EMR. Most of the countries in the Caribbean don't have electronic medical record. And there are lots of problems trying to implement that. I worked with the OECS from 2019 to 2022. They got Global Fund support to put an EMR in place. Hasn't happened. In the Guyana program, we shifted $250,000 US to support the development of an EMR. To date, that was in around 2015. That has not happened, right? So no, hold on. We're using different models. Dr. Moti's practice is more in developed countries. And
No,
it's
underserved communities. The big difference.
But
the
still-
same like a Caribbean community.
But no, still, it's a developed country. It's a developed. There are lots of differences. Right? And we want.
Yeah.
Finally, which are the most at-risk groups in the different countries? Coming back to Lenkapavir, many of us who've been in the HIV response locally, regionally, and internationally think that Lenkapavir will get better bang for your buck worldwide if that is given to adolescent girls and women, because they right now constitute one of the highest risk groups rather than looking at STI patients. Yes? But I'm open to discussions outside of this arena. Thank you very much.
Thank you. In closing, there were some great comments, great points, but very complex answers. But there are good answers for each one of those points, which I'll discuss with you later. Thank you so much.
Thank you, everybody, for an excellent session, and Dr. Edwards putting things in the local context. But I think, there's obviously a great deal of things to discuss, and I hope that everybody will take the opportunity before the end of the conference to, engage in those discussions. Thank you. And we'll move on to the next session in this room. Thank you.
No. En CARPHA, soy el jefe del laboratorio de CARPHA. Okay, good afternoon, everyone. Pleasure to introduce ourselves. I'm Gabriel Gonzalez Escobar, Assistant Director, Surveillance, Disease Prevention and Control, and Head of the CARPHA Medical Microbiology at CARPHA. and I'll let Dr. Hector Bolivar to introduce himself. Hector?
Good afternoon. This is Hector Bolivar from Midway in Florida, as Dr. Rangopal mentioned, and also Midway here in Guyana. I was faculty at the University of Miami for 23 years. And I just realized first time that I met Dr. Gonzalez that we born in the same place in Colombia. What a coincidence.
Yes.
Thank you for being here, and we will try to make this interactive. Thanks.
All right. So you can introduce the first one. Or it's part of your group. Okay. All right. So our first presentation would be Mrs. Chan Kuretsky, Sustained HIV Protection with Cabotegravir LA among Black and Latin individuals, data from the Midway cohort. So just a reminder, gentle reminder, 10 minutes for presentations and 5 minutes for questions and answers. Floor is yours. Thank you very much.
Thank you. And thank you everyone for being here. I have the honor of following Dr. Ramgopal's presentation to share some of the great outcomes of what we've had with the Midway cohort in regards to HIV treatment and prevention. This first presentation that we have here will review the outcomes of using cabotegravir long-acting for HIV prevention among Black and Latin individuals in the Midway cohort. So it's no secret to anybody in this room, if you're here, you have an interest in this field. We do know that there are populations that are disproportionately affected by HIV across the world, whether that's men who have sex with men, individuals who engage in sex for money, transgender individuals, all have higher rates of HIV. That's universal across the world. We also know that PrEP implementation has increased. We had a great discussion previously about PrEP implementation. We know oral PrEP through the use of tenofovir, Truvada, and Descovy has been around. Now we're moving into the space where we can start to offer long-acting injectables. But that doesn't take away the fact that the medications can be extremely impressive, but we still have to address social determinants of health, whether that's in a developed or in a developing country. And so one of the things that we've seen among our clinics here or in Florida is that the concept of diversifying clinic options, such as what we've done at Midway, to be able to extend the reach of healthcare providers from the public sector to the private sector has really helped to expand PrEP access. And then there's still things that we have to work through, especially addressing those social determinants of health, which are a key barrier to long-term PrEP success. So the objectives for this presentation, we're going to talk about persistence on cabotegravir long-acting for PrEP. We're going to talk about our success with adherence to on-time injections, and then reporting the incidence of HIV with cabotegravir long-acting. So we went back into our charts and did a retrospective review to describe the persistence of cabotegravir long-acting for PrEP over 3, 6, 12, and 24-month periods, as well as looking at on-time injections. We use those 4 time periods that you see in the calendars in purple at the bottom. So when we talk about persistence, we're talking about those time periods, those that stayed on it from 0 to 3 months, 0 to 6 months, 0 to 12, and 0 to 24. In our cohort of Black and Latina individuals in the Midway cohort, we had 159 persons who had received at least 1 dose of cabotegravir long-acting between December 2021 and December 2024. Those who were offered cabotegravir long-acting for PrEP were identified as high risk. So they were coming into us, sharing with us that they were engaging in condomless sex, that they had multiple sexual partners, or we knew either through positive testing with us or through self-report that they had a history of gonorrhea, chlamydia, or syphilis. So who were these individuals? Well, the population overall had a mean age of 39, with almost 50% of people between the ages of 30 to 39. We had about 87% that identified their gender as cis male. We did have race. 34% identified their race as Black, with about 70%, 7 out of 10, identified as Latina. Days on prep that you'll see, or days on aptitude, it was on a median of 288 days, so just shy of a year for this time period. About 50%, so 1 out of every 2 did have a history of gonorrhea or chlamydia, so kind of echoing what Dr. Ramgopal was talking about, prioritizing people who do have that history of a bacterial STI, and just shy of 1 out of 3 had a history of syphilis. So what did we see? During this 3-year period, thanks to cabotegravir long-acting for PrEP and the great team that we have at Midway, we had no incident HIV infections reported among this population. 97% of those injections, of just over 1,200 injections, were administered on time. So cabotegravir long-acting for PrEP is given every 2 months after a lead-in period of an injection followed by an injection a month later, and then every 2 months thereafter. To be defined as on time, it was within plus or minus 7 days of what that target injection was. So just 97%, a big kudos to the interdisciplinary team that we have at Midway, from our physicians to our pharmacists, to our nursing staff, to our nurse practitioners, case managers, everybody plays a role in this. Now, what did this look like for those 3, 6, 12, 24-month periods? Well, you can see within those first 3 months, we had really high persistence rates. But after a year, we started to see that the persistence rates of people staying on cabotegravir long-acting fell off. And so we're actually working with the University of Miami right now to develop a study to specifically assess what happens at these 12 and 24-month periods. Why are people falling out of care? Are they no longer self-identifying that they are at risk or have reasons for PrEP anymore? Are they moving out of the area? What are the reasons? So we are going to investigate this further. The purpose of this presentation is just descriptive to share our results that we have thus far, but know that we're not turning a blind eye to that. We very much have an interest in why that happens in our population. So more to come, maybe in a future year, we'll be able to share that with you. So what do we know? When we look at our persistence rates compared to persistence rates for those taking oral PrEP, whether that's Truvada or Descovy, we do know that it's very similar, where we do see after that 12-month mark that people do commonly discontinue PrEP. But again, if the risk and the reason for HIV protection is still needed, that's something that we have to investigate. Of note, this was really important. So sometimes the concern with an injectable medication is that there could be injection site pain. People don't want to continue anymore. Thankfully for us, only 6% of Latina and 9% of Black participants received a single dose and said, "I'm done." So that was great. So if they actually did agree to start cabotegravir long-acting for PrEP, they did continue with it for the most part. So in conclusion, cabotegravir long-acting for PrEP did have similar persistence rates to those taking oral PrEP. And we know that those rates were higher in the first 12 months, and know that we will be working to figure out what we can do to support that period beyond year 1 or beyond those first 12 months. One of the things that we're really excited for at Midway, that 97% of injections represents a very diverse population. When we look at other real-world cohorts that we have in the United States, such as the OPERA cohort, you will see that it is not very diverse. And so we are very excited to share our success of what we've been able to do in a very underserved and diverse patient population. And that was it. Thank you. Any questions?
Thank you very much. Any questions for Dr. Kuretsky, please? I think we're okay. Thank you very much.
Thank you.
Oh, there's a question? Oh, sorry about that. Yes.
Thank you, sorry about that. Thank you for a great talk, Doctor. My name's Ishan. I'm a public health student, medical trainee from Exeter Medical School and the London School of Tropical Medicine. Like you were saying there, and I think your study does point out that long-acting Lencaster have been, I mean, for us, when treating HIV patients, have been life-saving and life-changing for that access issue. I don't know if this is out of the scope of this study, but I was just wondering if you investigated at all the reasons why people dropped off after that 12 months, And then maybe in future studies, are you looking at models of care that could be used to bridge that gap? So I know Spanish and UK studies have looked into using community care clinics and outreach programs to do this. And is this something you think would be feasible in the future?
Sure. Yeah, so we do not have the answer for those on cabotegravir long-acting for PrEP. We did pursue the reasons why people would stop long-acting cabotegravir or piperine for treatment of HIV. And believe it or not, it was something like 60 to 70% had just simply moved out of the area. Cost of living can be a barrier, and so people have to move to make what's best, make the best decision for their families. So we did see that. So we do not yet have that data for cabotegravir long-acting for PrEP, but we are literally in the middle of conversations of planning a protocol to explore that for reasons for discontinuation. Because yes, we do want to help develop solutions. We are looking at developing mobile clinics. The reason why we have not yet thus far is there are many legal obstacles for that. And so as we work through each one of those, we're getting closer to that. So maybe that would be a solution. So yes to both. We will be working on that. We just don't have the answers yet.
Thank you.
Thank you.
Any further question? Okay, I think I'm not missing. Thank you very much, Dr. Kuretsky.
So the next presentation is by Joaquin Wu, who will present predicting virological failure in pediatric and adolescent people with human immunodeficiency virus, patients in Haiti, and it's a crisis-adjusted machine learning approach.
Good afternoon, everyone. Thank you for coming to this presentation. Today, I will show our work on predicting virological failure in pediatric and adolescent HIV patients in Haiti using a crisis-adjusted machine learning approach. This study was conducted through Georgetown University Center for Global Health Practice and Impact with the partners in Haiti. Our goal was to identify children and adolescents at high risk of virological failure early enough to support targeted follow-up and better continuity of care. So first of all, let's start why this study matters. Haiti has the highest HIV prevalence in the Caribbean area, with around 150,000 people living with HIV as of 2024. Also, Haiti accounts for more than 1/3 of new HIV infections in this region. Security crisis has disrupted service, mobility, and the continuity of care in the meantime as well. And pediatric viral suppression, which is 59%, remain far below than adults, which is 80%. And in this context, a missed which may reflect violence, disruption, not just non-adherence. So this is why we need risk tools that account for crisis condition. Next, let's see what's our objective. So this study is to develop and validate a machine learning model to predict the virological failure for children and adolescents aged 0 to 19 years old in Haiti. And we want to identify high-risk patients before rebound occurs. And as importantly, we wanted to do this in a way that reflects the reality of instability during the care delivery in Haiti. And under the TIDE Plus framework, the aim is promising and practical. We can improve the early risk identification, strengthen targeted retention efforts, and support program decision-making. This study is a retrospective cohort design using Haiti National HIV Electronic Medical Records data. And the data, this study contains 4,674 pediatric and adolescent patients covering the period from November 2023 to May 2025. And the outcome is the virological failure, which defined as viral load over 1,000 copies per ml. And we compared 3 different country-based models, including XGBoost, LIGBN, and CAPBoost, and using different kind of metrics to compare the model performance, including F2 score, AUCROC, PRAUC, recall, and precision. And we obtained our ASIC approval from Georgetown University IRB and Haiti MSPP with CDC Haiti. One key feature of this of this study is the crisis-adjusted feature engineering. We encode predictors to the patient's most recent viral test and added instability-focused features, including treatment interruption length, status change frequency, and the proportion of time on treatment. And also, we're doing some kind of subgroup analysis. We stratify analysis by age group for 0 to 4, 5 to 9, 10 to 14, and 15 to 19. And as you can see the table, the oldest adolescent shows the highest proportion for detectable viral test, which reinforces the need for age-specific risk modeling. So among all these models, CARPHA shown the best performance with an AUC-ROC of 0.74 and a record score of 0.75. And this is important because our target is to identify as many at high-risk patients as possible. And as you can see through the table, the F2 score also favors the CARPHA model with around 0.6. And under this machine learning model, it can help identify nearly 4 times more failing patients than the random selection, which make it promising for the future outreach. Then we use the CARPHA model to run different kind of models in different kind of age groups. And we want to see the performance in different kind of age groups. And the strongest performance shown in the people whose age is 0 to 4 and 15 to 19, with a record score over 0.8 and AUC-ROC over 0.76. And in the meantime, we can see the performance is not that good for the middle-aged children from 5 to 14, with a record score just a little bit over than 0.5 and an AUC-ROC around 0.7. And while middle age may require additional predictors or a different kind of modeling strategy, but we also can see like the model performance is very strong for the infants and the older adolescent. But in the meantime, we can feel like the one pediatric model did not apply for all the age groups evenly as well. So we also want to see like what the model learned to get this kind of conclusion. So we shape summary plot to see what kind of predictors contribute more to the outcomes and what is the directions between the predictors and the outcomes. And we see there are some kind of strongest predictors across all the groups, including historical detectable viral test rate, previous viral result, average treatment interruption days, and the late viral testing rate. But we also see some kind of unique predictors in some kind of groups. For example, for the older adolescent, the proportion of facility dispensations matter a lot, and also the facility type and the commune level risk. And for infants, interestingly, the sex matters a lot. And also the early or on-time pickup rates matters, same as for the clinic visit gap ratio. And for some of the variables, it also provides some kind of policy insights to policymakers. For example, the facility type, if it shows if the patients get the treatment in what kind of facility type will reduce the likelihood to being virological failure in the future. So the government can consider put more money on this kind of facility refinement in the future. So let's come to the findings, limitations, and conclusions. Through this study, we can find out the crisis-sensitive EMR indicators can support early triage. And we also can see different kind of intervention strategies are more effectively for different kind of age groups. And the continuous risk scores may help allocate scarce outreach resources as well. But we do need to understand there are some limitations in our study. First of all, the precision and the false positive score is modest because we prioritize the record score in the meantime. And also, we have some small subgroup samples, especially for the infants, which is under 500 numbers. And we also understand we did not capture some kind of social contextual factors in the EMR. So that's one of the future plans as well, to capture more predictors to improve the model performance. Even so, we can conclude that the crisis-adjusted machine learning models can strengthen the pediatric HIV surveillance, especially in the unstable settings. We also have future implications. I divided them into 6 dimensions. First of all, we can embed the machine learning risk score into the routine HIV program workflows for earlier identification for high-risk patients. We also can tailor the interventions by age group rather than applying the same retention approach to all the children and adolescents. And thirdly, we can use the risk stratification to prioritize the scarce resources during period of instability and service disruption. And fourthly, we can also translate model output into practical tools for clinics, such as a high-risk list, dashboard, or follow-up flags. We can also link the high-risk patients to timely outreach, adherence support, and closer monitoring. And lastly, we also can strengthen the clinic community coordination to maintain the continuity of care in insecurity settings. And next, I also want to thank for all these kind of like partners, including CDC, Georgetown CGHPI, Solution SA, and the two national programs in Haiti, which is PNLS and MSP. Thank you.
Thank you, Dr. Wood. Any question? In the meantime, I have a curiosity. I'm not an expert by any way in artificial intelligence. For the medical records in Haiti, they have different medical records, electronic medical records. How the model incorporate the different?
So there will be like 3 national EMR systems in Haiti. So like, I did not know how exactly it works out, but like we have, so you see the solution as a company, so the company take charge of the data set. So every time like we ask for a copy from the data set and ask for the data dictionary for all the variables. But like, as I know, like the Haiti just doing a huge like data innovation after 2016. So they remove all the data set from the handwritten one to the digital system. And they right now have 3 kind of like different kind of data systems right now. And we use mainly I forgot the name, but like we only use one of them for this kind of analysis.
Okay, thanks. I want to say something else. As I'm very close to the Haitian community in Florida, I know how challenging it is going there and doing studies, and I really want to congratulate you to take the time to do this. Thank you.
Thank you. Oh, no, there's one more question, I think. Yeah.
I thought it was. Okay, so I'm wondering, your study was about predicting biological failure, and it looked at different models and saw that it can be done by these models. But what did you find about the predictors? What were the predictors? And also the social contextual factors, I think, will be very important to factor in, especially, of course, in a place like Haiti, especially under situations of poverty and militarized kind of gangs, etc. All of those things, I'm sure would play into the sort of results that you might get. So I'm just wondering as well how you're going to factor those in later on, the confounders.
Yeah. So like I can divide the predictors into 2 types. One is the patient level, this kind of based on their previous EMR historical records, right? We cannot change like how many times they visited the clinic in the previous time period, right? This is like for patient specific, but like I think what the government can do, for example, one variable is called like facility type. So there will be 3 facility types. One is the health center with bed, and one is the health center without bed, and another is the clinic. So the results shows like if the patients get services in health center with bed, they are less likely to be in biological failure in the future. So that like for Haiti government, it may be a positive implications so that like you may consider like shift from the health center without bed to build more like health center with bed, something like that as well. And also I do agree like we do need a lot of like this kind of socio-economic variables. Also, like I think one thing is important, which they're not included in the study yet, is their parents. Because I think for a lot of like pediatric and adolescent, they got actually mainly from this kind of their parents, right? So if we do have this kind of linking ID to check about their parents, that would be beneficial as well. And we can, in the meantime, we can add more predictors to check these kind of whole parents. Yeah. Hope it's clear. Thank you.
Thank you very much. Okay, so we acknowledge again the presence of Dr. Jen Kudetsky, as an information, I have to say Dr. Kuretzky is the Director of Research and Education of Midway Specialty Care Center in the United States. And her presentation is the oral 51, and it's a countdown to control viral suppression in older adults with HIV from the Midway cohort. Thank you, Dr. Kuretzky.
Thank you. And I would like to give a special acknowledgement to the many names you see on this abstract. So Dr. Ramgopal often has many medical students working with him. And so the first 5 names on this abstract are medical students that he has had over the years. And although they could not be here with us today, they did play a really big role into putting this data set together. So a big thank you to all of them for their contributions. So I think we heard it earlier today, we heard it mentioned yesterday as well, that we know the population as a whole across the world is aging. And so that also means that our population of people with HIV are also thankfully aging beautifully just like the rest of us. The downside is that we're also seeing an alarming number of people over 50 who are becoming diagnosed with HIV at older ages, whether it's through delayed treatment initiation or just the fact that they themselves have reasons later on in life that they're exposed to HIV. And so we put this whole data set together to look at the outcomes of people who are over 50 versus under 50 to see if someone was diagnosed and started treatment after the age of 50, did they respond just the same as others who were under 50? And so that's what we're going to talk about here today. And it matters in all places across the world. It's not just in the United States. It's, of course, in the Caribbean following just right behind sub-Saharan Africa with the highest HIV prevalence. So, of course, still a lot of work to do. And despite advances in this, we know countries like Haiti, Jamaica, the Dominican Republic, and Cuba all account for a significant number of new cases. And we all can work together to improve viral suppression across the world, which would ultimately give us that undetectable equals untransmittable concept of prevention and be able to help eradicate HIV alongside PrEP. So I mentioned the point of this abstract was to look at the clinical outcomes of people who were over 50 and how well did they do in terms of viral suppression compared to those that were under 50. So we'll describe that real-world time to viral suppression and then also compare those 2 age groups. The data set that we did look at were treatment naive persons with HIV who started antiretroviral therapy for the first time between January 2021 to December 2024. We'll talk about these demographics on this screen. So we had 255 people that were included in this cohort. We ended up narrowing it down to 211 because when we looked at the comparison between the 2 age groups, we had 48 people who were ages 50 years and older, and then 164 ages 45 years and younger. And we intentionally left out that middle group of 46 to 49 because how can you tell the difference between a 49 to 50-year-old or a 46 to 45-year-old? So we wanted to make it very clear that there were 2 distinct groups, and so that's why you see the numbers were a little bit lower in our final inclusion criteria. So here's some descriptors of our population. So the mean age was 40. About 1 out of 5 were ages 50 years and above, right at 21%. 79% identified their gender as cis male. And we did have half of the cohort identified their race as Black, a quarter as Hispanic Latina. In terms of time to starting initiation or initiating treatment, the question came up earlier about rapid initiation. So in this cohort, we had about 70 or almost 70% of people had started treatment within 1 month of diagnosis, and about 30% had started treatment within a week. So we do prioritize that, and that's thanks to the fact that at Midway, we do offer access to care regardless of ability to pay. And so even if somebody didn't have insurance, didn't have a means to pay for their medications, we still got them in and were able to get them on treatment right away. In terms of the antiretroviral therapy that we used, almost 90% were started on an integrase-based regimen, such as a dolutegravir or a bictegravir-based regimen. So what did we see in terms of time to viral suppression? And this is real world, so keep in mind that this also takes into account when people miss their appointments, when labs are actually done, but still nonetheless impressive in the world of integrase inhibitors for the treatment of HIV. So there was a median of 57 days from the time that somebody started medication to the time they were virally suppressed. In our population, ages 50 years and older, the median was 60 days, 65 years and older, 63 days. And then of note and of concern to many providers is what happens with those high viral loads, what would we see in terms of days to viral suppression, and impressively, even with baseline viral loads above 500,000, 77 days until viral suppression, which is really great. If you think of the efavirenz-based era of HIV treatment, sometimes that would take upwards of 6 months, 180 days, and you can see how very quickly these numbers have dramatically declined. So that was the descriptive part about time to viral suppression. Now, what did that look like for our age group analysis? So thanks to our statistician, she was able to help us to run this statistical analysis. And as you can see on the screen, there was no difference, no statistically significant difference between time to viral suppression between the two groups, between over 50 and less than 45 years. There was a mean suppression time of 83.9 days in our younger population and then 89.5 in our population ages 50 years and older. So in conclusion, thankfully, time to viral suppression did not vary based on age, which is something that's always nice to see in the real world, as again, we know people are aging gracefully with and without HIV. Rapid suppression in older adults does really highlight the need to very quickly offer, through innovative models, HIV treatment. And then again, diversifying care like we have done across Midway and plan to continue to do in the US and internationally, to be able to offer it through private practices to improve access, to give patients options for other places to seek care that are best fit for them. And that was it.
Thank you very much. Any questions for Dr. Koretsky? I don't see any. All right, that's it. Thank you very much.
Thank you.
The next presentation is by Tariq Jagnarine. The title is Feasibility and Impact of Rapid Diagnostic Screening for Opportunistic Infections among Adults with Advanced HIV Disease in Guyana.
Thank you, chairpersons. Good afternoon, everyone. All protocols observed. First, allow me to say how happy I am to see so many HIV papers at the CARPHA conference. So today, on behalf of several of my colleagues, I'm presenting this paper, which is the feasibility and impact of rapid diagnostic screening for opportunistic infections among adults with advanced HIV disease in Guyana. It's a prospective, multi-centered cohort study. Before I proceed, as disclaimer, I would like to let you know that the interpretations presented here are my own, and it does not reflect the official position of the Ministry of Health, PAHU, or any of my collaborators. There's no financial conflict of interest, and ethical approval for this research was obtained from PAHU as well as the Ministry of Health. This will be an outline of how my presentation goes. So, as we heard from our featured speaker, despite widespread advancement and availability of antiretroviral therapy, advanced HIV diseases remain a major driver of early mortality globally. Opportunistic infections such as tuberculosis, cryptococcosis, and histoplasmosis are frequently underdiagnosed and continue to contribute significantly to mortality among severely immunocompromised individuals. A substantial portions of HIV-related deaths still occur in the context of advanced HIV disease, as you can see from the UNAIDS 2024 data. Among the deaths for HIV, 30% was because of opportunistic infections. This highlights the need for systematic screening and early intervention beyond symptom-based approaches, as is used in Guyana, the Caribbean, and many Latin American countries. So this research, our principal question was, what is the impact of rapid diagnostic screening for opportunistic infections on early detection and short-term outcomes among patients with advanced HIV disease? And to address this, we had three main objectives. First is to quantify what is the prevalence really of opportunistic infections using rapid diagnostic, including asymptomatic cases. Second, to evaluate the association between diagnostic positivity and short-term outcomes, specifically within 30 and 90 days mortality. And third, to identify the predictors of adverse outcomes, with particular focus on delaying antiretroviral therapy initiation. Our methodology. This study was a prospective, multi-centered cohort study conducted between February 2024 to March 2025 across 7 HIV treatment facilities in Guyana from different regions, including coastland and hinterland. The study population included young adults ages 18 and above who presents with an advanced HIV, which was defined as having a CD4 count below 200 or clinical stage in WHO of stage 3 and 4. A standardized screening protocol was implemented at point of care, where 4 rapid diagnostic tests was done on all of our patients. 1, a CD4 count test, a TB LAM, cryptococcal antigen test, histoplasma antigen test. This multi-pathogen screening strategy enables early detection of opportunistic infections with further confirmation if needed. It reduces loss to follow-up, and it also helps us to actually determine critical patients in time of need. Participants were followed prospectively for 30 and 90 days, and outcomes included mortality, loss to follow-up, and a composite endpoint. Comparative analysis was conducted between those who were positive and those who were negative with the rapid diagnostic tests, and we did some multivariable logistic regression to identify independent factors of adverse outcomes. We felt that this design flow helps to look at both prevalence estimation and assessment of predictors as well of mortality within the real-world clinical setting. So our results. Out of 124 patients who enrolled, 24 was positive. A different way to look at this is 1 in 5 patients had advanced HIV disease with opportunistic infection, TB being the principal cause, followed by cryptococcus and histoplasmosis. Importantly, approximately 1/3 of these patients, they were asymptomatic. This demonstrates that symptom-based screening, as we've been habitually doing in many Caribbean countries, likewise here in Guyana, this alone would fail in identifying substantial portions of those patients who are at high risk. So it supports the need for routine diagnostic screening at presentation. So when you look at the cohort characteristic, the baseline characteristic did not differ significantly when you try to compare those on ART, who never been on ART versus those who were re-engaged. So this suggests also that risk opportunities or opportunistic infection, it was not limited to newly diagnosed individuals. It supports a unified screening approach across all patients with advanced HIV diseases. So this is one of the slides I want to spend some time on, is when you look at those of you who are in HIV, the care cascade gap. Although diagnostic coverage was very high, all of our patients had testing done, there was a progressive attrition across all of the cascade. Those who received treatment, those who receive exposure prophylaxis, initiation on ART, but worst of all, when you look at TB prevention therapy, as is done in our part of the world, it was very low. This highlights a disconnection between diagnosis and treatment implementation, indicating that improving outcomes requires strengthening the entire care pathway, not just diagnosing patient, but ensuring they are linked to treatment, stay on treatment, and the entire pathway is respected. Mortality outcomes, rapid diagnostic positivity was strongly associated with early mortality. At 30 days, mortality was in 20.8% among those who had who were diagnosed positive, and compared to 6.8% in those who were negative. At 90 days, that mortality increased to 37.5%. 11 of those 24 patients passed away, or were lost to follow-up, or had a complex endpoint. This indicates that diagnostic positivity is a strong prognostic marker of mortality risk and underscores the need for immediate clinical intervention. So when you look at the Kaplan-Meier survival curve, it shows a significant steep decline among patients who tested positive versus those who tested negative, definitely indicating that the Guyana's program has some work to do. Predictors. Among predictors of adverse outcome, it's the delay antiretroviral therapy initiation. It emerged as the strongest independent factor. Patients' initiation on ART had a significant higher odds of mortality, both at 30 and 90 days, even after you adjust for diagnostic status. And this indicates that while diagnosis can identify high-risk patients, it is the timing of treatment that is essential that adds to survival. And that was a question I remember you addressed it. It highlights also a critical gap between diagnosis and clinical response. So the summary of our findings: 1 in 5 patients had an opportunistic infection. TB was the leading opportunistic infection. 1/3 of those patients were asymptomatic. Rapid diagnostic positivity strongly predicted early mortality, and care cascade gaps persist, particularly in treatment initiation. Critically, delay in antiretroviral therapy, not diagnosis, was the strongest driver of adverse outcome. Several limitations should be acknowledged. First, that this study was conducted across a limited number of facilities, which may affect generalizability. There is a potential for residual confounders for unmeasured clinical factors such as the adherence and ART therapy, as well as comorbidities. Additionally, variations in diagnostic availability and follow-up completeness across sites may influence outcomes, and short follow-up periods may underestimate long-term mortality. So a few discussion points put in this methodology and all of our findings together is that when you compare what we found in Guyana with the global evidence, it demonstrates that opportunistic infections remain a major driver of mortality in advanced HIV disease. So what next? Ideally, we'd want to ensure that we expand not just diagnostic tests alone, but health system that ensures rapid linkage to care. And so I want to, in conclusion, tell you what's going to happen next with our study is that we've now looked at a meta-analysis of other countries in the Caribbean doing the same tests and then compare those results. These are my references. I want to thank you. I welcome any questions.
Thank you, Tariq. There is a question. Yep.
Dr. Morris Edwards. Thank you for informative presentation. However, I wish to point out that the title of your presentation and what you actually presented, when you said opportunistic infections, that should have been selective opportunistic infection, because you only looked at 3 opportunistic infections, and the patients could have, we talk about the prevalence of opportunistic infection. Looking at only 3, you cannot get the prevalence of opportunistic infection because you only look at 3. There are a gamut of so many other opportunistic infections. For example, toxoplasmosis is pretty prevalent in Guyana. That wasn't even looked at, right? So just a point out there that this is not a prevalent study, and we shouldn't be using that. Just to say that selective, and of the three selective, this is what we actually found. Yes?
Thank you, Dr. Edwards, for that question. A very good point. What I must point out to you is that, as our featured speaker pointed out, in the Caribbean, difficulty having rapid diagnosis tests alone is a challenge. And so we wanted to have rapid diagnostic tests for almost everything that you can think about. But given the costing and challenges of this, we could have only gotten 3 of those. What we did look at, though, is from a clinical perspective, trying to predict what other opportunistic infections did exist with patients. That was something I didn't share here. It's a separate quantitative study, mixed study, sorry, that we had. What we wanted to just bring out here is the ones where we were able to get the rapid tests and how prevalent those was. That was the main idea of this study. But I do get your point. If you want to give an overall prevalence of the other cases, and like I said, the next step of our study is bringing this composite meta-analysis that would have the rapid diagnostic tests, those who were actually, or what we did with the clinical screening, and what happened in other countries.
Thanks. I think there is a question over there, and then Dr. Rangopal. So, go.
Dr. Joshua Rama, Georgetown Public Hospital. Thank you, Dr. Jainarain. Just remind me, I probably missed it. The patients were tested with your rapid diagnostic test. Were they treated, or they were all treated?
Yeah. You finished? Yes, very good question. Thank you for that. So we had a standardized CDC protocol that we followed. What it did, one, they were tested with a rapid diagnostic. Afterwards, they were then confirmed. Given that these are all advanced HIV disease and they're critical, they were all admitted at Georgetown Hospital and to ensure that they're placed in treatment. Yes.
What's your turnaround time for your rapid diagnostic test?
Turnaround time is within actually 20 minutes, some of these tests, yes. The longest one was histoplasmosis, which was 24 hours.
Is this available to us? Because I'm unaware of this. Usually critically ill HIV patients are admitted onto my service. We usually shotgun them, but wait weeks for these results. I'm curious as to
Very
this.
good question. One of the things I think I want to point out is I am the program manager of the National AIDS program. And so this was done for a feasibility test to see if it works well. And so we found that it does work well. And now for 2027 budget, we've incorporated into our guidelines to ensure that we can have this at all of the care and treatment sites. And we do have some of the rapid, I think we still have CD4 tests, and I think we might have some TB LAMA available.
All right, thank you.
Dr. Rangopal.
So we've seen a decline in late diagnosis as we have improved our testing capability and capacity. But I still see that patients are presenting with quite low CD4 counts in Guyana and probably Caribbean as well. The patients that we see in the Caribbean, we have a significant amount of Caribbean patients in our clinics. And the last 5 patients, I would say, who had opportunistic infections were toxo, TB, and were from Haiti or some other Caribbean country. So I think the question is, what is the next strategy to identify, to prevent late stage HIV, and what's the community awareness? I think it comes down significantly to community awareness and the strategies around it. Because by the time those patients are admitted in the hospital, the mortality is quite high, and you're losing the battle already.
Yeah, so absolutely, I really agree with that too, from Dr. Rangopal. What we're doing is we're ensuring now within our guidelines, we're going to update those guidelines to ensure that these rapid diagnostic tests are available, and you're not just going to screen persons who re-engage. Everyone who comes to clinic, especially if you're first time or as a first HIV patients, symptomatic or not, you are going to be screened for advanced diseases. And then, of course, we'll follow the treatment cascade, place you on treatment.
We screen every single patient.
Yeah,
every patient who
everyone.
comes into the hospital, we screen.
But remember, we don't have this yet, so yeah.
Question. Yes, thank you very much, Dr. Jainarain. I see you mentioned low tuberculosis prevention therapy initiated, and the majority coming out from the study were the OI that was highlighted most of TB. I was just wondering if you can clarify, because we don't want to start TB prevention therapy in those who already have TB. So what do you mean by the low TPT coverage in the study?
So one of the things for those who are negative, based in WHO guidelines, those who are, once you're negative, you still should be placed on TB prevention therapy. I know that guidelines is still questionable. It's going to be changed in some settings. But what we find is not just with this particular batch. Systematically, when you look at some cohort, there is that low start. And it has to do sometimes with that quality of care and uniformity of care between all care and treatment sites. You might have Region 4 sites. Most of the doctors are well informed, they're aware, they do it, while the hinterland community, some of them don't. It could be availability sometimes, not always, of the drug to start patients on. There are multiple factors.
Yeah, so therefore in this study, they had gene expert done chest x-ray, because before you start TPT, you have to do that. So probably maybe, I don't know, if the study included that, because we don't want to start TPT, not only on a negative rapid screening test, but the other tests that are done molecular.
But a confirmed negative, yes.
Yes. Thank you very much. So our last presenter today is for the presentation number 0053, Dr. Divya Shivdas. Forgive me for my pronunciation. Factors influencing adherence to antiretroviral therapy and engagement in HIV care at the National Care and Treatment Center in Guyana. A retrospective chart review. Floor is yours, Dr. Shivdas.
Yes, good afternoon, everyone. Thank you. Your pronunciation was pretty good. So yes, thank you for the introduction. Today, I'll be presenting the findings from a retrospective chart review that we had done, where we examined the factors influencing adherence to antiretroviral therapy and engagement in HIV care at the National Care and Treatment Center in Guyana. I worked on this with Dr. Ferguson, who is with the University of the West Indies, Jamaica. So for a little bit of background, HIV has transitioned from a fatal disease into a now manageable chronic condition, largely due to the advances in antiretroviral therapy. However, treatment success not only depends on access to care, it is reliant on consistent adherence and sustained engagement in care. We found that, well, it's documented that high adherence leads to viral suppression and good patient outcomes, while poor adherence leads to treatment failure and disease progression. Despite all of the advances, we have gaps, as we've heard already. In the Caribbean, only about 61% of persons living with HIV are virally suppressed currently, which is well below the levels required for epidemic control. While Guyana has made significant progress in the arena of HIV diagnostics and treatment, we still have ongoing challenges with retention in care and adherence. The National Care and Treatment Center is Guyana's largest HIV treatment clinic. It serves approximately 1/4 of the patients that we have nationally. So we identified this as a potential high-volume, programmatically relevant setting within which we can examine the adherence and engagement patterns of persons living with HIV within the national HIV response. So, given this context, we decided to conduct a study to better understand these challenges. Our specific objectives were to evaluate levels of engagement and treatment adherence among persons living with HIV at the National Care and Treatment Center, Guyana. We wanted to identify factors associated with adherence, and we wanted to examine the relationship between adherence and viral suppression. So to do this, we conducted a retrospective chart review of adult patients enrolled at the NCTC. The study included persons who were enrolled prior to mid-2018 and had at least one clinic visit during our study period in 2023. A random sample of 336 charts were selected from our clinic register,
And prior to any of this, we sought ethical approval from the Ministry of Health, IRB. Okay, as it relates to what we measured, we looked at the demographic information, the clinical information, as well as the psychosocial information that's routinely documented in these patient charts. We also had two outcome variables. We looked at viral suppression, which was defined as a viral load of less than 1,000 copies per ml. And for adherence, we had two different ways that we assessed this. We looked at self-reported adherence, which is based on the number of doses that a person would have reported to have missed within the previous 30 days. And we also looked at appointment adherence, which is based on the clinic timeliness of the appointment that they visited. Both of these measures were standardized, and we then categorized them as good adherence versus not good adherence, and assessed across multiple visits over a 6-year period. For the analysis, we used descriptive stats, we used logistic regression and Spearman correlation to examine the variables. All right, now we move on to the results. So overall, we found that self-reported adherence was relatively good. About 65% of persons had good cumulative adherence over the 6-year period, which varied between 85.5 and 91.5 annually. However, when we looked at the appointment adherence, a different pattern emerged. We saw that only 12.2% of persons were consistently on time over that period. Most persons were late, but it was short-term late, meaning about 7 to 30 days. Long delays were relatively rare. So what does this suggest? It suggests that there is a disconnect between the self-reported adherence and the appointment keeping for these persons. Okay. We then examined factors associated with good self-reported adherence. Viral suppression showed strong association with adherence. We found a person who had a viral load of less than 1,000, they had more than 20 times higher odds of good adherence. Home visits was also a good, sort of a good association with adherence, where home visits increased the odds of adherence by more than 4 times higher if they would have had this type of service. In contrast, we saw that delayed treatment was associated with poorer adherence, where each additional year between diagnosis and treatment actually reduced the odds of good adherence by about 11%. Together, these findings highlight the importance of early treatment initiation and targeted support interventions. I don't know if it's somebody else. Somebody.
Do we have any support from IT to help? Yes. Not working. No, it's not working. You can choose your one. It's working now.
Yes, so as I was saying, the 3 factors that we found to be associated with good self-reported adherence were viral suppression, which increased the odds of adherence, home visits, which also increased the odds of adherence, and delayed ART initiation reduced the odds of adherence. Now, with um, with appointment adherence, the findings were a little bit more limited. The only significant predictor of good appointment adherence that we found was the number of regimen changes, where each increased regimen change actually reduced the odds of adherence by about 58%. There were no significant association with age, sex, time to ART initiation, or any of the other variables that we checked. To note, viral load was not estimated, and we did not get an odds ratio for this because there were no unsuppressed patients who had good adherence. As per our final objective, we looked to examine the association of viral suppression and adherence. What we found is that self-reported adherence showed a weak but statistically significant association with viral load, indicating that better adherence was associated with lower viral loads. In contrast, appointment adherence showed no significant association. What this suggests is that medication taking behavior may be more directly linked to clinical outcomes than clinic attendance alone. Uh, do you? So for my strengths and limitations, yes. All right, the study had several strengths, which included the randomly selected sample that we got from the largest care and treatment site in Guyana and the 6-year observation period that we used. We used 2 different measures of adherence, which strengthened the associations that we were able to find. However, we do note that we've had some limitations. The fact that this was a retrospective design means that we could have made no causal inferences. Also, the use of paper-based records had the potential for having missing or incomplete information. And the generalizability was also very limited because we use a single urban site. Additionally, the use of self-reported adherence has been known to have, is known to have the potential for recall bias as well as social desirability bias. Nevertheless, we thought this was a very relevant study and the findings were relevant. While self-reported adherence was generally high, long-term appointment adherence was suboptimal. Early ART initiation, treatment stability, and psychosocial support are key drivers of good adherence, while regimen changes and delayed ART initiation are associated with poorer adherence. Self-reported adherence also was known to be linked to viral suppression, while appointment adherence was not. So what does this mean from a public health perspective? It means that strengthening patient-centered and differentiated care approaches will be essential to improving adherence, retention and care, and optimize patient outcomes. These are my references, and at this time, I would like to acknowledge my co-author, as well as the team at the National Care and Treatment Center and the National AIDS Program Secretariat. Thank you.
Thank you very much. Any questions for Dr. Shivdas, please? Yes, Carolyn, go ahead.
Thank you very much. Obviously, adherence is super important to getting the 95 target. I take your point, your conclusion that psychosocial support is very important, and I guess that you got that from the finding about home visits, maybe. But I'm just encouraging you to dig into that some deeper. Back in 2011, we published a study with people living with HIV in 3 Caribbean countries, looking at ART adherence when the regimens were even more much more complicated than they are now, and it was really found that counselling provided greater adherence, but also things like alcohol use reduced it. So and side effects reduced adherence. So I think a more holistic study that looks at the socio-ecological factors that might affect adherence and really interviewing patients and not just looking at records. I know that this was a record-based study, but maybe if it's possible to do some more social behavioral research that could give us new findings and new context. I think that would be helpful.
Thank you so much. But I'd just like to indicate that we did look at all of those different factors. We looked at additional social support interventions, things like counseling, support groups, as well as pill drop-offs and pharmacy pickups. For the logistic regression model, we didn't include it because when we did our cross-tabulation, we didn't find any significant. The p-value was not less than 0.2, so we didn't include it in that model. But I do know that because it was a retrospective study, some of the data may have been limited because what we found is in some of the charts, doctors don't always document when they're counseling a patient, they don't document when they're doing certain interventions that they consider to be, routine. So I think a prospective study may be better able to give, a better assessment, just like you would have stated. But yeah.
Thank you. We have an additional question.
Yeah, Dr. Edwards. Thank you very much. Very informative and interesting study because adherence, as Dr. Moti would have pointed out also, that treatment is available and virus suppression is where we want to go to, reducing the pool of infection and transmissibility of the viruses. This is a very important study. One, you said that regimen changes, right, impacted. Now, the question here is why were the regimen changes? Rather than just purely regimen change, because did they change regimen because of side effects? Did they have to change because of unavailability? Because I'm a part of the public-private partnership, so there are some things that I know, and therefore it'd be important for us to know what were the causes of these regimen changes that actually impacted. And then the second point here is that we talk about self-reported adherence and appointment adherence. What's the difference here? Because as far as I'm aware, Guyana doesn't have any other means, for example, electronic caps or anything like that to know whether people are actually opening. So for persons who keep in their appointments, they will then have to self-report in terms of their so I really don't understand the difference. So can you clarify for me what the difference is there?
Yes, thank you, Dr. Edwards. So I'll address the second question first. As it relates to self-reported adherence, this is this is an assessment that each clinician does at every visit. It asks the patient how many pills they would have missed within a 30-day period, and based on that number, they would record whether it's poor, good, or fair. That's the self-reported adherence aspect. With regards to the appointment adherence, this is based on how late the patient was for their scheduled appointment. So on each visit that you have, you give the patient a date when they're to return. If they return on time, you classify them as on time. If they're 10 days late, they fall within the 7 to 30-day period in terms of lateness, and so forth, as according to how we classified it. So that's the difference between those two measures. The first question that just relates to the regimen changes, everything that you said was correct. All of those could have been factors that led to regimen changes, in addition to things like toxicity or patient fatigue, pill fatigue with the patients. Because it was a retrospective chart review, we weren't able to discern a whole lot. So I think a prospective study on these issues would give a lot more data.
Thank you very much. Dr. Ramgala, please.
Yes, thank you. So this is the NAPS clinic with 25% of patients. That's about 2,500 patients, 2,000 or
About
3,000?
2,000.
Or 2,000. I think if you're going to do a prospective study, it would be good to look at the private clinic like Mercy Hospital, which have about 2,000 patients, to look comparatively to see what if it's very similar in the private setting versus the government setting. And the utility, and I would also consider adding looking at number of physicians per patient, patient load. That's also critical. I think that also affects patients coming to clinic, etc.
Absolutely. Thank you, Dr. Ramakabal, for that. I think we have some ideas for a lot of new studies that we can probably pursue in the upcoming months.
Thank you very much, Dr. Shivdas. I was wondering, yes, with the clarification, I had a similar question I want the
Mhm.
difference between the self-report and the appointment.
Yeah.
So because I see that there was a good self-reporting, but
Mhm.
basically poor appointment
Right.
reporting. And I was wondering if from this study, were
Mhm.
you able to suggest or recommend any modification to the self-reporting? Because it seems to be a disconnect. Because
So-
if the clinicians are
Mhm.
reporting good,
Mhm.
but the patient is coming late, therefore is the patient hoarding medication, what, yeah, and
So-
so forth. Thanks.
Thank you, Dr. Grant, for that. Just to clarify, though, it's the patient that's reporting how they take their medication. So several things could have contributed to this disconnect, so to speak. We have the tendency in Guyana or the practice of doing multi-month dispensing of medication. So clients tend to have a little bit more than would take them to their exact appointment date. This could be one of the reasons for that. Additionally, there are different places that persons can access treatment in the case that they cannot make it to their clinic. As you know, we have different types of a network where we're able to offer treatment at different sites if they're to show up at a different site in a different region. So this could have also accounted for that, especially if the physician do not make the documentation in the chart to indicate that this was the case. So yeah, it is something that we can look at more in depth, but these are some of the things that we propose to have been related to that.
All right, thank you very much. Okay, this has taken us to the end of the session today. It's been a pleasure to co-sharing with Dr. Bolivar. According to the program, we have a break, 15 minutes. We are 15 minutes behind, but yes, be attentive to the bell guide. Thank you very much.
Okay, so our first presenter today is Ms. Mohini Sukla, and she's going to be talking about smart trap and IoT-based entomological surveillance integrated with AI for real-time mosquito density mapping. She's a technical officer from the Ministry of Health, Guyana.
Good afternoon, colleagues. Thank you, Chair. I'll just ask kindly if you can just give me 2 seconds just to test this pointer. It should have been smart, yes, I agree.
Oh, the IT guys.
That's so shameful.
I'm the next presenter, so I need to pick it.
Okay, yeah. Sorry, good afternoon again. Today I'll present on smart traps, Internet of Things, artificial intelligence for real-time mosquito surveillance. And this is the outline for my presentation. So what do we know? We know that mosquito-borne disease remain a major global health challenge, with approximately 700,000 deaths occurring annually, with vector-borne diseases accounting for 17% of infectious disease globally. And so in 2024, WHO recorded 14.4 million cases of dengue, representing the highest burden recorded, with sustained increase over the past 2 decades. These trends are influenced by urbanization, climate variability, and expanding vector habitats. This highlights the need for more responsive and scalable surveillance approaches. Now, the rationale for this study includes a comparison of traditional methods and smart technology. So what do we know? We know that traditional methods are limited by delay. We know that there is delay in reporting, high operational cost, and restricted coverage. In contrast, we know that smart technology, on the other hand, they have real-time automated and scalable surveillance system. They cover a wide area via drones and sensors. They're also continuously monitoring. They improve species identification and rapid response to outbreak. Importantly, they also support WHO Global Vector Control Response 2017-2030. However, while there's all of these fancy categories and all these fancy things about smart technology, there are limited consolidation, and evidence on their performance is also limited, and this is why we're doing this review. So our study objectives is to map the evidence on smart surveillance technology, to assess species identification accuracy, to identify barriers to implementation, particularly in low resource setting, and to evaluate alignment with global vector control frameworks. Our methodology follows one of the ARCSI and O'Malley framework report using PRISMA guidelines. A structured search was conducted using multiple databases. Studies were screened using predefined criteria, followed by standardized data extraction. The findings were synthesized using descriptive statistics along with thematic analysis, and a narrative approach was adopted due to variability across technologies and study design. So this review included studies between the years 2015 to 2025, and these studies focused on Aedes, Anopheles, Culex species. And of course, there were peer-reviewed studies with measurable outcome. Now, in terms of quality appraisal, the CASP tool was used in this study. And a key limitation is heterogeneity, high heterogeneity, which prevented meta-analysis, but allow broad thematic comparison across technology. So what do we find? We found 354 records identified. However, upon screening, there were 320 duplicates which were removed. 68 full text were identified. 252 records were excluded, and based on our inclusion criteria, we had 68 studies being included in this study. So in terms of our results, there were 4 main technologies identified. There were the acoustic system, computer vision and deep learning, IoT-enabled platform, and multimodal and drone system. In terms of acoustic system, they demonstrated moderate accuracy of 65 to 80% accurate. There was high scalability and suitable for a low resource setting. Computer vision, on the other hand, proved to be 91 to 97% accurate, and this was achieved in controlled environment, in lab-based. IoT models, they foster real-time risk mapping and outbreak prediction, while multimodal and drone system focused on wide area habitat. So one might ask, where were these studies conducted? They were conducted in the United States, in Canada, in Germany, Thailand, in Kenya, along with Tanzania. So Tanzania, they used a software called Handbag system, and they used it on their mobile app in a limited setting, a limited lab setting, and they had their phones, and it was community-based. Importantly, the findings proved that no single technology met all of the operational criteria. And so what they advise is that integrated system combining AI, IoT, and field-based tools, they were the most viable approach for real-world deployment. Now, this graph actually shows a comparison of species identification and density estimation method. So it shows that deep learning models consistently demonstrate the highest performance, exceeding 90% accuracy in species identification. However, their effectiveness may decline in field condition due to environmental variability. This highlights the need for validation in operational setting. However, from a methodological standpoint, this supports the adoption of AI-driven surveillance system in vector control programs, particularly where precision and scalability are critical for decision-making as well as outbreak prediction. Now, our limitation. The following are limitations that we came across from the study. Most studies were conducted in controlled settings, and this lacked generalizability. Another limitation is that infrastructure barriers, which include power supply or power connectivity, data quality, challenges in low resource setting. Now, in terms of future priorities, include field validation, deployment of interoperable systems, and integration into national surveillance system. It is critical to note that ensuring equitable access to these technologies are critical. Oh, there you go. Sorry. So to conclude, AI and IoT technology demonstrates strong potential to transform mosquito surveillance. This system aligns with the global framework, vector control framework 2017 to 2030, as well as One Health approach. However, large-scale implementation remains limited. So the take-home message: smart system is no longer a future concept. We have it here, and it's ready now. And so AI models achieve up to 97% species identification accuracy, while IoT and drone systems enable real-time wide area surveillance. So what's next? Next, we need to do field validation because, as we noted, some of the studies were done in controlled environment, standardization, and equitable deployment. These are my references. Thank you for listening. I will now invite your questions.
The floor is open to questions. Question?
No questions?
Okay, so I have a question.
Oh, sure.
Thank you. So Guyana has very high diversity as far as the mosquito species, etc. You have over 180.
Sure.
So how would something like this work in a setting like Guyana?
So of course we need abundance.
Well, in addition to money, but what's something like this
So,
in Guyana?
so we can use drones to start with because we have quite a few companies established in Guyana that operates drone on a large scale. And so to start with, we can use drones as one of our startups.
Okay. Thank you so much.
That's welcome. But money is important.
I have a question about, which leads on from this question, which is that for AI to work, it needs validated data sets in order to make predictions. So I'm just wondering for an ecosystem that is so diverse and has many different species, do you think that there needs to be quite a long validation period where there's ground data to train the AI?
I mean, we have not focused on that specifically, but I would like to think that we would need, given that we're now testing these technologies worldwide, and so, yeah, validation would be something that we truly need to take some time to look at. Yeah.
Hi, thank you for that presentation. I'm struggling to see where the sensitivities and of the identification come in. Is this something that's put up to the cloud and the mosquitoes are identified virtually?
So I know low research setting like us, Tanzania did a similar program using the Humbug software, and yes, they kind of did use a mosquito, and they used the software to try to use it as like a key to identify them. Yeah, I'm not sure if that answered your question. Like a key that's within the software. So as you upload the picture, it identifies.
Right, and I guess we haven't deployed this at all in the Caribbean region yet.
No, we have not. Certainly have not.
Okay, thanks.
Got any other questions? No? Thank you.
Okay, I'm excited to introduce our next presenter, who is also our chairperson, Dr. Simone Sandiford, who you just met, senior lecturer at the University of the West Indies, Mona in Jamaica, and she's presenting on the molecular surveillance of the invasive Aedes vititis in Jamaica.
Oh, wonderful. Good afternoon again, everyone. Thank you so much for that introduction. So I'm presenting on behalf of my student, Mr. Samoy Noble, who unfortunately could not make it here today. So Aedes vitatus, which most of you probably have not heard of, is a highly invasive mosquito that continues to expand globally. So it originated in Corsica, which is an island in the Mediterranean. It spread throughout Africa, Asia, and it's now in the Americas. It is a very morphologically distinct mosquito, as you can see from this picture. There are 6 silvery spots on the scutum, as indicated by the arrow. But when the mosquito is a little less than morphologically pristine, it's going to be very hard to identify. One of the other key features you can look for are these subapical bands on all the femur of the mosquito. But again, if you don't know what you're looking for, things could become a little bit difficult. So within the Americas, as I previously mentioned, Aedes vitatus is now here. It was first reported in the Dominican Republic in 2019, also in Cuba in 2019. We identified it in Jamaica in 2023. We were not looking for it. We were doing arbovirus surveillance work and we encountered it. We actually misidentified it at first, and then got it using molecular studies. And in 2024, it was reported in Mexico. And in Mexico, it was reported actually in the Yucatan Peninsula. And if you look at this map that I have illustrating here, you would see that it's the Northern Caribbean that has thus far identified Aedes vitatus. We do not know if it's present in the rest of the Caribbean region. It could just be that we're not looking for it. So one of my goals here today is to, of course, create awareness about this particular mosquito species. So the reason why we are concerned about it is because it is a highly invasive and also a neglected vector, meaning, of course, we don't know very much about it. But what we do know is that, for instance, first and foremost, it is a very aggressive biter that has a preference for human blood. If other hosts are available, it would bite something else, but it prefers human blood. In addition to that, studies out of Africa, they've shown from field-caught mosquitoes, they've isolated arboviruses such as yellow fever virus and Zika virus from this particular mosquito species. Also, in lab-based studies in India, they've demonstrated that Aedes vitatus, similar to Aedes aegypti and Aedes albopictus, you can have transovarian transmission of dengue virus by Aedes vitatus. And last but not least, laboratory studies have shown that this mosquito is a very highly competent vector for both chikungunya virus and also West Nile virus. And you note that these are all arboviruses that are currently circulating within the Americas. So this is one of the reasons that we are concerned. If it is here, what is it doing? Is it playing any role in disease transmission? So we know it's here. As I said, we identified it in 2023. So what we wanted to get a better idea was what is happening with our Aedes vitatus populations in Jamaica. The key question we wanted to figure out was whether or not they were all the same, because this has implications as far as control and also the ability to vector certain arboviruses. And we also wanted to see whether or not they were related to the Aedes vitatus mosquitoes found in some of the other places in the region, and also by extension in other parts of the world. So this is my student, Mr. Samoy Noble, who of course is the one who spearheaded all this work. So to do this work, we did something called haplotype analysis. And very, very briefly, a haplotype is basically a block of DNA that is going to be inherited together. So in my very simple schematic, so please work with me, I have 5 different mosquitoes here. And we can see that mosquito 1, 4, and 5, they belong to one haplotype. Because in certain positions, you're seeing this CAG, which is highlighted in red. Whereas mosquitoes 2 and 3, they're another haplotype, because in that same position, they have TCA, which is highlighted in green. And haplotypes are important because the genetic material from the mosquito, that, as I said, can influence how the mosquito is able to transmit viruses, how the mosquito can respond to control methods, etc. So it's important to know on the molecular level what is going on with our mosquito species. So that's what we try to do to get a better understanding with our study. So to do this work, what Samoy did is he did field collection of mosquitoes. Right, from 2023 to 2024, we did field collections of mosquitoes, collecting both adults and larval samples. And so for the adults collected with BG sentinel traps that were baited with dry ice, because when dry ice give off CO2, attracts mosquitoes, and we get them. For the larval samples, we collected them using turkey basters and also pipettes, collecting from the breeding sites. DNA was then extracted, and then we used PCR to amplify the COI gene, which is the cytochrome oxidase subunit C gene, subunit 1 gene, and this is a gene that is commonly used for barcoding mosquitoes. So it enables us to not only tell different mosquito species, but within a particular mosquito species, how they differ. So then we went ahead and did Sanger sequencing. We would have loved to do whole genome sequencing, but because of the cost, we just did Sanger sequencing with this one particular gene. We then aligned all these sequences using Mega, and we aligned all our mosquitoes from Jamaica and also compared them to sequences that were in GenBank, which is a database of all these different sequences from all over the world. And then using this DNA SP software, we were able to identify different haplotypes. And then this was then illustrated using pop art so that we could do a median joining network. So again, we can see how related our mosquitoes are. So this is a map of Jamaica, and within Jamaica, we collected from 4 different parishes, and as you can see, we collected from different parts of the island. So UWI, the university, is located in Kingston and St. Andrew, which is in the southeast part of the country, and the university's campus is pretty big. Aedes vitatus is in multiple locations in the campus, and so we collected from different locations in and around UWI's campus. We also collected from Myersville in St. Elizabeth, which is a rural farming community. Petersfield in Westmoreland, another rural farming community, and these are on the southeast coast of the island, and also in Walkerswood, St. Anne, which is on the north coast of the island, another farming community. And this was all convenient sampling. When other outreaches were going on, we took the opportunity to collect samples. Okay, so what I'm showing you here is a pretty busy diagram, but in essence, it's a haplotype network of some of our Aedes vittatus mosquitoes. And in this illustration, I'm only showing you 11 specimens. And the take home here is that not all our Aedes vittatus mosquitoes are the same. These 11 specimens actually belong to 9 different haplotypes, suggesting, of course, that we have a fair amount of diversity what's going on with our mosquitoes. So if you note, samples from Kingston and St. Andrew, which is highlighted here in green, they actually belong to 3 different haplotypes. Samples from St. Elizabeth, they belong to 2 different haplotypes. Samples from Westmoreland, also 2 different haplotypes. And St. Anne, 1 haplotype. And in this diagram, every dash represents a mutation. So it shows how different the samples are. So the takeaway here is that you can see that haplotype 8 from St. Anne, that mosquito is really, really different from all our other mosquitoes. So the question is, why is that happening? What is going on? So in addition to looking at the mosquitoes and how they compare to the Jamaican specimens, we of course wanted to see how they compare to specimens from other parts of the world. So again, we did the same thing, and for this now we're using other specimens from information that is already in GenBank. And again, a very busy diagram, but the take home here is that some of our samples are identical to specimens from Cuba. Other sets of samples are identical to the specimens from DR, Dominican Republic. And this supported the paper from Cuba, which showed that the specimens from Cuba and the specimens from the Dominican Republic were not the same, suggesting, of course, multiple introductions of Aedes vittatus into the Caribbean. In Jamaica, we have both. In addition to that, now, we also found that some of our specimens were more, and I forgot to mention, the ones that were related to the ones from DR, those are also in the cluster that are related to the, pointer's not working, that are also related to specimens from Nepal, which is highlighted in light blue, India, which I think is a darker blue in this diagram. We also found that some specimens were somewhat related to specimens also from India, and then we also found that some of our vittatus specimens that we have analyzed are not really lining up with anything else at this point in time. So again, the question is, what is going on? So the take-home message right now, as far as our Aedes vittatus and our public health significance, is that clearly, in the Jamaican context, we've had multiple introductions of Aedes vittatus into the country. At this point in time, it is unclear whether or not we got these specimens from Cuba or they actually got it from us. We're still trying to figure that out. Also, from our limited work, I mean, we've gone ahead and done a lot more, but this is what I'm presenting today for ease and simplicity. We can see that our specimens also have high genetic diversity. So the fact that they differ so much suggests that maybe, possibly, these specimens, Aedes vittatus, might have been in Jamaica undetected for quite a while, adapting, evolving. We just didn't pick it up. And further work is we're looking into whether or not these differences might impact things like vector competence and, of course, insecticide susceptibility. Caveat here is, of course, too, that we've only, at this point in time, I'm presenting data looking at one gene, but of course the idea is to expand this to other genes which are going to be more relevant to things like insecticide resistance, etc. So the last thing I want to highlight also is the benefits of doing molecular surveillance. So the work that we're presenting here today, giving us a better idea of what's happening with the movement of mosquito within the region. And this is very important so that we know what we need to do things like strengthen our borders, etc. When we're islands, yes, but things can move. We have trade, we have people coming in and out. So these things can be very insightful for that. This can also be very insightful to track insecticide resistance within the country and also within the region. And all these things can, of course, help to improve our control strategies, which are, of course, necessary and very badly needed within the region. So with that, thank you very much. I would like to, of course, acknowledge my student, who is a GIDRTP Research Fellow. He's sponsored by the training program, which is based at the University of Buffalo. And also, of course, our collaborators at the Johns Hopkins School of Public Health, Dr. Renee Ali and Dr. Douglas Norris. And with that, I'll be happy to take questions. Thank you so much.
We'll take questions, please.
Could you please let us know if the Aedes vittatus has the similar breeding sites and biting times as Aedes aegypti, or because if we're going to be looking at this in other countries, it'd be really nice to know what their predilection sites are. For
Excellent question. So we find that it tends to overlap a lot with Aedes albopictus. It seems to be following a lot the pattern of Aedes albopictus. We find Aedes vittatus preferentially in more forested areas, maybe more peri-urban areas also. And we tend to, as I said, find it breeding together with albopictus. We would also find Egypti also sometimes, but mostly with albopictus. Biting times, daytime. But, and if you look at the literature suggests specifically daytime, but we have seen, and while doing trapping, we have had situations where it's biting you aggressively also in the night. And this is up to like 10 o'clock in the night, it was biting my student, but mostly daytime biter.
Good question here.
Thank you for that really great presentation on the students. You can clearly see a lot of work done there. I do look forward to when you expand the genomic work from one gene. But I don't know the answer, so that's why I'm asking the question. Is it that when you pick up these clades or haplotype blocks in is it definitely related to migration patterns, or is it simply that you have, because of recombination, that's what you're gonna get if the mosquito is present in the country for a long time? So it's not necessarily that it's come from India, but that it was there for a long time, and that's the clades that you're going to pick up over time as recombination happens.
Yeah, that's a very good question. And I don't even know if I know how to answer it fully, to be fair, but that's a very good question. And it's something that we're definitely going to have to look into a little bit more, because as I said, to be fair, the analysis that I'm showing you today is only one gene. And I also forgot to point out, caveat, we had to shrink the sequence that we could use so that we can do alignments with what was in GenBank, because some of these sequences are very short. We have gone ahead, as I said, we did mitogenome analysis, and so we have a little bit more information as far as how it lines up. And again, we still see these different haplotypes and see alignments with some from the Indian subcontinent, and also now actually we've done mitogenome analysis, and we have one mitogenome from Jamaica that's aligning with a mitogenome from Zambia. So again, more work is coming.
Another question I don't know the answer for, but would you normally do some sort of linkage disequilibrium type analysis to see how far or?
So we can. We haven't done it yet, but we can. This is definitely a place that we want to go, because we're trying to get a better understanding of we're trying to get into more of population genomics so that we can have a better understanding, not only for Aedes vittatus, to be fair, but also including Aedes aegypti and also Aedes albopictus. So that's one of the areas that we're going into. So we're kind of now starting this work, and that is definitely where we want to go, because we realize that's where the world is.
There's a question in the back.
D'abord from the University Hospital of Martinique. Very nice presentation. And it's not a question, but if you said, we know a little bit about albopictus, which is the tiger. Even we get the tiger and even the capital in Paris. So if you believe that, I'm waiting for your publication, I know that's coming, but if you believe that this is a type of albopictus, and not you, your student, why did your student choose to get some sample from the university hospital? Why didn't, I believe, this is my point of view, areas like Portland, areas like Montego Bay, areas like the airport, whatever, in Kingston, that should be great to look at. Thank you.
Yeah. Yes. So again, excellent point. As I highlighted before, this was convenient sampling. So we happened to encounter this invasive mosquito by accident. We were doing something else, and this came up in our collections. We did not realize we had it because we had a mosquito that morphologically was very, for lack of a better word, beat up. And so when we sent it for molecular identification, it came back as this. And then when we went back and looked back at some of our collections, we realized that we had it. So excellent point. Because of logistical challenges, etc., we haven't sampled as much as we would like to. this is something I would definitely love to work with the ministry with because they have the logistical power. So that is something that we would love to do. But thank you for that.
I think there's one more question. We'll take this as our last question and then move to the next. Thank you.
Have you done any testing for these to see if they're carrying any arboviruses yet?
So that was the project. So the project is our virus surveillance. So yes, so we have literally just finished sorting all our pools of mosquitoes and we'll be sending them for analysis. So this is one of the many different species that we will be sending. So more to come on that also. Thank you so much.
Thank you.
Thank you.
All right, we will move to our next